mode. And also, you can find a mask, just like mine, all right, in the back. Would you please change it to the mask for the forum this year? Because later we're going to have a group photo. So would you mind changing to the mask for this year's forum? You can find the mask in the back. Thank you so much. 各位贵宾，我们的大会呢，大概再过6分钟之后哦，会正式开始。那我们等一下会有合照的桥段哦，让拍起来呢比较好看。各位贵宾呢，都可以帮我们换上这一次的论坛的主题口罩，大家的资料袋里面呢都有我们这一次的口罩哦。那在我们开始之前呢，我们先为各位介绍有来到现场的我们台湾的一些贵宾。And before we begin, let me introduce some of our VIP guests from Taiwan. 我们在现场呢，要欢迎外交部条约法律司连建成司长，欢迎中华民国医师公会全国联合会周庆明理事长，欢迎，也要欢迎亚洲健康势能学会张武修理事长，财团法人台湾医界联盟基金会林世嘉执行长，台湾之友会张富美理事长，欢迎。台湾长期照护专业学会吴孝琪理事长，弘光科大黄月贵校长，非常欢迎。台湾心理卫生社会工作学会巫淑君理事长，欢迎。弘道老人福利基金会李若启执行长，台湾社会福利总盟卓春英理事长，国立台湾大学林文珍教授，大林慈济医院林明南副院长，非常欢迎。全国劳工联合总工会林恩豪理事长，财团法人中华经典社区促进联盟洪礼从理事长，中华民国护理师护士工会全国联合会季淑静理事长，非常欢迎。接下来呢，来到现场的，我们也要欢迎中华民国牙髓病学会涂明君理事长，欢迎。医院许师典院长，以及中华民国临床心理师工会全国联合会郭乃文理事长，欢迎。台北医学大学公卫学院陈怡化院长，台湾特殊需求者口腔医学会陈信明理事长，欢迎。同综合医院口腔医学部陈雅仪营运长，台湾老人福利机构协会陈瑞祥理事长，台湾社会福利总盟陈洁如副理事长，欢迎。新北市卫生局陈润秋局长，台安医院黄辉庭院长，云林县卫生局曾春美局长，台湾中医护理学会曾素美理事长，台湾居家护理暨服务协会曾晴元理事长，咨商心理师全国联合会黄雅玲理事长，中山医学大学附设医院文心院区黄玉峰院长，欢迎。卫生福利部花莲医院杨南平院长，全国建筑师工会刘国龙理事长，台湾病理学会赖琼如理事长，非常欢迎，以及台湾制药工业同业工会苏东茂理事长，非常欢迎各位来自于我们国内的台湾贵宾哦，莅临我们这一次的盛会，再次感谢。 Ladies and gentlemen, we'll begin in 1 minute. Would you please take your seats and make sure that you change your mask to this mask for this year's forum, okay? Because later we're going to have a group photo together, okay? You can find the mask in your bag. Thank you so much. 各位贵宾，我们即将要正式开始喽。那请各位贵宾呢，都可以帮我们换上这个资料袋里面的这一次的大会主题的口罩，谢谢。Distinguished guests here with us in the room and our friends who join us online. Welcome to the 2022 Global Health and Welfare Forum in Taiwan. 我们先给这个论坛一个掌声好吗？欢迎各位现场以及线上的贵宾一同参加2022台湾全球健康福祉论坛。Ladies and gentlemen, it's been 2 years that we haven't seen such a huge gathering of the health community happening here in Taiwan. And we are very happy, very thrilled to be joined by so many VIPs, so many friends, so many partners from all over the world. And together we are advancing health and well-being for all. One Health. 再次谢谢我们今天呢，来自于全世界各地现场以及线上的贵宾一同参与我们的论坛哦。我们要一起全面促进健康与福祉。健康一体 okay? And now to begin, we have a very special performance for you, all right? What you're about to see on the stage are called 官将手 troops, okay? They are literally God's bodyguards in traditional Taoist belief, and their job is to catch the bad guys, okay? The demon, and you know, in traditional Chinese culture, we used to believe that it is the demon that brings plagues, that brings diseases to the human world. So by catching the bad guy, the demon, the 官将手 also cast away the plague, COVID-19. That's what we want, right? Okay? All right. Yes. Okay. So, ladies and gentlemen, now please join me in welcoming Song Kun Performing Arts Group for giving us the 官将手 troops. 接下来让我们掌声欢迎宋坤传译为大家带来的官将手的演出。我们掌声欢迎 Put your hands together. The legend has it, a boy on a crane flying in the sky is leading the way for 官将手, the green-faced generals, the red-faced generals, and tiger general. 首先，我们看到的是白鹤童子引路，在高空巡弋，为虎爷、为青面将军、为红面将军开路。Before going out on the mission, the 官将手 have to make a list of who the bad guys, who the demons are they are going to catch for the mission. And to do that, they would firstly pray to the God to make sure that everything goes well. 官将手会以五礼敬天、整装整容、敬拜主神，接令洞察停留在阳间的魑魅魍魉，缉拿违规，阴间执行律法审判。You want to make sure that you have everything ready before you go out. You have your soldiers, you have your horses, you have your weapons, so that you can see on the stage. They have the spear, they have the knife, they have handcuffs, and as you can see, there is a gourd they are holding in their hand. That's very important. It's a gourd that 官将手 uses to squeeze the bad guys, to squeeze the demons into it. 点兵，主将清点各部军马兵器，壮盛军容，势如破竹，威震八方。And now it's time to hunt down the bad guys. They are performing different skills, different tactics to the best of their ability to catch the demons, to bring peace back to the human world. That is the umbrella used to make the demons surrender. 镇煞除恶，缉拿鬼魅，降妖除魔。And lastly, after catching the bad guys, we'd like to pray to the God. So now we'd like to invite everybody to pray for yourselves, to pray for the world. 那最后呢，敬神，我们是有请部长以及陈建仁院士带领我们全场的贵宾一起双手合十，我们一起敬天，为世界祈福。Now please put your hands together and let's pray for God. Let's pray for health for all, one health, world peace, and safety. 我们再次掌声谢谢关教授。Once again, a big round of applause for our opening performance. 关教授 from 宋坤传艺. Thank you so much. Thank you again. All right, now you're all here, so we'd like to firstly take a group photo of all of you. We would like to have our photographer on the stage. 接下来我们想首先有请我们的摄影师到舞台上哦，帮今天全场的贵宾，我们先拍一张大合照。And yeah, to have a group photo, would you please put this mask on? Yes, okay. The mask for this year's forum. All right. And once again, we are very happy to be joined by so many friends. OK. 那接下来呢，我们请各位贵宾呢都帮我们换上这一次台湾全球健康福祉论坛的口罩。那同时呢，我们也为前排的贵宾有准备了道具板哦。我们试试一起看向舞台上方的镜头。OK, take number 1. Let's have a look at the camera on the stage. 3, 2, 1. Take number 2. I would like to have everybody take your mask off. Yeah, we want to see your smile, all right? Okay, that's very important for us. 接下来呢，第2张是把这个口罩拿掉，露出最大的微笑。And the last one, thumbs up. 那大家也知道，我们最后一张呢，一定都要比一个赞，好吗 ？Thumbs up. 好，我们试试再次请各位贵宾给自己一个最大的掌声 ，Give yourselves a big round of applause. Thank you so much. Woo! 再次谢谢我们现场所有来自于国内外的贵宾哦，参与2022台湾全球健康福祉论坛。Thank you once again for joining us today for the 2022 Global Health and Welfare Forum in Taiwan. And now, to welcome you all, to give you the opening remark, ladies and gentlemen, please join me in welcoming Dr. Ruiyuan Xue, Ministry of Health and Welfare, Taiwan, to the stage. 接下来，我们首先有请主办单位卫生福利部薛瑞元部长上台开场致辞。我们掌声欢迎部长。部长有请。
Dr. 陈建仁，former Vice President in Taiwan. Dr. 蔡明燕，Minister, Deputy Minister of Foreign Affairs. Honorable Health Ministers and Excellency and Ambassadors. Distinguished guests from home and abroad. On-site and online, and friends from the media. Good morning.
Morning.
Welcome to the 2022 Global Health and Welfare Forum in Taiwan. Today is the first time after the WHO declared that COVID-19 pandemic in 2020. That we have guests come to Taiwan from abroad to attend the forum. On behalf of the Ministry of Health and Welfare, the Republic of China, that is Taiwan, I would like to express my sincere gratitude for all your support and for all the guests who had traveled from afar to attend this forum, despite the inconvenience caused by the global pandemic. This year marks the 17th anniversary of the forum, which had attracted health leaders and experts from all over the world and become one of the most important global health events. As the world recovers from the threat of the pandemic, the present issue is how to build back better and move toward achieving the sustainable development goals again. The theme of the forum, One Health, advancing health and well-being for all, calls for calls for greater attention to not only the eco-environment we live in, but also the roles of plants and animals in supporting human health and sustainable development. The theme also signified the fact that all members in the society, regardless gender, ethnicity, income, and disability, should have equal access to health literacy resources and equality health care services. This year, we are honored to invite a number of globally renowned leaders and experts from fields of health and well-being and welfare to provide opinions and suggestions on environmental sustainability, global cooperation, and disease prevention, and to explore how to ensure health and well-being throughout global solidarity. As the pandemic continues to pose risk to the world, Taiwan has shown that the democratic spirits of freedom and openness, respect for diversity, protection of human rights, and care for the disadvantaged is the key to promote national consciousness and social unity and combat the pandemic. Moreover, Taiwan's national health insurance program has expanded its telemedicine service and provide people in remote areas with affordable and accessible care by establishing a total of 105 air medical transport and telemedicine stations nationwide. Under the new Taiwan model, the Taiwan government has continued to boost the COVID-19 vaccination coverage to protect the elderly and the children. Taiwan's vaccination rate of children aged 5 to 11 years was ranked second in the world, only after to Singapore. In numbers, annual survey, Taiwan was ranked first in the world in healthcare index category for 2022 mid-years. Furthermore, the government also had taken the national economic development into account during the pandemic. Taiwan's economic growth rate for 2021 reached 6.57%, which is much higher than the global growth rate of 5.8% in the time of the pandemic. The government seeks to allow people to lead normal lives while active epidemic prevention measures remain in place, and the country is steadily open up. A friend in need is a friend indeed. The world today continues to face challenges for the pandemic, and the countries should deeply realize the necessity, urgency, and the legitimacy and the solidarities and the cooperation for sustainable growth recovery. Here, I would also like to take this opportunity to express my most sincere gratitude for the support of our international friends during the 75th World Health Assembly this year. Human rights are universal values. Though not a member of the United Nations, Taiwan has valued human rights and organized the International Review Conference on the CRPD and the CRC. On the right, that's the Convention on the Rights of a Child. This August, to implement the spirit of this convention in policies, which demonstrate our determination to abide by international convention and join international organization. As a member of the global community, Taiwan is willing to share its rich experiences in healthcare and social welfare, and to work with the rest of the world. We would like to demonstrate that Taiwan can help, and Taiwan is helping, as well as our determination to participate in global health affairs in a professional and pragmatic manner, so that we can make contributions a part of the global effort. I would like to express my gratitude again for those guests who had come from afar to attend this forum this year. And now I'm honored to announce that the opening of the 2022 Global Health and Welfare Forum in Taiwan. Thank you very much.
Thank you so much to Minister Ray Yuan-Xue. 非常谢谢部长。部长，接下来呢，请在舞台旁边稍后一下下。Ladies and gentlemen, we're going to do another photo on the stage to open a 2022 Global Health and Welfare Forum. 那接下来呢，我们要邀请我们全场的这个各国的贵宾哦，到台上来一起大合照哦。那诚如刚才这个部长所提到的，那这一次的论坛呢，真的是非常谢谢有各国的。有这个政府的代表，也有谢谢非常多公民社会的组织，当然也有我们许多第一线的工作人员一起参与哦。The forum today is not possible without the participation of policymakers and representatives of civil societies and the practitioners on the front line. Thank you so much for your great support. 再次谢谢我们所有世界各国的贵宾哦。那接下来首先有请这个部长到这个中间来就座。首先有请部长就座。All right, and we'd like to firstly have Minister Xue, please take a seat on the stage. 那接下来呢，我们就掌声有请我们的贵宾一一的到台上来。我们首先呢要有请中研院陈建仁院士 ，Ladies and gentlemen, please join me in welcoming Zhenren Chen, Academician, Academia Sinica, Taiwan. Please also join us on the stage. 有请。接下来呢，我们要邀请共同主办单位外交部蔡明彦政务次长，有请明彦蔡 Deputy Minister, Ministry of Foreign Affairs, Taiwan. Please also join us on the stage. And it is also a great honor that we are joined by the Ministers of Health from different diplomatic allies of Taiwan today. We'd like to firstly welcome Lizzie Noxie, Minister of Health, the Kingdom of Eswatini. 让我们掌声欢迎施瓦蒂尼卫生部长. Thank you so much for joining us today. Kevin Bernard, the Minister of Health and Wellness, Belize. 接下来让我们掌声欢迎贝里斯卫生部长，掌声欢迎。And also joining us today, we have Moses Jean-Baptiste, Minister for Health, Wellness, and Elderly Affairs, Saint Lucia, 圣露西亚卫生部长，掌声欢迎。Please also join us on the stage. 接下来呢，我们要邀请来自于瓜地马拉的贵宾 Francisco Coma, Minister of Health, Guatemala, 瓜地马拉卫生部长，掌声欢迎。And also here with us today, we have Isaiah Vaipunate, the Minister of Health, Tuvalu. Let's welcome Tuvalu 卫生部长。Saint Clair Emmanuel Prince, Minister of Health, Saint Vincent and the Grenadines 圣文森卫生部长，掌声欢迎。接下来我们要欢迎卫福部王必胜政务次长，必胜王 Deputy Minister, Ministry of Health and Welfare, Taiwan。接下来我们欢迎吴运东吴任所大使，非常欢迎大使今天特别来参加我们的论坛开幕仪式。Next, we'd like to welcome Yun Dong-woo, Ambassador at Large, ROC Taiwan. Please also join us on the stage. Next, we'd like to welcome Jack Niedenthal, Secretary of Health and Human Services, Marshall Islands. 掌声欢迎马绍尔群岛卫生部次长，欢迎。接下来我们欢迎卫福部李丽芬政务次长，丽芬 Lee, Deputy Minister, Ministry of Health and Welfare, Taiwan. 接下来我们欢迎卫福部石崇良常务次长。Next, please welcome 崇良石 Vice Minister, Ministry of Health and Welfare, Taiwan. 掌声欢迎。And also here with us today, we have Victor Hernan Martinez, Vice Minister of Health, Paraguay, 巴拉圭卫生部次长。掌声欢迎。Thank you so much for joining us today, and please also join us on the stage for a group photo. Thank you so much. 非常谢谢我们这么多友邦的这个贵宾哦，今天也一同来参与。那接下来呢，我们唱名到的贵宾要请您站在这个椅子的后方 ，and for our guests later to join us on the stage, would you please stand behind the chairs? We'd like to firstly welcome Ms. Padmini Murthy, Global Health Lead, American Medical Women's Association. 让我们首先欢迎美国女医师协会全球卫生总监。Let's welcome her. 掌声欢迎。Next, please welcome Clemens Martin Oyer, President of European Health Foundation, Gastein, 欧盟健康协会主席。掌声欢迎。Let's welcome him. Thank you so much for joining us today. Joseph Suvada, Advisor on Health to the Prime Minister of Slovak Republic, 斯洛伐克总理卫生顾问，掌声欢迎。We also have Bettina Borsch, Executive Director, World Federation of Public Health Association, 掌声欢迎世界公共卫生协会联盟执行长。John Dennis, Representative, the British Office in Taipei, 英国在台办事处代表，掌声欢迎。And also here with us, we have ambassadors and also representatives of foreign missions in Taiwan, including Ambassador Candace Augusta Pitts of Belize. 掌声欢迎贝里斯大使。Please join us on the stage. Ambassador Promise Misby of the Kingdom of Eswatini, 史瓦蒂尼大使。掌声欢迎。Ambassador Jordan Kapas of Nauru, 诺鲁大使，掌声欢迎。Next, we'd like to welcome Ambassador David Adams Oricum of Palau. 接下来让我们掌声欢迎帛琉大使。Ambassador Robert Kennedy Lewis of Saint Lucia. 接下来让我们掌声欢迎圣露西亚大使，欢迎。Ambassador Bikanibu Panu of Tuvalu. 接下来让我们掌声欢迎图瓦鲁大使。And also here with us today, we have Omankar D. Wali, Administrator, Office of Global Health, Ministry of Health and Human Services from Palau. 我们今天呢也有邀请到帛琉卫生及公共服务部的国际卫生办公室主任，掌声欢迎。Tommy Kambu Kanji, Representative, Papua New Guinea Trade Office in Taiwan. 接下来让我们掌声欢迎巴布亚纽几内亚代表。卫福部张庸民主任秘书，掌声欢迎主秘。Yongmin Zhang, Secretary General, Ministry of Health and Welfare, Taiwan. 卫福部国民健康署吴昭君署长，掌声欢迎。国健署呢也特别承办这一次的活动啊，非常的辛苦。We have 赵俊吴 Director General Health Promotion Administration Ministry of Health and Welfare Taiwan。也要非常谢谢外交部国际组织司吴尚年司长今天一同参与。We also have Sharon Wu, Director General Department of International Organizations, Ministry of Foreign Affairs, Taiwan. Thank you so much for joining us today. 接下来呢，我们掌声欢迎卫福部社会保险司商东福司长，掌声欢迎东福商 Director General Department of Social Insurance Ministry of Health and Welfare Taiwan. Thank you so much. 接下来呢，我们要掌声欢迎卫福部李美珍参事，掌声欢迎 Major Lee Counselor Ministry of Health and Welfare Taiwan. 掌声欢迎。卫福部刘丽玲技监，掌声欢迎。We also have Li Ling Liu, Director General Office of International Cooperation Ministry of Health and Welfare, Taiwan. All right, and we have one more row to go. All right, 我们还有一排哦。Okay, yeah, we have so many VIP guests joining us today. All right. 我们首先欢迎美国史丹福大学医疗预防及成果政策研究中心王志宏主任，掌声欢迎 Jason Wang, Director, Center for Policy, Outcomes and Prevention, Stanford University. And next, we'd like to welcome Anjanette Chelas Angel, Deputy Chief of Mission Embassy of the Marshall Islands, 马绍尔群岛副代表，掌声欢迎。And also joining us today, we have Ibrahim Ahmed, Trade Commissioner, Nigeria Trade Office in Taiwan, 奈及利亚商务代表，掌声欢迎。Donya Francis, Minister Counselor, Embassy of Saint Christopher and Nevis, 圣克里斯多福及尼维斯临时代办，我们掌声欢迎。Let's welcome him. Victoria Fan, Associate Professor of Health Policy, University of Hawaii at Manoa, 美国夏威夷大学卫生政策所副教授，掌声欢迎。Fran Baum, Director of Stretton Health Equity, University of Adelaide, Australia, 澳洲阿德雷德大学史崔顿健康平等研究所所长，掌声欢迎。Indika Mahash Karanas Leo Thek, Professor of Department of Medical Education, Faculty of Medicine, University of Colombo, Sri Lanka, 斯里兰卡科伦坡大学医学院医学教育系教授，掌声欢迎。Next, we'd like to welcome Hiroshi Egusa, Professor and Chair of Graduate School of Dentistry, Tohoku University, Japan, 日本东北大学牙医学院江草红教授、日本東北大学Egusa Hiroshi 教授、お願いします。ステージにお越しください。接下来呢，我们要掌声欢迎来自韩国的贵宾 Choi Song-hoon, President of International Society of Oriental Medicine 国际东洋医学会崔生勋会长，掌声欢迎。Next, we have Lakshman Samarang Hayake, Professor Emeritus and Immediate Past Dean Dentistry, the University of Hong Kong 香港大学牙医学院荣誉教授，掌声欢迎。Kenji Watanabe, Visiting Professor, Center for Kampo Medicine, Keio University, Japan, 日本庆应大学汉医学研究中心渡边贤治教授，掌声欢迎。日本慶応大学渡辺健治教授，お願いします。接下来，让我们掌声欢迎 Noriyuki Takayama, Professor Emeritus, Hitotsubashi University, Japan, 日本医巧大学高山宪之名誉教授，掌声欢迎。日本一橋大学名誉教授高山Noriyuki、お願いします。Next, we have Professor Masamine Jimba, Professor and Chair, Department of Community and Global Health, Graduate School of Medicine, the University of Tokyo, 日本东京大学医学研究院神馬争鋒教授、日本東京大学医学部Jimba Masamine 教授、お願いします。Won-sup Kim, Professor, Department of Sociology, Korea University, 高丽大学社会学系金元谢教授，掌声欢迎。All right, ladies and gentlemen, last one. Okay, we have Shlomit Avni, Director of Senior Research Planning and Training Division, Ministry of Welfare and Social Services from Israel. Ladies and gentlemen, let's welcome her. 让我们掌声欢迎以色列卫生部司长，试试到台上来，一同加入我们合照的行列。Yeah, I just want to make sure we have everybody on the stage right now, okay? Yeah, okay. 中间吗？ Okay, I need the second row to move one step to your right. To your left, I'm sorry. Okay, too many people, okay. Yes, okay.
第2排右侧的那边的朋友往左边站一步。
All right, okay. Yeah, we just want to make sure that we have a good photo, okay? Yes? Our VIP guests on the stage, let's look at the camera in front of you. Okay, and also we have some signs for you to hold in the hands. Sorry about that, we have to move people around so that we can have the best position, okay? I'll give you 10 more seconds to do the fine tuning, okay? Yeah? 可以吗？可以哈，好。All right, 3, 2, 1. Let's have a photo together. Thank you so much. And for the second photo, would you please take your mask off? 第2张，我们请这个贵宾呢，可以把这个口罩拿下来。A big smile, everybody. 3, 2, 1. All right, let's do it. One more time. 3, 2, 1. Okay, the last one. Thumbs up, everybody. 最后一张，我们一起比一个赞，好吗？ 3, 2, 1. 我们试试再次热烈掌声给台上哦，真的是来自于世界各国的代表，以及我们的学者、专家一同参与2022的全球健康论坛。Thank you so much. You may return to your seats right now. 谢谢台上的贵宾，请您先行回座。我们再次谢谢台上所有的贵宾哦，一同参与我们这一次的全球健康福祉论坛。那真的是有全世界各国的政府以及这些民间组织的代表一同来参与哦。那我们这一次的议程呢，大家也可以看到，我们2天呢排得非常的满，非常的丰富哦。就是希望呢带给大家最多元的观点。And you can see our agenda. We have 2 days, very packed agendas, and our speakers will be talking about some most important issues regarding health and welfare in the world, including civil participation, including how to improve infrastructure, and how to address some of the most imminent challenges facing us right now. 那我们的讲师呢，会分就这个公民参与啦，或者是如何提升全民健康福祉的基础建设等等重要的议题，以及我们所面临的挑战呢，来提出他们宝贵的看法。All right, okay, ladies and gentlemen, now we are going to move on to the keynote speech session. 接下来呢，我们进入到这个我们今天上午的这个专题演讲的场次哦。And let me firstly introduce to you the moderator for our keynote speech session, and she's going to introduce our speakers joining us this morning. Ladies and gentlemen, please join me in welcoming Li-Fen Li, Deputy Minister, Ministry of Health and Welfare, ROC Taiwan. 让我们掌声有请专题演讲场次的主持人，卫生福利部李丽芬政务次长。次长有请。
Distinguished guests, fellow colleagues, dear friends from all over the world, ladies and gentlemen, good morning. Welcome to the 2022 Global Health and Welfare Forum in Taiwan. In this year's keynote speech, we are honored to have 5 distinguished speakers. Each have astounding achievements in their field. To highlight our theme and share their insights into critical topics concerning human health and well-being. Coming up first is Professor Liet Vasur, who is a professor in the Department of Biological Science at Brock University, and UNESCO Chair of Community Sustainability from Local to Global. Professor Vasur will speak to us online on the topic One Health, how humans can thrive with ecosystems. The second speaker will be Professor Joseph Suvada. He served as the advisor on health, advocacy, and science to the Slovakia Prime Minister. He will help us navigate the complexity of global health with his speech titled Global Health in Emergencies Without Borders, Myth or New Paradigm. For the third speaker, I introduce Professor Martin McKee. As a professor of European Public Health at London School of Hygiene Tropical Medicine, Professor McKee is an acclaimed scholar and a long-term contributor to the Global Health and Welfare Forum. He will speak on the topic, Never Again, the world must work together to prepare for the next pandemic, through a pre-recorded video. The fourth speaker is Professor Jianren Chen. He holds the honorable title of Academia at Academia Sinica and is well known for his service as the Vice President of Taiwan. Professor Chen will speak on NCD's precision health strategy to cope with the greatest threat to human health. Last but not least, Dr. Clemens Martin Auer from Austria will give us his special remarks on how the European Union is preparing for global health and aging society. Dr. Auer is the president of the European Health Forum Gestion and has been a prominent figure in the global health space. We are grateful to have Dr. Auer to address our event. That concludes my introduction. Let's give a round of applause to welcome these remarkable speakers.
Thank you so much to our moderator, Deputy Minister Lee, 非常谢谢次长. And now, joining us online, please welcome Professor Liet Vasseur, Professor of Department of Biological Sciences, Brock University, Canada. 接下来让我们掌声欢迎加拿大布洛克大学生态科学教授 Liet Vasseur， 掌声欢迎。Professor Vasseur, are you online?
Yes, I am.
Yes.
Can you see my screen?
Not yet.
Oh.
We still cannot see you right now. Oh, yes, yes. We can see you right now, but please, you have to enlarge your screen. Yes, that's perfect.
Better now? Perfect. Great. Thank you very much. So thank you very much for this invitation, and I'm very happy and I congratulate you for doing this kind of meeting, because this is really needed right now, especially because of the pandemic, and especially because that the world is changing. So today I will be talking about the first thing, that human health is the survival and the well-being. It's not just survival, it's well-being. And it's a question of being not only free of disease, but the capacity of physically and capability mentally be functional. And we have to think about it in a really integrated place. As we know, the population is increasing, and this increasing is probably a little bit too fast. And probably we don't realize that this is creating in some way some stress that we sometimes forget about in terms of what it means at the global level. And when we think about it, is that human population is not only looking at population growth, but we have to look at what we are doing, all the impact every day that we are doing in terms of pollution, in some cases overfishing, it may be warming, it may be in terms of population growth, but all these things are going to have an impact on what we're doing in our society. And in some way, when we think about it, sometimes people think, oh, there's no problem. There's no problem because, oh, we don't have to worry. Hey, for example, no allergies. But at the same time, we know that we are leading to some species to extinction. So we have to figure out the balance between what we can do to save our world and at the same time making sure that we are going to have a good living. And by then, we have to remember, and this is one thing that I always take to all my students, because I'm a professor, and one thing that I always say, make sure that you understand that we only have one planet. We only have one place. Even if people think that we can go to Mars and all the other places, by the end, this is our life. And when we think about it, what should we do? The world is trying to really take into account all these different 17 goals of this Sustainable Development Goals. And when you think about it, you have to remember all of them are directly integrated together. You cannot separate one from the other. Even if you think about it, like even you think about no poverty, you think probably, oh, it doesn't have any impact on land of land. But if there's no land, there's no agriculture. If there's no agriculture, there's no poverty. Yeah, right. So you can see what I mean by that. So by the end, 2020, severe acute respiratory, we know the COVID issue. What happened? But we realized suddenly that, oh, by the way, we can have only one little virus that can completely change our environment, can completely change the way of life. How does it mean in terms of resilience? How does it mean in terms of what we're doing in life? We have to think about more personally now. How do we deal with these kind of things? Because we realize suddenly that, oh, by the way, the world has been changing. And I should say I'm part of the, in fact, the deputy chair of the Commission of Ecosystem Management of IUCN, so the International of Conservation and Nature. And one thing that we have is one of the group is called the ENI Project. And in this kind of group, we are trying to figure out a little bit more all this conceptual model. What does it mean to think about the zoonose and how it works around the ecosystem health? How does it work about the ecosystem health? Because it's not only one part, but how does it work in these all interactions? And I should say it's a big group. And as you can see here, it goes from our chair, Angela Andretti, to many other people that are part of this group. Some are medical, some are more biological, some are more sociological, some are more at different level. But what they are trying to do is trying to connect all these different places together. And this is the conceptual model that we have started to put together in terms of understanding that when we look at the zoonose, like which became, in the case, the pandemic, you can see how it's not just a question of the human society, and the governance, but it's also the ecological integrity. It's a question of the biodiversity. It's a question of the climate change, which I'm part of, and all the other components, and they all interacted together. So when people are saying, "Oh, we have a problem because no, it's more complicated." It's really the question that there are many interconnections, and we have to understand that to be able to start thinking about what are the solutions. So I'm just going to put a few of them, for example, that you can understand more what is the issues that we have to deal with. But for example, in terms of this is emergence, but we understand very well that is a question that we need to understand that there is a question of where's the pool, where are coming the people from, and how is it going to, but these things are connected together. And sometimes we have to realize that there's not only one component, but many components of the ecosystem that will bring the virus to another place. So this is one component that we have to understand. We have to also remember that we sometimes forget the history that we have in terms of when we were many thousands of millions of years more gatherer and hunter. We were looking at more wild animal and all that. And at that point, we were more looking at wild animals, and very few, I would say, germs were coming up to you. Gradually, when we started to be more sedentary because of farming, we started to do agriculture, wild animals, domesticated animals, and gradually we started to be more interactive, if you want, with the animals and other species, and gradually started to increase, if you want, the possibility of connection with different diseases and different possibilities of viruses and everything else. So we have to remember that the reason in part is our domestication and how we gradually get into this system. So one thing that we worked on the conceptual model related to the issue of connecting, zoonose and diseases is the fact that population have gradually related to domestication, related to higher, in fact, transmission to different type of zoonose and also different vectors of zoonose. So what you have seen here is this little connection that often we don't realize, but they are very important in terms of connecting what is wild and what is domestic. And when we look at the ecological integrity, it's even worse, because what we realize is that there are many connections that are not necessarily understood at the beginning, but it can be just related to natural environment, but also the connection with the interaction with the human interaction. So as you can see here, you can see that how many of these different connections are probably interacting and may enhance, in fact, the issues, for example, zoonose. And we know very well, for example, that land use changes and are a part of these issues. So, for example, between Haiti and the Dominican Republic, the difference, the fact that one is more protected and one is more exploited, will have this kind of different system and will impact the way that it will bring issues over time. In terms of connection for climate change and zoonose, this is something that I've been working quite a lot. And the reason is that we know very well, and everybody has seen the IPCC last report, that we are, in fact, in an increasing curve. And that will have a big impact of what will happen in terms of the differences in ecosystems functioning, ecosystem services, and how, by the end, it will impact what are happening in the world. And I should say I've been working quite a lot, in my case, nationally and internationally, in terms of extreme events. And for example, hurricanes, storm surges, flooding, heat wave will all have impact. And we can look at coastal communities or even inland communities, and we have both pictures here, that will have huge impact in terms of economic growth, in terms of well-being, security, and a lot of other type of productivities. So when we look at long-term climate change and these increased impact, we know that it's a question of warming, it's a question of exotic species, it can be in terms of change in distribution. So we have to think about it in terms of not only our own local system, but what it will represent in terms of the overall ecosystem that we're living with. And this is just a way to put it in terms of zoonose, because this is one thing in terms of health issues that we know, is that it's not a question only of one province, for example, in Canada, but it's a question of all the provinces, from the north to the south, to the east, to the west, and how they're coming in terms of, is it coming by boat, airplane, is it coming from simple transportation, but also the question of how are we dealing with it, and how we are really understanding the issues of what it means for the communities. And I should say, I live in Southern Ontario. Many people, even if we know that Lyme disease exists, that encephalitis exists, West Nile exists, many people still deny this component because they think they still are just out of the border. So there's a real education component that needs to be put into it to make sure that people understand the threat that they have to deal with. And this is just a model that I put, and it's not finished, and we're working on publication right now, but showing that, when we talk about climate change, it's not a question of the difference in terms of changes in species composition. It can be their capacity to deal with the ecosystem, but it's also a question of their reaction and how, in many cases, they may probably increase new hosts. So it's a very complex system, and we have to make sure that we understand the system to make sure that we can better protect the population, and we can protect people to understand how to deal with these issues. So there are many other issues. This is just one of the conceptual models that we're working on in terms of legal and regulatory elements, which means that we have to start thinking about better understanding of the policies that have to be part of these issues. And also the different constraints that we have, absence of corruption, which is often and unfortunately very difficult, and different components that should be part of the governance issues. And that means that we have to also think about species protection, wildlife trade, animal welfare, and these are part of the issues of how do we integrate these different movements of species across the world. So by the end, when we think about zoonoses, when we think about health, what we have to remember is that we need a transformative change currently, right now. We have to change the worldview. We have to require that we have to reconnect people and nature together. And it may be in many cases in terms of traditional and cultural practices. And it's more a holistic view of the world that we have to think about. So it's more a system thinking in terms of really not only thinking one species, one disease at a time, but really getting all these things together. And because by the end, we have to remember that when we look at the full complete system, we know that we will be able to get a better healthy community and a better system. So this is why we always are thinking about nature-based solution, because nature-based solution is usually looking at healthy ecosystem with healthy people. Healthy ecosystem means biodiversity, and healthy ecosystem means increased redundancy, and healthy ecosystem means more capacity to withstand extreme system. So by the end, when we look at that, is a question of protection of natural ecosystem, making sure that the ecosystem is healthy, so that by the end, what we want is an ecosystem that is healthy and can lead to healthy ecosystem, and I would say healthy system at the whole. When you look at all these systems here that I'm put with the red, is that all is healthy for human society. So I'm hoping that this can give you an idea that we have to get the direction of a better conservation, better strategic target with the SDGs, and that it will give you, by the end, an idea that we have to prioritize more and more the issue of protection of the natural environment for the issue of better health. And I will leave you on this one, that from Jane Goodall. How can you have ever believed that it was a good idea to grow food with poison? Thank you. Thank you.
Thank you so much once again to Professor Liet Basur. Thank you. We hope to see you very soon in person. 再次谢谢加拿大的 Basur 教授哦。And our next speaker is here with us in the room, coming afar from Slovakia. Ladies and gentlemen, please join me in welcoming Joseph Svoboda, Advisor on Health to the Prime Minister, Slovakia. 掌声欢迎我们下面一位讲师，是斯洛伐克总理卫生顾问。掌声欢迎 ，Let's welcome him.
Yes, okay. Thank you very much for this very kind invitation. I am very pleased and honored to be part of this global community, and really after a couple of years to be again back in Thailand, because Taiwan is really inspiring country and they are living many clever people, and I will mention some of them later on. So regarding to global health and emergencies, we have read and recognized in the last couple of weeks, months, and last 2.5 years, thousands of books which are dealing with surveillance, with different healthcare structures, with gaps and facilitators, with what has been done, what should be done, what was not done. And there are many research papers published every day, almost in average, more than 1.5 million publications which are recognized with some sort of valid evidence has been published related to the last pandemics, which we are still living on. And we know that couple days ago, just 3 days ago, WHO recognized new variants of concern, XBB and BQ1, which are not yet recognized as really those we know what natural and also vaccinated immunity will do, whether it will be escaping or no. But there are a couple of threats and a couple of recognitions, and I would like to share some of them with you. So these are my disclosures. Today I am here as a researcher, not the member of executive board, but I will address some related agendas as well. So last time when I was visiting this beautiful country, it was 2017, and I was attending conference ICC with very clever people, as I have mentioned, and there was a topic which I was part of it, and I was chairing, and it was topic of catastrophic and disaster medicine. What has been changed? Has been changed something? We are back together. This is the same. And this is the most important stuff, and I can end my lecture over here, because this is the most important, to come together, to share, to understand, and to recognize what is the priority. I would like to start this talk with one exact or two cases from one specific place. This place is located in Lebanon, in Middle East, in Beirut, in part called the Baye. And this is the refugee camp, which is hidden perfectly just 200 meters behind five-star hotel. And they are living on this space where there is no place and the ground for kids to play. They are living more than 30,000 registered refugees, which are not having the access to healthcare, the official system. This is playground after bombing the school, which is used for play of the children. We recognized some, and I will come back to this place later on. We have found here one lady 7 years ago who just gave the birth. She was on her journey from Syria, and she gave birth to 2 premature kids, twins, and they were diagnosed by TB and multi-drug pneumonia. They had no chance to go to the healthcare. They entered 3 different hospitals, but they were kicked off. And today, the guys are like this. Thanks God. And thanks to NGOs. And thanks to international community, which is able to provide some sort of support. But is this sustainable? Would they survive if there will be no charity organization nearby? And this is the global health, and this is the emergency. They are concrete, particular stories of particular people living somewhere, waiting for the decisions which we, all of us here in this room, are making or we are contributing to. And this is the clinic. You see, we renovated the bombed school, and we established clinic. And clinic is just next to the rubbish place from whole camp, because there was not other place. So we recognized that there were several epidemics going on due to this. Without help of the community and understanding of the community, there will be still ongoing epidemic of the TB or meningitis or gastroenteritis, very probably. And behind all the emergency, there are even more sad stories. Stories of kids which had been abused, which had been neglected, which are surviving with some sort of the post-traumatic stress disorder, and they are experiencing again and again acute and chronic PTSD. These are paintings from Uganda, from South Sudan, from Lebanon, from Syria, from our missions, of the kids, how they recognize conflicts, what they think about it, how they live with it. So we have to deal not only with the AMR, with the policies, with preparedness of something very concrete diagnosed in lab, but also something what should bring new generation which will take the decisions on behalf of us for our future, for future of next generation, which are traumatized. If we are not going to deal with this, I am very afraid that we will be not having right future. And those kids are living in the environment. And you know the report of UNICEF and very, very nicely designed connection between health and environment. And we know even different areas what we have to consider when we are talking about the health of the children. So crisis is really related with higher expectation of different threats, including infectious. So we know that altogether with social determinants of health, we can expect some problems. Even the migrants, we know measles, TB, we recognize them in all the events related to the migration and to the war conflicts. But do we recognize them as it is within the context? Are we bringing these behind stories and related stories with NCDs and mental health somewhere upper to the global health? What does it mean, global health? Global health should improve outcomes of the health, should bring the security, and should provide the strengthening of the health systems with using appropriate policies based on the research, innovation, and clinical needs, and altogether transform to the education. But we are experiencing that every emergency is related with breaking health systems. Why? Why it is like this on the local, regional, or even global level? We know UHC is great concept. To leave no one behind, it's our wish, daily wish. Do we really recognize what matters and how we can address even potential threat from new outbreaks where we can really recognize it like we understand them. We know where they're coming from. We know some biological relations. We know what does it mean, the biosecurity. But how to translate these feelings and knowledge into the practice. When we did the mapping of existing evaluations of the protocols and policies within the last days related to emergencies, so only 16% of the countries, evaluated countries, they were included 67 countries, they had emergency protocols included, including all the pillars they are known that they have to have. And regarding to preparedness, you see that it was hardly reached 40% for all the domains. So there is also a challenge which we recognize also in Slovakia, biosecurity. Yeah, there are permeable borders. There are threats, but I don't know, you are researchers, scientists, policymakers. You are involved in the research every day. You are reading different scientific papers. Perhaps you passed through some and you recognized, as we did, that there are more than 200 research with complete sequencing and modeling of the coronavirus for designing how to escape the immunity, how to design coronavirus which will be able to escape the immunity, either natural or the vaccination. Should this be publicly available? Is this not material for bioterrorism? Should not be this included in the international health regulation somehow? Should not be addressed this issue somewhere? And I know that Taiwan is really strong in addressing international health regulations and even the misconception and misunderstanding of some recent design of next development and the redesigning of them. So we have found that really we have to understand, and then we can prevent and we can detect and we can respond. But we have to really bring all relevant stakeholders together, and we have to recognize also that there is no global health. Health is divided, world is divided according to different measurements, according to development, according to the death index, another index. Everything is somewhere. And we try to reach equity. What does it mean, equity? Are we able to not only speak on the conferences and forums about the equity, but to do something what should address the equity in the practical way, not to left someone behind? So the determinants of UHC are really important. And for example, Doctors Without Borders, they are bringing some evidence that there is lack of the evidence in the emergencies. There is lack of access to the appropriate medication and testing. Especially in rising numbers of the conflict zones, there is problem also with the human resources. And what is higher, humanism or politics? So there is a question. But we know from science, from humanitarian aid, that there are many guidance and standards related to the evidence. We know how to provide the measurements and assessments, how to recognize contextualization of the needs, and how time matters. This is our lesson learned also from the pandemics, that at the beginning, time was not taken into the consideration, but the politics was the first. And based on this, we can perhaps agree with Henry Kissinger that we are not so ready for the next crisis. So how to bring practice and theory together with designing of the goals? Do we have a competence? Are we following what we have been studying, how to develop evidence-based medicine? Are we applying this in the science for the policy making? So there have been published a couple of nice papers. For example, this one addressing adherence of clinical practice guidelines related to the COVID-19 treatment. And that is really important to address appropriate clinical question we are addressing, and appropriate even evaluators who are part of the audience, who are part of the process development of this kind of guidelines. Who are those who are having to adhere? It's only the patient, or it's also someone else, somewhere upper? And how we can expect outcome when we are not on the same page? So the evaluation showed us that only 3 guidelines out of 72 were addressing patients and public perspective, and they were included somehow. And you see that only 2 had full compliance with international standards. And we know that there are a couple of pages we could find the evidence and recommendations how to treat our patients. But how many physicians they really knew where to search for the evidence? Was it accessible? We did a research between 7 countries in European Union, and we have found that only 13% of GPs were able to find appropriate evidence or the portals where appropriate evidence was published. There is a problem that living evidence is missing. So therefore, we established with McMaster University, which is collaborative center of WHO for research impact and evidence, living evidence, and we provided reg map, recommendation map for whole domains of COVID-19, prevention, treatment, diagnosis, even public awareness. I will come to this later on. Regarding to evidence and policies, so even students had been included in the designing of some recommendations and evaluation process. And students find out that 4 recommendations out of 11 were crucial based on their research. First, it was rebuilding the trust among the citizens. What does it mean, trust, these days? So they addressed that involvement with really ethical binding and also conflict of interest, showing and declaring the transparency is the crucial together with the data. And for example, in Slovakia, we had good example how we can do it. In the first wave, we established a National Crisis Intervention Clinical Team. I was responsible for that. We published a couple of communications, UHC principles, including the policies, and we engaged all the community leaders, and we tried to develop also evidence-informed policies, and so on, and based on international collaboration. Then new government came, and everything has been stopped. We were dismissed because it was not necessary anymore, because first wave was only with 28 deaths in Slovakia at all during whole first wave. And you see how it continued. We lost within 3 months more than 7,050 people with the preventable death related to COVID directly or indirectly, more than 6,000 directly, and additional next 7,000 related to collateral damage. Is this really understanding what we should do? This provided really great distress. And therefore, all of us, we are able to recognize also need for psychosocial support, for functional team to establish strategic plan and leadership. And as Saneka mentioned, where we don't know where we are going to swim, we will be not happy with any wind. And therefore, where there is a problem, we can create this fish a bird, bird a fish, or we can comply with what is evidence bringing to us, how to develop evidence-related, evidence-informed policies. And we know that the lens is really important. If we are not bringing right people on the board, we are not asking right questions, then we should not expect good outcome. Perhaps you know GOPSAD method. I really like it when I am lecturing about clinical guidelines, because it's evidence-based medicine. Good old boys sat around the table and made a decision. And we know that in many countries, including mine own one, it was not done the best decision all the time during the COVID. Why? Because there was not good partnership with science and with the recipient of the recommendations. So for the strategic planning, we really need to know who is partner, and we need to address them the questions, to explain them why we need them, what's the common role, and how we can address what they need, what they are fearing too, what they need to explain, even uncertainty. Let's have a look for transparency. Perhaps you know this kind of pages about non-transparent advisory groups in different countries. How many of them, or how many of our countries published who is advisor for COVID and what they are with the background, what they really would like to achieve, what is the conflict of interest on the behind? So there are some questions, and we really need to show the evidence which is related to the needs. We really need also to create a set of indicators to measure whether the outcomes had been reached. And also we need to prove the transparency, and we need to have really good communication. Partnership and collaboration is the way for effectiveness. Here we can see that membership list, publicly announced framework, measurements, outcomes, how society approach, behavioral and cultural insights and interventions, recognition, multi-sectoral stakeholders and evidence, adoption, adaptation, contextualization is a key, as it is summarized in the report of WHO. At the beginning, we know that it was a problem even for WHO itself to understand and accept even face mask recommendation. Even there was very strong evidence, because it was also somehow driven by member states. And we need to address this very honestly, and we have to take lessons from this experience as well. And as we may know, that there are a couple of studies related to the communication. Social media are really very crucial, and it should be based on the intuition again, or based on the evidence. And based on the evidence, we tried to collect the data in COVAS studies related to the hesitancy, but even side events, and to communicate properly. So we have found that really people who decided not to take a COVID vaccine, they were more announcing the adverse or fear of the adverse reaction, or they were thinking that this is only doctor's recommendations, or they don't have a trust, or this is the government push, this is the politics behind, yeah, it was not appropriate time, and so on and so on. So we have to understand why people are fearing, and because perhaps this was not properly addressed in our communication. And WHO did a very nice study related to these messages, and they put for 6 months on web page of WHO different contents of the information related to COVID-19. And as you may see, there are different outcomes with description of the framing, and we have found that this framing is really very important, and you can see how many clicks it was related to positive and negative headlines. And this is also a way how we have to contextualize. We have to understand what other people are looking for and what is really way for right communication of the difficult things and even the emerging changes, because this is time of dynamic process. And we need therefore also living evidence. And this living evidence is giving us a chance to communicate even during emergencies very effectively. So we have to honestly disclose what we know and what we don't know. We have to honestly invite people to join the advisory boards and to show also their expressions. Budget is one and needs are many. Different groups, different opinions, but if they are sitting on the same chair where we are sitting, so very probably this is the way how we can find really people-centered approach from the community, and we can address really composition and participation as the main pillar for our sustainability, and how to address cultural and language and other barriers related to the challenges of designing appropriate and scientific-based policies. So I would like to continue with the addressing of recommendations and the strength of the recommendations. We know that many things don't know. We have to have a time, and this is in emergencies, this is fine. This is completely fine, but people have to address their questions and they have to get the answers. What is the problem? To be honest, that we don't know something? This is not a problem, because for a person who is responsible for human lives, so this is the duty, daily duty. We have to find a way how to address it. And there are many options, even to translate the evidence into understandable language. And we have to explain this why and to provide rationale for that. We have to, for example, address why the conditional recommendations and what is the rationale behind, how we can use this in daily practice, how our patients should benefit from it, and what are the benefits and what are the harms. Are there really strong RTCs behind, or there is just expert opinions? That's fine if there is only expert opinions, if there is something very emerging and very new. So let's be more careful, all of us. Yeah? Is there equity addressed? Are the key populations' needs really well recognized? Who else needs the why? Of course, politicians and policymakers. How they are able, or are they able to understand and to read the research papers? What is your experience? Mine is not at all. OR, EF, whatever is there, the abbreviation, they are completely lost. Not even to translate into the paragraphs of the legislation. Sorry, but this is our duty, your duty, to help them to transfer this into understandable language. And how we can do it? With recommendations we developed with McMaster University and around the world community from 30 countries, living evidence of COVID-19. We did it also for TB, and we are recently doing it for pediatric cancer and some other diseases. If you are willing, you can join us. And you see that more than 30 countries are involved, and they're evidence-based groups. We developed until today's 6,560 recommendations. Yeah? And you can see that this is really also translated into the language understandable general population, but also politicians. I don't want to make you overworked with these busy slides. I will just share the QR code. If you are willing, you can have a look what we are doing, how you can perhaps contribute, how you can adapt this for your language, how you can be part of our community. So this is the QR code if you are interested. So this is also a way how we can let people know what we are doing, what we are thinking, how to translate the evidence, not to talks behind the doors, and they are left, they are feared, and then they create these informations on social media. So of course, there are a couple of very nice contextualized systematic reviews, for example, Cochrane review, which summarize together with OECD analysis of 14 recommendations for health systems, strengthening and gaps addressing for next emergencies. They are summarizing some recommendations, and I would like to combine what I told already with other abstractions from the research, that the collaboration, capacity strengthening, and giving people voice is the crucial pillar for any emergency decision. And these are last two slides. The innovation is really neat and is a reflection, and the action has to follow. We have to really learn how to explain the evidence, how to collect it, and how to address the needs of different populations. And this will be just for summarizing. Evolution of information and communication technologies are supportive. We have to use it in a very wise manners, and we have to rapidly change our thing in the context. We have to address the context, and we have to bring it into the action through the policy designing. So global health is happening in the context of regions, peoples. Evidence is the key, and sustainability without transparency is only the myth. Working together is only one key pillar and paradigm what we should do. And this is coming to the first slide and first my sentence that we are together, nothing has been changed. We are together, I can finish my talk, and we are together, we can work together and we can achieve more. And I really appreciate that I am today with you, and I am looking forward for all the others very excellent lectures to study more about your achievements and to learn how we can address this on global, regional, local, individual level. Thank you very much.
Professor Joseph Sawada, thank you so much for your very, very informative talk. Thank you again. All right, ladies and gentlemen, next up is our old friend, Martin McKee. He couldn't be here with us this year, but he has a pre-recorded video for us. So next, please welcome Martin McKee, Professor, European Public Health, London School of Hygiene and Tropical Medicine. 那接下来呢，我们有请伦敦卫生及热带医学院公卫教授 Martin McKee 透过预录的影片来跟我们分享。Let's welcome him， 掌声欢迎。
Good morning, and thank you so much for inviting me to talk to you today. I'm really sorry not to be with you in Taipei. I've enjoyed my visits to Taiwan so much over the years, and of course it's been impossible during the pandemic. And sadly, although Taiwan has now opened up with the removal of the quarantine restrictions, I already had a long-standing commitment in Bogota in Colombia. But anyway, I do hope that I'll be able to join you in person in next year or in future years to see my so many good Taiwanese friends again. When I spoke to you last year, I was talking about the work that we had done in the Pan-European Commission on Health and Sustainable Development. It was looking at how we build back better in the light of the pandemic. So I want to move on from that to look at what's been happening since then. The key message in everything I'm going to say is that we, wherever we are in the world, need to work together, because otherwise we're going to have many of the same problems that we saw during the pandemic. So the key message is, wherever we are, we're all in this together. Now, this is a slide that you will have seen many times before in various formats, and it's simply a reminder that we are in a continuing evolutionary battle with microorganisms, many spreading to humans from the animals in which we live in close contact with. And because of this recognition, of course, countries of the world have done a lot to ensure that they are for the next infection, the next initial pandemic microorganism. But how well does it work? Well, in 2019, the Global Health Security Index was developed by a group of researchers and policy analysts in the United States, and it looked at the countries of the world in terms of their capacity to respond to a pandemic. The countries that came first and second were the United States and the United Kingdom. And of course, it's true that both had immense scientific capacity. Their laboratories, their researchers were very well prepared. But of course, when it came to the pandemic, it became clear that there were certain problems, and both of the countries did really rather poorly. Now, this is in marked contrast with Taiwan, which actually did very well in the pandemic, at least until the emergence of Omicron. And you will have recognized the challenges that you faced, also the many criticisms from other parts of the world, but yet you were able to keep the pandemic at bay, at least in the initial stages. And many of us in Europe were looking with great admiration at what you had done. But of course, COVID is one thing, and now as hopefully the threat is retreating, although we never know what the next variant will bring, we're seeing the risk of other infections. And we have monkeypox, of course. Fortunately, that seems to be being brought under control in many parts of the world. But we have Ebola in Uganda, and we have no idea what we will have next. But we need to look forward. And in a phrase that many of us have taken up, we are seeking to understand how we can build back better. Now that means reconstructing our society. It means making up for the losses in education, the problems of chronic health that are a consequence of COVID, long COVID, and the increased mortality we're seeing in many countries, the economic consequences, and so on. So a lot of effort is going into that, but then we have the problem of politicians being thrown off course. Now, there is a famous quotation from a British Prime Minister in the 1950s who was asked, "What keeps you awake at night, Prime Minister?" And he said, "Events, dear boy, events. Things happen." And unfortunately, whether it's extreme weather events or conflict or whatever, there are many events that are throwing people off course. And the greatest of these, at least for those of us living in Europe, is of course Russia's unlawful invasion of Ukraine. And that's having consequences for the energy supplies to Western Europe, for the food supplies to many parts of the world, countries like Yemen or Lebanon that are very much dependent on the grain that came from Russia and Ukraine. So this is something that is having global consequences. And now we're hearing threats that we might see the use of tactical nuclear weapons, which we all desperately hope will not happen. We clearly have much more to be worried about. And that is dominating the attention of policymakers and making it very difficult to move forward, particularly in the G20, which of course Russia is a member of, and which is one of the settings in which many of us hoped there would be a possibility to achieve progress. So as we move forward to prepare for the next pandemic, what do we need to have in place? Well, I'm going to talk about 6 different things briefly. I'm going to talk about the need to prevent the emergence of a pandemic. I'm going to talk about the need for intelligence to detect one if it arises. I'm going to talk about innovation to make sure that we have the technology available. And I'll talk about equity, because we all share this small rock, the third rock from the sun. We're all living together on this planet, and we all have a mutual dependence on each other, but we don't always show it. I'm going to talk about the legal framework that we need to move forward, the international law framework, and I'm going to ask where we will find the money to do all of these things. So let me start with the idea of prevention. One of the things we know is that we are so dependent on biodiversity. There are still many species that remain undiscovered, but as we are damaging the environment around us, we're chopping down the tropical rainforest, challenges for climate, of course, but of course that is bringing us into contact with animals that we were not living alongside before, and with it the risk of zoonotic infections. And that takes us to the area of One Health. And this is the health that arises at the intersection of humans, of animals, and the environment, the natural environment, the built environment, and so on. So how do we work together as countries in the world to deal with the challenges in these areas? We're quite fortunate in many ways, because we're now recognizing, we have evidence to back up the very strong economic argument for supporting biodiversity. The Dasgupta review was commissioned by the British government and sets out in great detail why it is in everybody's interest to maintain biodiversity. It sets the economy at the center of the biosphere, but it talks about how the economy is embedded in the biosphere and is not external to it. So this is the economic argument, which of course is what many politicians are interested in. But of course we know what we are doing to the environment. I've already mentioned the tropical rainforests, the implications for the vegetation, but also for the animals that are there, and for the microorganisms that are harbored with them. We are essentially cutting down our future. Now, there are things that can be done. We have a Convention on Biological Diversity. A number of years ago, governments of the world agreed the Aichi targets, which set out a number of goals to be achieved. And in 2020, we had the UN Biodiversity Conference. So the countries of the world are coming together to do something about this. But clearly there is so much more that needs to be done, and in all parts of the world. But of course there is a particular challenge in some parts of Asia, which have benefited from the tropical rainforests, but where we're now seeing such damage being done. Let me say something about One Health. As we know, the COVID virus, SARS-CoV-2, almost certainly emerged in the wet markets in Wuhan. And here I pay tribute to the Taiwanese scientists who were among the first to draw the world's attention to it. The problem is that the responsibility for One Health is divided within the different parts of the United Nations. We have the World Health Organization responsible for human health, the World Organization for Animal Health, self-evidently responsible for animals. We have the Food and Agriculture Organization with its role in agriculture, and the UN Environment Programme. Now we are seeing this quadripartite relationship strengthening. These organizations are talking to one another much more, but clearly there is much more that needs to be done, and we need to do everything possible to encourage this process. Let me talk a bit about intelligence, because whatever we do to protect biodiversity, we will have new infections arising. And here I want to talk about surveillance and open source intelligence. Now, there already are a number of mechanisms that are in place for surveillance of infectious disease. This is PulseNet, where you have a network of laboratories in countries all over the world that are collaborating to share information on emerging infections. But we can see that it doesn't cover everywhere. There are large gaps in countries of the former Soviet Union, in the Middle East, and in particular in Africa. And this is just a voluntary association. We have seen tremendous progress with GISAID, looking at the emergence of variants with SARS-CoV-2. Again, a voluntary collaboration. And this has allowed us to track the emergence of the variants. But the tragedy, of course, is that countries have often very limited genomic sequencing capacity. So a few countries, Denmark, the United Kingdom, have been major contributors. But this has helped us to trace the pandemic. But we need to do much, much more. And again, this is an area where Taiwanese scientists have been very active. But we need to go beyond that. And one of the things that I've been particularly interested in is what's called OSINT, or Open Source Intelligence. And this is a concept that's been around for a long time, but it has really come into its own in the war in Ukraine. It's been defined as any or all information that can be deprived from the open, the overt collection of information from media, government reports and other documents, scientific research, commercial vendors, the internet, and so on. So the main qualifiers are that the information does not require any type of clandestine collection techniques. Now, we all know that we can look at Google Earth and have a really detailed view of what's happening in the world. We can have access to the world's media. And in Ukraine, people are getting access to Telegram channels and all sorts of other sources to understand what's happening. So the official government intelligence services that previously had a monopoly on this are now being challenged by these other groups like Bellingcat, and they're having a huge impact. So if we could do this with a war, surely we can do this with the risk of pandemic infection. Surely we can find new ways of trying to use this information to get early access. And again, to some extent, this has already happened. And some of the earliest signs of what was happening in Wuhan were detected in this way. But there is much, much more that I think that we could be doing. And these are separate from the formal surveillance mechanisms through the United Nations and the World Health Organization in the international health regulations. So far I've talked about preventing the next pandemic, detecting it earlier, but we need to be able to respond. And that takes us to innovation. And here I want to talk about the discovery of new therapeutics and vaccines and clinical trials. We know that the existing system for therapeutic innovation is not working. It's not working because it is not delivering antimicrobials, for example. And here the problem is simply the market structure. If you develop a new antibiotic, you have spent a lot of money doing so, and you need to recoup your income. Now, you're only going to recoup your income if you sell a lot of antibiotics. But if you sell a very large amount, then the more you sell, the quicker you will get resistance. And if the resistance occurs before the expiry of the patent on the antibiotic, you will not make your money back. So we need new models. And we have new models we can look at. New models like the Drugs for Neglected Disease Initiative, for example, a public-private partnership that has developed new drugs for the diseases that are neglected by the existing system. Indeed, we should ask ourselves, why are there any neglected diseases? Why are there any neglected populations? But there are. So we need to find new ways of working. So that's the discovery and the development of new drugs, new vaccines, and so on. But we need to evaluate them. And this is something that we have not been so good at doing, with a few exceptions. So we can look at the WHO COVID-19 Solidarity Trial. Now, this was a platform for undertaking collaborative research to evaluate new medicines for COVID. It did have some successes, but when it tried to recruit patients in each country, it had to go through complex regulatory approvals. There was one very good French study that was already existing, but the regulatory barriers to scaling that up across Europe were very difficult. The one exception, and an exception that shows what can be done, was from the country I live in, the United Kingdom. And the recovery trial went from the completion of the protocol of the trial to the recruitment of the first patients in 9 days. And it had sufficient flexibility in it that when it became clear that they needed to evaluate new candidate drugs, they were able to switch very quickly. And it was the recovery trial that showed us that chloroquine was not effective, for example. It was the recovery trial that showed us the benefits of steroids. Now, these are trials that would never have been done commercially. And this shows you the importance of having a very strong infrastructure in place. And the recovery trial benefited from that earlier investment. I've already said the United Kingdom was very poorly prepared for the pandemic. We had a lack of political leadership, but some things it did well, and the recovery trial was one. And that owes a great deal to the work of the National Institute for Health Research, led by Sally Davis, which put in place the regulatory mechanisms to get the IRB, the ethical approval, through quickly, to get the regulatory approval through quickly, and to have a network of clinicians working in hospitals who could recruit patients to the trial. But we need to look beyond that. We need to ask, what is the purpose of the research that we fund? I've already said that the model does not work. It's not delivering the antimicrobials that we want. It's not delivering many of the drugs for rare diseases. It's a model that was based on blockbuster drugs, where you discover a drug which can be used to treat millions of people for the rest of their lives. The antihypertensives, for example, the anti-inflammatories for musculoskeletal disease. But all of those diseases now have perfectly good treatments. We need something new. So we need to have national research strategies and internationally coordinated research strategies. We already have that in Europe with Horizon Europe. Sadly, the United Kingdom, where I live, is not part of that for ideological reasons by the British government, but then that's one of those things. But we also need to be looking at the neglected diseases and populations and fill those gaps. We need to be working with industry, between the public and the private sector, but we need to do this in a different way. the public-private partnerships should not simply be a way of giving a lot of taxpayers' money to industry to benefit their shareholders. We need to find a system of sharing the risks and the benefits. We need to remember that much of the original discovery is done in public sector laboratories, and yet the benefits come to the private companies. In effect, governments are paying twice, first to develop the drugs and secondly to buy them. But it's no good to have new medicines if we don't make use of them, and we need to look at how we can create learning health systems, another area where we can exchange ideas. What are the ways in which we can get evidence into practice? We've got many different models, but which are the ones that work best, and how can we diffuse them into all countries in the world? So we can deliver the innovation, but can we actually make sure everybody benefits from it? That takes us to the issue of equity. Now, COVAX was the means by which we hoped that this would achieve success, a collaboration between CEPI, Gavi, UNICEF, and the World Health Organization. And did it actually achieve what it set out to do? Well, no, because there were many, many problems. The concept had a good idea. It was based on the idea of all countries sharing their vaccines and working to get 20% of their populations vaccinated. As with so many of these things, it raised only $11 billion out of an $18 billion target. We're seeing similar challenges as the Global Fund is replenishing its funds, and some countries like the United Kingdom have yet to make, at least at the time I'm talking to you now, have yet to make a pledge to do that, which is scandalous given that they were a major donor in the past. The rich countries bypassed the COVID system to buy their own vaccines, and this meant that COVAX was at the back of the queue for purchasing vaccines. The program failed to engage effectively with poor countries. It was very much dominated by the rich ones, and it rejected the mRNA vaccines as too expensive. And that was a problem because people in poor countries were left thinking that they were getting the second best. Now, eventually, it accepted donated vaccines rather than getting the money to purchase vaccines, but that led to problems of deliveries. So vaccines were being delivered to low-income countries whenever they only had perhaps a few months of shelf life left, and the countries couldn't use them. So we now come to the issue of a legal framework, because the countries of the world have to collaborate within a clear framework in international law. And there, the obvious answer is a treaty. There are so many treaties on all sorts of things, the rights of the child, on nuclear weapons, on the law of the sea, on fisheries, and on world trade, and so on. Surely, after the pandemic, we must realize that health is at least as important as all of these things. So there is a proposal for a pandemic treaty. There is an intergovernmental negotiating body, which has been tasked by the World Health Assembly to negotiate a pandemic instrument. It's at 2 meetings so far, with the 3rd meeting coming up in December. And that will be to consider it a conceptual first draft, effectively. So the negotiating body has decided that this pandemic instrument should be a legally binding convention or agreement, which can be done under Article 19 of the World Health Organization Constitution. But there should also be non-legally binding elements. Some bits will be legally binding, other bits will be optional. Now we have a document, a working draft that has been published in July, but it's got many issues and it demonstrates the huge scale of the challenge ahead of us. But there are still very few details in the responsibilities or structures. The negotiating body is conducting informal focus consultations to inform the development, and the team are attending WHO regional committee meetings to update the member states and to consult with them. The expectation is that this will conclude in 2024 at the World Health Assembly with the adoption of a pandemic instrument. There'll be a working group on amendments to the international health regulations, which should be coordinated and reported at the same time. Now, There is progress on transparency. We do need transparency if we're going to have confidence in this process. So the second meeting of the INB was broadcast publicly almost entirely, which was a big improvement in the past. But there's still a lot to do, and in particular to ensure civil society participation. But it is expanding, it is being helped. But there are, of course, some people who say we should not be aiming for a treaty. Some people don't believe in global treaties, but many people who do also are conscious of one of the particular challenges that is involved. And this is the problem of the United States. The United States is one of a handful of countries, along with Somalia and a few others, that has not ratified the UN Convention on the Rights of the Child. It has not ratified many other international agreements. And in fact, it hasn't for a very long time. One of the problems in the 1930s was that although Woodrow Wilson was one of the leading advocates of the League of Nations, he could not bring Congress with him. And here we have one of those people, Tucker Carlson, who, as you know, spreads disinformation, misinformation at every available opportunity, talking about the WHO being given power over Americans, which of course is complete nonsense. But he has a large audience, he is very influential, and it will be very difficult to get the USA to agree to anything. And without the USA, let's face it, we have a challenge. So this is a huge problem for global governance when you have a country who, despite the best efforts of the president, cannot bring the legislature with them. But even if we have a law, we need money. So where do we get the money from? Well, we have a proposal. A financial intermediary fund, in fact, more than a proposal, created by the G20. Now, when we were working on the Pan-European Commission, we saw the G20 as the real hope here, because that's the reality, that's where the power lies. The United Nations, with its 193 countries, can do so much, but in the end, it is limited because there are so many countries with different interests. So the Financial Intermediary Fund is managed by the World Bank in collaboration with WHO, and it began work only a few weeks ago. The governing body includes equal representation from sovereign donors, potential implementing country governments, representatives from foundations and civil society organizations. And it's going to strengthen laboratory systems and surveillance and support epidemiological sharing of data and so on. But so far it has only raised 1.4 billion of a $10.5 billion target. So it still has a long way to go. But what about the money for governments? It's fine to get, we need a global entity like this. We already have the Global Fund, which of course is also competing for funds with the Financial Intermediary Fund. We thought about this quite a lot in the Pan-European Commission. We need to create an enabling environment. Now, much of this will be decisions by individual governments. A government can decide how much to spend on health and on preparedness. But the international arrangements can help or hinder. So we need to change the accounting systems that countries have to adhere to with their system of general accounts in ways that promote investment. We need to look at ways in which investment in the health sector is seen as an investment and not routine expenditure, because you are investing in your future health and your future economic security. We need to incorporate health into the economic forecast by groups like the IMF, who need to say to a country not that they're spending too much on health and therefore they should be spending it on other things that drive productivity, but they should be saying that you're not spending enough because if there is another pandemic, your economy will take a hit. And that means that we need to get health included in things like the Article 4 consultations by the IMF when they come to visit a country. We need to look at ways in which we can come together to invest in global public goods. And we also need to recognize that the rich countries need to increase the share of development finance spent on health. So I've talked quite a lot about preparing for a pandemic, but that's not the only problem we face. Again, in our report, we asked what comes next. And it could be almost anything. A few weeks ago, we had an attempt to fire a satellite at an asteroid. It collided. with the asteroid. It just had to show that it was going to. But in the future, if there was an asteroid coming towards Earth, the idea would be that you could fire a nuclear weapon at it and knock it off course. Very dangerous unless you get it just quite right. And some of you might play billiards or snooker, and you can try to knock a ball on the table in one direction, but it may not always go in the way that you want it to. Obviously, the threat of other infectious diseases, and now tragically, we see in Europe the real threat of nuclear warfare. But then there are all the threats in cyberspace. During the pandemic, we saw attacks on the information system for health in Ireland, for example. We've seen cyber attacks on countries like Ukraine and Estonia. We're now seeing this being used as a weapon of war in many countries. But there are a whole range of these things. Now, we discussed them in great detail in the report of our Pan-European Commission. So I didn't go through all of it because I spoke about a lot of it to you last year. I've tried to move forward and look at where we're getting progress, but I would thoroughly recommend that you do look at our report, and in particular our evidence review. This was a panel chaired by Mario Monti, a former Italian Prime Minister and European Commissioner, with a lot of senior politicians, very few health people, but that was good because we had a very fruitful discussion. And of course, finally, I would like to refer you to the work of the European Observatory. And here you can find our COVID Health Systems Response Monitor, our webinars. There is a wealth of material there, and I hope that you'll find that interesting. So thank you very much indeed. I'm really sorry I'm not with you in person in Taipei, and I very much hope that I will be with you sometime in the future. Thank you very much indeed.
Thank you so much to Professor Martin McKee. We hope to see you very soon. Thank you so much. 非常谢谢我们的讲者哦。And now it really gives me a great privilege to introduce our next speaker, academician of the Academia Sinica and former Vice President of the ROC Taiwan. Ladies and gentlemen, please welcome Dr. Jianren Chen. 接下来让我们掌声欢迎中研院院士、中华民国前总统陈建仁博士。
Thank you very much. I would like to thank the organizing committee for inviting me to give a talk on the non-communicable diseases with a subtitle of Precision Health Strategy to Cope with the Greatest Threat Human Health. And as we all know that the non-communicable diseases, NCD in short, kill 41 million people each year, and it's equivalent to 74% of all deaths globally. There were 17 million people died from an NCD before age of 17, and 86% of these premature deaths occurred in low and middle income countries. And the main types of NCD, including the cardiovascular diseases, cancers, chronic respiratory disease, and diabetes. And these four disease groups account for over 80% of all premature NCD. And NCD threaten progress toward the 2030 Agenda for the Sustainable Development, which include a target of reducing the probability of deaths from any of the four major NCDs between age 30 and 70 by 1/3 by 2030. And as we all know that NCD affect the people of all ages and regions and countries, and they have long duration and are a result of a combination of genetic, physiological, environmental, and behavioral factor, and modifiable behaviors such as tobacco use, physical inactivity, unhealthy diet, harmful use of alcohol, and exposure to environmental carcinogen may increase the risk of NCD. And we all know that these behaviors can increase the occurrence of metabolic and risk factors, such as the hypertension, hyperlipidemia, hyperglycemia, obesity, and also exposure to physical, chemical, and biological carcinogen may increase the risk of various cancers. And NCD are driven by rapid, unplanned urbanization, globalization of unhealthy lifestyle and population aging. And From these modifiable behavioral risk factors, for example, tobacco accounts for over 8 million deaths every year, and 1.8 million annual deaths have been attributable to excess salt or sodium intake, and more than half of 3 million annual deaths attributable to alcohol use are from the NCD, including cancers, and also 830,000 deaths annually can be attributable to insufficient physical activity. And for the metabolic risk factor, hypertension, overweight, obesity, hyperglycemia, hyperlipidemia, they are all very important to increase the risk of NCD. And the NCD have a significant impact, especially when we consider about its socio-economic impact. The poverty is closely linked with NCD, and the rapid rise in NCD is predicted to impact poverty reduction initiative in low-income countries, particularly by increasing household costs associated with health care. And vulnerable and socially disadvantaged people get sicker and die sooner than people of higher social positions. And also, in low resources setting, health care costs for NCD quickly drain the household resources. So we have to consider this socio-economic impact of NCD. And in order to have a better control and management of NCD, we consider that precision health is very important, and precision health strategies in better management of NCD are really critical. In precision health refer to the tailoring of health promotion, disease prevention and treatment, and palliative care to individual characteristics. And it does not only mean that the development of medicine and medical devices that are unique to a patient, but also the ability to classify individuals in subpopulations that differed in their susceptibility to a particular diseases in biology or prognosis of those diseases they may develop or in their response to a specific treatment. So preventive and therapeutic intervention can then be concentrated on those who will benefit and sparing expense and side effects for those who will not. And this slide shows this the paradigm shift in the treatment of NCD. From the very beginning, we have the so-called one-size-fits-all medicines. And among these people who got the treatment, only 1/3 will benefit from it. And another 1/3 have no benefit, and another 1/3 have the adverse event taking this medicine. And we shift from one-size-fits-all medicine to stratified medicine. We try to group the patient by their disease subtype, and also the risk profile, demographic, and so forth. So we can stratify the patient into 3 groups, and we give the medicine to those only who can benefit from the drugs. However, we have to move further, shift this paradigm from the stratified medicine to personalized precision medicine. And we try to give each individual patient based on their genomic or omics, lifestyles, and health history and so forth, and try to develop companion diagnostic and biomarkers as well as the therapies, and to provide therapies for these 3 different groups of the patient. And from the precision health point of view, of course, we have to have a precision management of this diseased patient. This is the current intervention, and this is the threshold for the earliest clinical detection. But in the future, we have to move from the diseased status to the healthy status and try to use molecular biomarkers to have an early detection of the diseases, and then we can prevent the progression of the diseases. And even further, we may move to these people who are still healthy and try to provide them the risk assessment and promote their health status and to prevent the occurrence of the diseases. So from this precision medicine to precision health, originally we focus only on diseased person, and we use precision medicine such as the diagnostics and therapeutics as well as healthcare to provide to the diseased person. However, in the future, we have to promote precision health, including this risk assessment, precision screening, as well as the health promotion, and to change the lifestyle, living environment, as well as the personalized dietary intake and nutrition, exercise, and so forth, and try to promote health and prevent disease occurrence. As said by William Osler, he said that medicine is a science of uncertainty and an art of probability. So in the precision health, the prediction is very important. And for the predictive medicine, it entails that predicting the probability of disease and instituting preventive measures in order to either prevent the diseases or significantly decrease its impact on the patient by preventing mortality and limiting morbidity. And as we all know that for the disease and the prediction, this Framingham study is a very good example. It's a study began in 1948 with more than 5,000 adult residents in Framingham have been studied for the cardiovascular diseases, and they have developed a series of the risk functions for the prediction of arterial fibrillation, cardiovascular diseases, and other cardiovascular diseases. And for example, this is coronary heart disease and risk predictors according to our Framingham study. If we know the age, the total cholesterol level, high-density lipoprotein cholesterol level, blood pressure, diabetes status, and smoking status, then we can try to add up a different kind of a risk score and come up a good prediction. For instance, the CHD, if the total score is 13, it means that within the 10 years, the person will have a 45% risk of developing coronary heart diseases. And then we can come back to teach the patient that if you treat your diabetes, treat your hypertension, taking care of your hyperlipidemia, then the disease can be prevented. And for example, if this risk score reduced to 1 or 5, then you can see a significant reduction in the predicted risk of coronary heart diseases. And this predictive model or the risk calculator are very important in the precision health. I will try to give you an example how we reduce the liver cancer mortality in Taiwan. And as you can see here, that's this is the 10 leading causes of death in Taiwan. The top one is the cancer. Cancer is the top one since 1982. And chronic liver disease used to be the number 6 leading cause of death. Now it's reduced to the number 9. And I will share with you also for this instance and mortality of top 10 cancers in Taiwan. The liver cancer used to be the number 1 cancer killer in Taiwan. And also here, this is the mortality. But after we implement some interventions, you can see that the liver cancer incidence and liver cancer mortality decreased very significantly. And what we have been doing is try to identify the cause of the liver cancer. And as you can see, liver cancer is quite prevalent in Southeast Asia as well as in sub-Saharan Africa. Before we know the causal agent of the liver cancer, basically we can do nothing. But when Dr. Brumberg identified that the hepatitis B, and we found that hepatitis B carrier rate is higher in the liver cancer high incidence area. And in Taiwan, Palmer Beasley, he carried out a very first and long-term follow-up study and published in 1981. He found that hepatitis B surface antigen positive, it means the chronic carrier of hepatitis B have much higher risk of primary hepatocellular carcinoma instance compare with the surface antigen negative people, showing a relative risk as high as 200-fold. It means that in Taiwan, most of the liver cancer are due to hepatitis B. So Palmer Beasley carried out a vaccine trial in Taiwan and tried to prevent chronic hepatitis B carrier among the newborn and giving the vaccine. And the control group, compared with the experimental group, we found that this immunization is indeed very important to prevent the transmission of hepatitis B from mother to child, and to prevent this vaccine can prevent the occurrence of the chronic hepatitis B carrier. So in Taiwan, dating back to 1984, we started our national hepatitis B immunization program, and up to now, the vaccination rate is quite high, or recently it's more than 95%. And in addition to the chronic carrier, for those who already been a chronic carrier, we try to carry out a cohort study to identify what are the major determinants for them to develop this HCC. And we found that hepatitis B E antigen is very important. Compared with the chronic carrier without the E antigen, those E antigen positive have much higher risk of liver cancer. And also, we found that the serum level of HBV DNA, the viral load in a chronic carrier, is very important predictor of the liver cancer. As you can see here, the higher the viral load, the higher the HCC risk. So we can use this kind of risk predictors to come up HCC risk predictors in Taiwan, and this including the viral factor, host factor, as well as this alcohol consumption. And from this risk calculator development, we have the collaboration with the Hong Kong group as well as this Korean group. And this is this example that how we derive the risk predictors. For instance, if we know that the gender, age, ALT level, E antigen positive or negative, as well as HBV DNA level, and we can give a very good prediction of this 3 years, 5 year, and 10 years risk of HCC. And you can see that the prediction curve under the AUROC is quite good. It means that this is a very good prediction. And we can use this kind of prediction to adjust and to see whether this antiviral therapy indeed can help the prevention of this HCC. So as you can see here, we collaboration with this Stanford University, and we found that for those who have the treatment by antivirals have much lower HCC risk compared with those without the treatment. And then this kind of HCC risk calculators were recommended by different hepatology society in the world. And also in Taiwan, we have this kind of liver cancer risk prediction model used in our National Health Insurance Administration. You just key in your risk predictors, then it will give you the risk of developing HCC. So in Taiwan, when we know that the important risk predictors of HCC are hepatitis B, and among the hepatitis B biomarkers, E antigen is important, HBV DNA is important, and also the ALT is important. So we can triage the patient into different groups. Some group for the antiviral therapy, some group for HCC surveillance. And in year 2003, we implemented our national chronic hepatitis B and hepatitis C antiviral therapy program. And as you can see, we have, after this year 2010, each year we have around 20,000 chronic hepatitis B carrier been treated by antiviral. And for the hepatitis C, we also have DAA used for the treatment of HCV. And I would like to show you that, as you can see, this this is the chronic liver diseases and cirrhosis mortality. You can see this for male and female. And after this implementation of the launch of the vaccination program, this you can see the liver diseases mortality did not decline. But after this launch of the antiviral therapy, we can see a very significant decline in mortality from liver diseases. And this is for liver cancer mortality and hepatocellular carcinoma instance. And you can see after this vaccination program, there's a decline in HCC mortality and also a decline in HCC instance. So I would like to share with you that for the vaccination, this is unvaccinated cohort, and this is after the vaccination program was launched 30 years after 30 years. And you can see that liver diseases mortality, HCC mortality, and HCC instance all decreased around 50%. And this is for the antiviral therapy, and this is for the vaccination. This is a post-vaccination cohort. You can see around 80% reduction in liver cancer mortality and also the HCC mortality. So this is the way we try to identify the cause of the diseases and to have a good prediction, and then we can implement a good precision health program. And as just mentioned, that Taiwan's healthcare system was ranked as this by Numbeo as the #1 in the world. And in Taiwan, we have around 480 hospitals and over 18,000 primary care clinics. So we try our best to implement good intervention and good health care for the people in Taiwan. And this, we have world-renowned high quality and also the efficiency and high volume of services, and each person visits a hospital or clinic 15 visits, and highly managed and competitive healthcare system in Taiwan. And in our national health insurance, we try our best to use smart technology and to set up this MediCloud system, including a different kind of a system there. For example, this is a medication record within the last 3 months, and surgery records, and so forth. And use this kind of NIH MediCloud system, and then we can have a cost saving and also the resource sharing, as well as ensure patient safety. And we can reduce the unnecessary testing or examination and use this kind of PharmaCloud. You can see there's the duplication of drug prescription for schizophrenia and for antihypertensive decreased significantly. And in addition to this the entire system and each individual in Taiwan, because we have a national health insurance smart card, so every citizen in Taiwan can apply for My Health Bank, and then in the My Health Bank, and every person can check their 3 years of medical data and health information displayed in diagram to enhance the readability, and also they get that's an educational guidelines. And these are the contents of My Health Bank. For example, this is the 3 years of medical data. This is the CKD prognosis and dental notion illustration, and also hyperlink to health education website. And through this kind of precision health, we try to give a better management of non-communicable diseases in Taiwan. And in 2020, precision health industry was regarded as the 6th core strategic industry in Taiwan. And we try our best to promote this transform our healthcare system using the digital technology with the aim to improve healthcare quality and promote health, and to feed high volume services of medical need, and to improve administrative efficiency, as well as to facilitate our medical industry nationally and internationally. And Taiwan have very strong biotech industry, and we try to use our own this smart technology to promote the biotech industry in Taiwan. And there are several key initiatives for this digital healthcare, including the artificial intelligence, blockchain, cloud system, data, big data, edge computing, and fifth generation 5G mobile phone, as well as the gene bank. And as I just mentioned that every Taiwanese hold a national health insurance and smart card. So NHIA can use that for data management and also, for example, for infectious disease tracing and monitoring. And we use this smart card to give each healthcare provider have authentication, and then they can easily have access of this information. And this is I think this is very important for all the hospitals and clinics because they have adopted electronic medical record for 20 years. And this data can give the patient a reminder and to check whether there's a duplication, and also give the patient their vital signs, allergic, and so forth. And this well-established Medicloud system is very important for the healthcare data exchanges in hospital in Taiwan among the hospitals, hospital and clinics, and also the individual can check their own data as well. And all medical images in Taiwan have to upload to Medicloud within the 24 hours and sharing with other providers, and also reviewed by artificial intelligence, including the CT scan, MRI, endoscopy, imaging, X-ray, ultrasonography, and even X-ray of teeth. And this kind of integrated biobank and genomic and imaging database are very important for the precision health. And in Taiwan, in our National Health Insurance Research database, we have the biobank platform. We collect the data as well as biospecimen from 30 biobank medical centers in Taiwan. And also we have the genomic database and as well as the imaging database. So we can integrate and fully use the statistic with the standard format and public-private partnership model. And this slide shows the Taiwan Biobank in different hospitals, and we already recruit more than 200,000 residents in general population, and also recruit the data from the patient and try to use that for precision health prediction. And in the future, we try to use these biomarkers and multi-omics and to incorporate with the health data cloud to engage in preventive medicine, predictive medicine, personalized medicine, and participatory medicine. And in the future, wearable IoT physiological monitor devices will collect more and more data, and customize the smart home or self-health monitoring are also important for us to get more individualized data, as well as this genomic data in the future. So in the near future, each individual will be surrounded by a virtual cloud of billions of biosignatures, and along with the rapid development of multi-omics, wearable physiological monitor device, smart home monitoring, and environmental toxic substance surveillance. So we can use this artificial intelligence to analyze this health data and then try to help us to optimize wellness and minimize the diseases using this kind of precision technology. And also, it will transform the healthcare practice over the next decade, moving it from this provider-driven reactive disease treatment model to this consumer-driven proactive health promotion and disease prevention model. So this is not only done by the government, it also has through this public-private partnership and my health bank data can be used by the third party and to do more value-added services. And this is this digital healthcare from Taiwan to the world. And our strategy is to complete our ecosystem for the precision health and including this digital healthcare based on our national bio database and national R&D energy, and then try to foster the supply chain and to encourage the application solution and also connect to this global market. And we try to help and also to collaborate with all these health sectors in the world. And through this, we say that Taiwan try our best, will be the best partner for the digital health industry cooperation. And we have strong medical profession, academia, and industry cooperation, and enhance the medical practice and patients' health, and also the international brands for ICT and biomedical products and government support. I think this, for the NCD control, precision health is the way to prevent the occurrence of the NCD and have a personalized treatment of the NCD. And I would like to conclude that the important components of precision health include this preventive, predictive, personalized, and participatory medicine, and risk calculators can be developed and international validate for the risk prediction of NCD to help promote primary, secondary, and tertiary intervention of NCD. And high-impact essential NCD interventions can be delivered through a primary healthcare approach to strengthen early detection and timely treatment using smart technology of e-health and telecare. And such interventions are excellent economic investment because they can reduce the need for more expensive treatment. So in Taiwan, we try best to have a better control and management of NCD, and through this, the effort of precision health. With that, I would like to conclude my talk. Thank you very much for your attention.
Thank you so much to Dr. Jianren Chen. 非常谢谢前副总统陈建仁院士的精彩分享。再次谢谢陈院士。Thank you so much. All right, ladies and gentlemen, next to talk about how the EU is preparing itself for global health and aging society. Please welcome the last speaker this morning. We have Dr. Clemens Martin Oyer, President of European Health Foundation. Please welcome him. 掌声欢迎我们接下来的专题讲师，加斯坦欧洲卫生论坛的主席 Clemens Martin Oyer.
Thank you very much for the nice introduction. I'm pretty much aware that I'm standing between you and the lunch break. Ladies and gentlemen, Excellencies, I'm here in my capacity as President of the European Health Forum, but I'm also speaking in my many former functions. So to say, I was the Director General of the Ministry of Health in Austria for a long, long time, responsible for more than 30 billion euros of public health expenditures. And I was also vice chairing the executive board of the WHO. So I have a lot of experience. I'm from the policy side, not from the science side, you know. A lot of experience on the global aspects of health and the regional, the European Union, national and local. And as such, I always was very much interested in close cooperation and collaboration with Taiwan. And in the last 24 hours I'm in this country, I have even been more convinced how important it is to internationally cooperate and support Taiwan. Because I think Taiwan, and we have to say that coming from the outside, is a beacon of liberal democracy in this not so easy geopolitical corner of the world. And you are upholding human rights, women's rights, gay rights, and health in all policies, so to say, and connected with the title of this conference, you're also championing of the notion that health is a human right, you know, and this is, I think, very important. I'm here to talk about the European Union and its role in global health. And let me start with a question. What would you call it when someone, a person, an institution is doing a fantastic job in the respective field, but nobody knows it, nobody talks about it? I would call it bad communication. And I think this is absolutely true for the European Union and its 27 member states and the European Commission. And I give you another question, you know. I'm from the policy world, so to say. Who is the largest donor, payer, contributor when it comes to global health programs? And I think somehow we always have this intuition on this reflex that it might be the United States of America. But that's not true, friends. That is not true. I can tell you that Germany alone is the larger donor when it comes to WHO programs. Germany, you know, I'm not a German, so I can say that, you know. I'm German speaking, but not German. You know, in the biennial budget for the World Health Organization, Germany alone was spending or paying 1.2 billion US dollar versus 660 billion of the US. So once again, you know, Germany, the other 26 member states and the European Commission combined, we are by far the largest contributor when it comes to global health programs. I give you another example, you know, the World Health Organization, and I'm a strong believer in the World Health Organization, is notoriously underfunded. And also here again, you know, and we learned this lesson very much during the COVID-19 pandemic crisis. But there was one fact, you know, the assessed contribution by the member states of the World Health Organization only scaled up to 16%, 1/6, not 60, 16% of the program budget of the World Health Organization. And I think we, the member states of the European Union, we, especially after this, after the experience we had with the COVID-19 crisis, and WHO was not able, I'm not criticizing it, it was not able to fulfill their expectation. We came together and had said, you know, we have to stop that. And it was the European Union which was really pushing hard, and the last World Health Assembly in May voted it in to increase the assessed contribution to at least 50% of the program budget for the World Health Organization. I think that was a big quantum leap. And in the beginning, this discussion we had in Geneva about this topic was very critical, because many member states didn't want to follow us in that way, in our leadership role in that way, especially, once again, the US was very skeptical, but also larger countries, like Brazil and many others. I give you another example, you know, where the European Union really tried to exercise global leadership when it came to the COVID-19 vaccines in the late 2020 and 21. I'm very self-critical about it. You know, we all could have done a much better job, you know, and I was co-chairing the vaccine drive, you know, the purchasing drive for 450 million Europeans. So maybe I'm also one of the guys who made a problem, you know, when it came to empty out the world market for vaccines. But let's focus on some other aspects. You know, once again, you know, I'm very self-critical when it comes to the failures in this whole vaccine thing. But on the other hand, you know, if you look at the market reactions, you know, India, for example, or the United States of America, again, closed the borders when it came to exporting vaccines or parts for the productions of vaccines. You know, I have to be frank and open, you know. China was playing the People's Republic of China, not the Republic of China. The People's Republic of China was, you know, propaganding all the time that they are supplying the world with vaccines. But friends, China only donated 10% of all the vaccines to the world. The rest was sold to a fairly high price, by the way. The same happened with Russia and their wonderful Sputnik vaccines nobody wanted. And here again, you know, the European Union, from the very beginning on, we made it very clear that whatever is produced on the European soil is shared with the world. We always, from the very beginning on, 50% in the beginning of 2021 of the vaccines produced in the European Union were exported. And I think Martin McKee already made some critical remarks, and when it came to COVAX and the ACTA program, no, they delivered, I don't have the exact number now, but I think in the beginning of 2022 it was more than 1 billion doses they delivered to the rest of the world. But you'd never find in the documents of COVAX and Gavi that at least 60% of all these vaccines were donations by the European Union. You know, excuse me, you know, I have to say this because sometimes the whole truth is not told. Ladies and gentlemen, we also learned during this pandemic crisis that the international health regulation has proven to be inefficient. And we do need a new legally binding instrument, I think, and Martin McKee was laying it out very, very eloquently. And we do need this instrument for better preparedness, prevention, and response for if we are getting in the same situation of a public health emergency of international concern. And Europe and the European Union pushed very much to start this intergovernmental negotiation process. And I don't want to get into the details, but I have to be very frank here. The success and the measure of success for this adventure of this intergovernmental negotiation will be that, you know, I'm coming from the rich part of the rich corner of this world. You know, we have to overcome, and I'm saying that to the dear ministers and friends from not the rich part of the world, the test will be that we have to overcome the mentality of charity and start a time and a period of empowerment. This is what it is about, you know, and if we cannot agree on matters in this intergovernmental negotiation process and not finding the legally binding instruments for this empowerment instead of charity, we are failing and we are betraying the world again, the people, not the world, the people of this world again. So we all, and you know, once again, I'm from the club of the rich countries, you know, but this is especially true for the global south. We do need investments. We do need investments. You know, we within the European Union, because we never wanted to detect ourselves or be in a situation that we are ill prepared for a pandemic situation, so we founded this instrument. It's called HERA, Health Emergency Response Authority. But behind this is to have an instrument which really does, in a private-public partnership collaboration, the best to prepare ourselves. And there's a lot of money attached to that. There's 30 billion euros for the next 5 years. So that's really big money, you know, to guarantee supply chains, et cetera, to have these public-private partnerships when it comes to better preparedness. But friends, if we are not capable of having similar instruments like HERA in the global south, once again, we are failing and we are betraying the people and the global south. You know, once again, I'm very self-critical. It took a very long time that European companies started to fill and finish vaccines in Africa, for example. Too late, too little. Too late, too little. But still, this is what we have to learn about the pandemic crisis, and this is what we have to do much better. You can ask, you know, why are the member states of the European Union and the Union itself are doing all this? Because we are deeply convinced of multilateralism. Europe is defending multilateralism. And multilateralism is a solution. It's a solution to tackle One Health issues we have so eloquently heard all about this morning. And this is, you know, we have to work against isolationists, nationalists, because they don't deliver the answer when it comes to a better world for tomorrow. So this is why the European Union is defending this multilateralism. And we have learned from our own tragic history in Europe that working together is the only way out. And this is especially true when we look at our times of perma-crisis. Someone said polycrisis. No, it's a perma-crisis, you know. Now we have a war again in Europe. This is all these ugly siblings of war, you know. We have an environmental crisis. I don't have to repeat that. And fiscal crisis, food crisis. And all this has a very, very negative impact on health and when it comes to the notion that health is a human right. Let me briefly touch the second topic of my little intervention here. It's about the fact that Europe is an aging society, and that is very important to keep in mind when we talk about well-being, health and well-being. I'm part of this problem. Look at me, I'm baby boomer generation, and my whole life I have always experienced once, you know, that we are many. Many in schools, many in the universities, you know, many in the job market. And now we have I personally have another experience that we are many when it comes to the need of nursing and care. And I have to tell you that Europe is very ill prepared to tackle that. Very ill prepared, like many other parts of the world, but Europe especially. And I would say this is one of the challenges, you know, we talk about well-being here of a society. This is probably one of the number one challenges when you look at the healthcare delivery system per se. And the answer is, and the WHO gives this answer, and many of you, and I think probably also in Taiwan, all the policies are geared into this direction. The answer is primary health care. The answer is a strong primary health care, because we are noticing that people are ending up at secondary and especially tertiary care, you know, in hospitals where they are not, where people shouldn't be there. So it is about new forms of primary health care, interdisciplinary, interprofessional, because it's not only about medical care, it's also about life care, nursing, social care, etc., etc. And Europe, once again, is very ill prepared because, you know, the traditional way to present or to exercise primary health care is still in single doctor offices. And that's not working, because a medical doctor is trained to deliver medicine, to do medical work. But he or she is not a nurse, he or she is not a social worker, and all these life care elements are very much important for efficient primary health care. So we have to build new primary health care infrastructure. In my home country alone, we are investing in the next 2 or 3 years 500 million euro. There's also funding from the European Resilience and Recovery Fund after the pandemic situation, because it is really important to invest in that sector. But let me come to another critical point. If we simultaneously are not looking at our health workforce, we are failing again. And we are not delivering, as a policymaker, I have to say that we are not delivering what we should deliver. And we have to train and invest into a new generation of healthcare workers. They have to be better trained. We have to look at the better work-life balance. We have to ease them from the burden, from the daily burden they are suffering from. And we have to work against this notion, and I was at the conference, which the title was The Grand Resignation, the grand resignation of the global health workforce. And I think that is an accurate title, and we have to think about it. You know, why are so many people working as healthcare workers leaving the sector? Because they are burdened by too much work. Let me close. I can guarantee you that the European Union is a strong partner in global health. It's committed, and this is the policy line in almost all the 27 member states, committed to strong multilateralism. And here I would like to contradict Martin McKee a little bit. Global health is not a matter of G7 and G20. Be aware of that, because it is about inclusion, it is about transparency, and it is about integration. I'm from a wealthy country, you know, but I'm not part of G7 and G20. And I also have to be part, my government has to be part in global health initiatives and global health programs. So the only answer is, when you talk about global health, to strengthen WHO again. Because this is the only organization, the only agency where all the member states sit equally at the table. And this is not true when it's reduced to G7 or even G20. So we have to sit at the table. And this is my last remark. We are working hard that Taiwan is also sitting at the table when it comes to the World Health Organization. And I'm optimistic that we are getting there. Be a little bit patient, and you have heard that for many, many years. But without Taiwan sitting at the table, we don't talk about global health. Thank you very much.
Thank you so much, Dr. Clemens Martin Oyer. Taiwan will be a part of the global health community for sure. Taiwan can help. Thank you once again. Thank you. 再次谢谢. All right, ladies and gentlemen, that's it for our morning session. And please give all of our speakers this morning another big round of applause for their valuable input. 再次谢谢我们上午所有的讲师哦. And next, we're going to have lunch, but we are very sorry that we only have 40 minutes for you because we want to give you the most out of the very limited time that we have in these 2 days. So please bear with us. So follow our staff to the dining areas outside. We have lunch boxes ready for you. And when you come back, we are going to delay our afternoon session for 10 minutes. So we'll be back by 1:10. 10 minutes after 1 o'clock this afternoon. Thank you again. 再次谢谢各位贵宾。那接下来呢，是我们午餐用餐的时间。不好意思，我们2天的议程呢，非常的紧凑哦，所以我们今天午餐用餐时间呢，只有40分钟。不好意思，要请各位贵宾呢，接下来可以跟随我们工作人员的脚步到外面的用餐区领取餐盒。Enjoy your lunch. And if after lunch you still have some time, we have an exhibition on the 10th floor showing some AR, VR solutions and assistive devices. Feel free to pay a visit. Thank you again, and we'll see you in the afternoon. 那大家午餐用完，还有一点点时间的话呢，都欢迎到10楼参观我们的展览哦。我们要展出一些新的 AR、VR 以及辅具，都欢迎各位贵宾呢前往参观。Enjoy your lunch. We'll see you later. Thank you.
所以讲的时候我事实上可以看到这个，对不对？下一页是哪一个？哦，这个就下一页。下来了吗？目前没有，就是这个。我不知道，下午的呢？我帮你确认。下午的会不会？对。会需要确定要。我不知道，像早上都3个。
张荣发的同事在吗？可以帮我把中间的布幕放下来吗？中间的。 请问张荣发的中控室人员在吗？可以把中间的布幕放下来看一下吗？会挡到。panel 的时候，就是综合讨论的时候才会。
他要来演讲，他要先试他的那个。
好。
玉安来。来。
桌上。
这个等一下的讲者要试一下他的 slide， 然后把先生。
And the microphone also. And I will go to display your slides.
So you already.
Yes, I have received. I'm waiting.
啊？对啊，他马上要移，等一下。
现在有人可以帮我重剪吗
？Baby， 你去帮他。
对，一张茶几，
带一张沙发。那边还是会挡到，对不对？
我刚刚这一张也不，
对。
到时候再移吗？还是怎样？
还是就3张。
那这边就没法放名牌，就不管了。
他的可以放，对。
没有啊，那这个人呢？这个人要怎么放？
那这2个交换。
交换。
好。那边就会比较不会这么。也可以，如果你们可以接受他桌子放前面放3张，哦，好啊，也可以。好，好。对，我们会上麦克风跟桌牌，等下就摆好。那就是 不是，可是 pan 因为它不会挡到后面的荧幕，在中间会挡到，然后它是 panel 的时候它上来这个会升上。那这个就对。
这边只会给一支麦克风。
没有，他等下会拿，不要急，好不好？对。
啊，杯水。
杯水，等一下。
中控大哥，不好意思哈，等一下就是 panel 就是 discussion 的时候，讲者会上台，就是右手边这边。那这边的时候，就是开始的时候，这个荧幕就帮我们升上去。OK。就是综合讨论的时候。没有，就在这一边现在的位置。所以这个后面这个布幕，到时候综合讨论帮我们升上去啊，就是主要是前面投影灯要帮我们关掉。哼，没关系，因为他们在中间，原则就是会挡到这个大荧幕。有综合讨论有。对，就是综合讨论就是这两个，啊这个上去，关掉。
Ladies and gentlemen, please take your seats. We'll begin in 1 minute. Thank you so much. 各位贵宾，请您就座喽。我们下午场呢，再过1分钟之后就要正式开始了。谢谢。Okay, everybody, welcome back, and we hope you all have enjoyed your very quick lunch. Thank you again. 非常欢迎各位贵宾呢继续回到我们的会场哦。This afternoon, here in the session, we are going to talk about health promotion strategy on NCD, echoing the Geneva Charter for Well-being. 那我们下午的第一个平行场次呢，重点是要探讨慢性病健康促进策略。呼应日内瓦福祉宪章。那首先呢，我为各位介绍我们场次的2位主持人，请他们为我们的场次来开场哦。And let me introduce to you your 2 moderators for this session. We have Professor Hong-Yi Cho, Director of Institute of Population Health Sciences from the National Health Research Institute, Taiwan. 首先呢，是国家卫生研究院群体健康科学研究所的所长邱宏毅教授 ，and also Professor Zhi Chengxu, Deputy Director, Institute of Population Health Sciences, National Health Research Institute, 以及呢国家卫生研究院群体健康科学研究所的许志成副所长。Now, please join me in welcoming your moderators. 那接下来我们就掌声欢迎我们的主持人为我们开场。
Good afternoon, our distinguished participants in this conference room. It's our honor to host this afternoon section 1B, and our title is Health Promotion Strategy on NCD, echoing the Geneva Charter for Well-being. And as you know, the Geneva Charter for Well-being underline the urgency of creating sustainable well-being society, committed to achieving equitable health now and for future generations without breaching ecological limit. Well-being requires a whole of society approach involving action across all levels, stakeholders, and the sector, from community and the winning organization to regional and the national government. And the role of the health promotion is to catalyze and support this movement by ensuring that the people and the community are enabled to take control their health through education, health literacy, meaningful empowerment, and engagement. And we also enabling, mediating, and advocating for a unifying approach to creating well-being society by shaping the determinant of health in all settings. And we know, following the release of the GBD, Global Burden of Disease study finding in May 2000, and the WHO 52 World Health Assembly passed resolution WHA 51.18, calling for implementation of the global strategy for the prevention and control of non-communicable disease. And most of the resolution and the global strategy focus on we so-called the big 4 disease, including the cardiovascular disease, cancer, and the chronic pulmonary disease, and the diabetes. And also the 4 prominent risk factors we know: the tobacco use, alcohol use, abuse, unhealthy diet, and physical inactivity. And this is the WHO 4x4 framework as published in the 2018. So this is our meaningful to talk about this topic. And in Taiwan and the world, diabetes is the most important NCT in every country. In Taiwan, in the morning topic, we know DM now is the fifth top leading cause of death in Taiwan. And we know the diabetes highly correlated with the CVD, CKD, stroke, and this disease might be highly associated with the frailty and the disabled. And if you look at for the prevention outcome, you can see diabetes was caused by the physical inactivity, unhealthy diet, and also increasing the obesity about the whole society. So this is a very important disease in the NCD. So why we talk about these topics? And we are very happy we have the 3 very important, very world well-known speaker from America, Japan, and Taiwan. And I will introduce our first speaker, Professor Padmini Mursid. She is the professor and the director from the Department of Public Health and Global Health, and also director School of Health Sciences and Practice from New York Medical College in the United States. And she also the Global Health Lead, American Medical Women's Association, and the chair of International Health Section, American Public Health Association. So let's give the big part to welcome the Dr. Padmini Mursid to talk about the ongoing global health crisis. Welcome the Professor Mursid.
Thank you so much for having me. It's really an honor. And one of the things I just want to say, as we're having this global, thank you. Thank you so much for having me. Good evening, good afternoon, good night. We are from different time zones. Thank you so much for having me. It's always great to come to Taipei. And it's so nice that we are face to face after 2 years. And it's nice to see all the old colleagues and meet the new ones. I just want to say, as we are having this very important global health forum, the non-communicable diseases or chronic diseases are increasing by leaps and bounds, and diabetes is a major challenge. So I am just going to, you can see what my objectives are. I'll be briefly discussing the global health crisis because of diabetes and the contributory factors. And unfortunately, during the COVID pandemic, this has increased because people did not have access to get their medication or even go for checkups because everything was at the bottom of the rung. So this has been a major challenge. And we are talking about good health and well-being, SDG 3, which is I think one of the most important SDGs, and it's a driver for the others. But how can we have good health and well-being and hope to achieve the 2030 agenda of leave no one behind when we have so many people suffering as a result of diabetes? So moving on, we can see that this is like the International Geneva Convention for Good Health and Well-being. One of the issues here are, as you know, our esteemed moderator just presented, this is a major challenge, and the former Vice President, His Excellency Dr. Chen, presented, NCDs are exploding. And I would just like to bring one thing to the attention of all the esteemed guests, excellencies, ministers, colleagues, friends, that because of we are forgetting one thing, long COVID is a major issue. That is also an NCD. It's contributing to diabetes too. Because I know personally from some of my physician colleagues in the US, some of the patients who did not have diabetes after COVID, 6 months to 1 year have developed diabetes. So this is a major issue. So this is something when we are talking about preventive strategies, we need to be thinking about that. So again, I just have this infographic up because it was really nice and it's worth 1,000 words. But one of the things I just wanted to say is what is the importance of the Geneva Charter? Because this was so important as it outlines 5 key actions, is to design an equitable economy that serves human development within planetary boundaries. It sums up the inaugural speaker who talked about the environment. So again, diabetes is both dependent not only on genetic factors, but the environment and what we push in to the mouths of the children too. Because one of the issues is we have such unhealthy lifestyles because caloric-rich food is cheaper than healthier food. So this needs to be a multifactorial campaign where we can really prevent the increase of diabetes and have secondary prevention where we control the damage. So again, that fits into the create the public policy, universal health coverage, and the digital transformation. And the esteemed former vice president talked about digital transformation, and Taiwan is really a leader in this. So that's some lessons we can all learn from that. So this is like really the sad part, that when we are talking about the control of NCDs, it looks so nice here, but again, how much of it is actually being put into practice, because we have so many issues. We've had a lot of financial crisis because of diabetes, because of COVID, increased diabetes, and all the NCDs. So it's like, unfortunately, the infectious diseases, I'm just going to talk only about COVID, because of long COVID, have become now a chronic disease. So what do we do? And this, the last part, ladies and gentlemen, is the last 2 slides. 50% of eligible people receiving drug therapy, a lot of times they do not have drug therapy. And I can tell you the supply chain has also affected the availability and access to these important medications. And 80% availability of the affordable basic technologies and essential medicines, these are not available. So again, when we are talking about meeting the objectives of the Geneva Charter, promoting the targets of good health and well-being, we need to start looking at a multi-pronged approach. As a physician, when treating a patient, a lot of my physician colleagues, we look at a multi-pronged antibiotic approach till you get the diagnosis. The same thing, we have the diagnosis here. It's diabetes, it's hypoglycemia, and it is also pre-diabetes, especially in pregnant women. So we need to see how can we address this, not only through prevention, but also make sure there's policy and there's inclusion. So the WHO has come up with the Global Diabetic Compact to really address this, because there are a lot of major issues. And at the 75th World Assembly, the 5 new targets set the standards were that 80% of people living with diabetes are diagnosed. And I just want to tell you the recent statistics from the International Diabetic Federation, especially in the Asia region, which has some of the highest diabetics. And as we speak, a report released in December says that 90 million adults, please note, between the ages of 20 to 79 are living in, with diabetes. in Southeast Asia, and this is expected to go to 113 million in 2030. That is when we finish with this agenda of SDGs and come to the leave no one behind. And unfortunately, again, to add to this, 46 million adults living with diabetes in the area are undiagnosed. So it just adds, this gives more juice to what I just said is, and if you are undiagnosed, how can you have a good control of your diabetes or prevent hyperglycemia or hypoglycemia? And again, this is another issue when we are talking about non-communicable diseases or chronic diseases. It's just not that it's one disease, because a lot of people with diabetes have also hypertension and more prone to other systemic damage, as we know. And one of the goals is 100% of people with type 1 diabetes have access to affordable insulin, and this has become really hard. So this was passed by the core part of the work requested by the member states in a resolution, as I said, at the 75th World Assembly. This looks so nice on paper, but we need to make sure at least we can reach most of it. So I say that access to diabetes, to insulin is a human right. And we are coming up in less than 2 weeks. We have the World Diabetes Day. It's on 14th November. It's observed as World Diabetes Day. And why do you think I have that is access to insulin is a human right? Because in so many populations, women are denied the right to have medication, because the gender inequity comes into play too. So that is why when we are looking at making sure, in the previous slide, one of the goals, providing insulin to everybody, we need to put in the human rights component, because some of my colleagues and I, we look at everything as a human rights issue, because we need to ask why is it equitable and what can we do, and also factor in the gender, because women are more at risk when they are pregnant if they are not diagnosed, if they're undiagnosed diabetics, and then there is also increased maternal mortality, morbidity, infant mortality, and morbidity. So again, this is a major issue we need to be concerned about. And then we have grassroots efforts, like this was, in the US Congress, like there is an Affordable Insulin Act, which is going to be hopefully passed, and then people will have more access. And then this is the very scary part, ladies and gentlemen. You see that this picture, you can see the high percentage of diabetes in certain parts. As you can see, the Asian region has the maximum number of diabetics. And the contributory factors are also genetics and the food eaten, lack of access. And I would like to just bring in, at this point, health literacy. And I don't know if Dr. Peter Chang is here. Yeah, he just had a fabulous health literacy conference. And one of the issues is it's the communication. How do you tell people it's important? They need to understand what do you need to do to make sure your health doesn't get worse. Because one of the key factors in diabetes management is also secondary prevention from making it worse and affecting the other organs and leading to systemic failure. So this is March of Diabetes. Like we have the March of Dimes in the US, where it is, to reduce neural tube defects, where we all march and collect dimes to make sure that pregnant women have enough of vitamin B so that they do not have children with neural tube defects. But look at this. This is a really, these are just not numbers, they're actual people. So this is the March of Diabetes. As you can see, how many diabetics are around. And I'm sure if we have this talk a year later, this would be added up, and we don't even know how many other people. And this is the scary part, as you can see, that there's a 156% increase. It is not 10, it's not 15, it's 156. So this is really a global crisis. World Diabetic Day, and then, so this is infographic just shows that what is important. I'm hopefully going to be able to play this video here. Can you help me to hyperclick this video, YouTube video? Because I have no mouse here, how do I play this? Or can you play it for me? Thank you.
桂格大燕麦片，天天吃，降低胆固醇，战胜体脂肪。
When did you last learn more about diabetes? Today, diabetes affects over 500 million people worldwide. That's more than the population of the United States, Canada, and Mexico combined. Almost half of people with diabetes do not know they have the condition, putting them at increased risk of life-threatening complications. The rising tide of diabetes is putting healthcare systems and healthcare professionals under increasing pressure and preventing people with diabetes from getting access to the care and education they need. For more than 95% of the time, people with diabetes are looking after themselves, so they need to understand their condition and know how to manage it. Healthcare professionals need to make the most of the limited time they have to provide the best possible advice and care. People living with diabetes and healthcare professionals need to keep their diabetes knowledge up to date. Diabetes education can help stop the rise of diabetes and prevent its complications. Access free diabetes education today to protect tomorrow.
Thank you. Can you stop that, please? Thank you so much. So one of the things I just want to talk here is this is an issue, the malformations. And unfortunately, the culture in so many societies also is a contributing factor to the increasing diabetes, especially among women. And as I said, the lifestyles like eating sweets and so many calories of calorific foods because they are cheap. And if somebody comes, you want to give them, you feed them. It's like I grew up in India. So I remember when we were children, if any guest came home, my mother would tell the cook to make at least like 5 sweets. Then we would love it. But now I'm thinking like, Mom, you were educated. What's wrong with you? Why did you have so many sweets given to people? Long story, it is the culture. So we need to work positively with the culture to just say that modifying what you eat, modifying it with no sweet, or instead of having like a cake or ice cream, have fruit. So again, it's how we do it. And health literacy is very important because it tells the population what are the foods with a low glycemic index. Choose brown rice over white rice. So these are the simple things which we all need to, as healthcare professionals and concerned citizens, to get the message across. And this is like really a major issue because women are at the receiving end, and 2 out of 5 women, as you can see, with diabetes are in the reproductive age. And if they're not diagnosed, it adds a worse burden, as I said, due to the various issues. And then, so this is diabetes, gestational diabetes. It is on the rise globally, and 1 in 7 births, these children are affected. I trained as a gynecologist, and I can tell you that it is very hard to manage a big baby, as we call it, macrosomic baby, if it's not diagnosed before, because if the woman cannot have access to a cesarean section, secondary medical care in the primary health care center, oftentimes she has a lot of trauma. The child can break its shoulders when coming out because the diabetic babies are big. So all these are issues, and you don't even know that sometimes. So this is a big, big problem. So again, prevention, and then, precision prevention is so important, and messaging is crucial. So these are some of the interventions, as I mentioned. So this is a partnership, this Venn diagram between the insurers, the employers, like you have information which your employees can understand, have a structured lifestyle, reduce stress, easier said than done, diagnosis of pre-diabetics is crucial, and activated patients need to be informed. And one of the things is, just because somebody is diagnosed with diabetes, it's not a death sentence. We need to get that message that you can still work to reduce the effects, the horrific effects of diabetes on your system. So just finishing up, I just wanted to tell you that these are some of the things which are being done in the US, where the state public health actions like our CDC, like you have here in Taiwan, we talk about the states are involved too. So this is an ongoing partnership between the states, the various states in the United States, and the Center for Disease Control. So this is the partnership where, to meet the targets of SDG 3, we are talking about SDG 17, which is promoting partnerships at many levels. So COVID, as I said, this is a major issue. This is from the British Medical Journal. It was just published a few months ago. And this is a very nice diagram where it shows why it's important to have diabetes care preparedness cycle during epidemics. As I said, that patients don't have access, so what do you do? So whenever we have an emergency preparedness in place, we need to make sure we include a plan to address these non-communicable diseases or chronic diseases. Otherwise, it will get worse. So what are some of the challenges during COVID? We had 9 and 10 younger adults. This is scary. They did not keep up with their appointments. And then you have to go to 911 if you have symptoms which are really troublesome. Get a COVID vaccine, because it also, the problem is when a patient has diabetes, it weakens the immune system. So you want to make sure they are up to date with their vaccines too, so that you reduce that. So just finishing up, SMART is an acronym we use, is specific, measurable, achievable, realistic, and timely. So we tell our patients to come up with the SMART goal, like not something like you cannot run a marathon the first day you start. So step by step, what to do. And the main thing we say that you have to measure also what your glucose is, chart it, because not everybody has access to the new sensors, which are more expensive. And if your insurance doesn't pay for it, or you can't afford to pay for it, so still a simple finger stick test is important, and to make sure they have it. And again, these are all the different technologies available to address diabetes. So we need to make sure people are aware and there is access. So what do we do as a global community? We need to work together. As I said, lifestyle changes are important, and use of metformin, health policies where you do have less sugar-sweetened beverages. And I can tell you, in New York City, I'm from New York, a couple of years ago, there was a policy passed in schools. They avoided sugar juices. So because a lot of children get their food from the school cafeteria, lunch is provided, so there was a reduction, and they replaced those sweetened sugary drinks with fruit. So these were some of the steps taken to, promote healthier lifestyle. And this is the most important thing we need to do, is to have a healthy environment. So that environment is at home, it's on media. It's so important that we need to have these kind of messages, the simple steps which people can understand. What do you do? And there are some apps and cartoons created which show children how to lead a healthy lifestyle. And even in New York schools, they sent home cards with what healthy diets was, because we have a big immigrant population. Not everybody understands English. So these pictorial cards were really useful. So these are some of the things which are done and are being done. So these are my references, and thank you so much. And we are all in this together, and we really need to address the big D in the room, which is diabetes. Thank you.
Thank you so much to Dr. Padmini Murthy for your talk.
If you have any question to discuss with the Pandemic Mercy Professor, we have a 30 minutes panel discussion after the three topics, okay? So now we move to the second topics about the diabetes advocacy for well-being in Asia. And our speaker is the Professor Masa Junba. Junba Sensei is the professor and the chair of Department of Community and Global Health, Graduate School of Medicine, the University of Tokyo. And Dr. Masa Junba, his research is very broadly cover the health promotion, global health, human security, and the public health issue in the world. And from 1994 to 1996, he worked as a WHO health coordinator for the Gaza Strip and the West Bank. And from 1996 to 2001, he works in the rural Nepal as a team leader of the school and the community health project by the Japan International Cooperation Agency and the Japan Medical Association. And then he come back to the university and do a lot of the health promotion project and research cover the Asia, Africa, Latin American. And now he is the president of the Japan Association for International Health and also the immediate past president of the Asia Pacific Consortium for Public Health. Let's give the big applause for welcome the Professor Masabin Junba.
Liho. I'm very pleased to be here today after 3 years of absence in Taiwan. And finally, I could come here. And I was planning to test your knowledge about November 14th, but in the previous lecture, you already learned. So I'm just testing your memory about November 14th. What is this? Maybe you know. World Diabetes Day, 14th November. And from 2021 and 23, they had a special theme, access to diabetes care. So we are in the middle of this theme. Then another question, 3 days after November 14th, what day is this? Maybe nobody knows. This is my birthday. So if you remember this, please send me your email to me to congratulate my birthday. And this is the birthday for my retirement age in the University of Tokyo. So this is very special to me. And my topic for today is diabetes advocacy. We've already heard some activities in the United States and in the world. So these are 3 contents, advocacy in the world, in Japan, and for Asia. So you've already seen these messages in video. It shows 100 years after its discovery of insulin, millions of people with diabetes cannot access the insulin they need. And many, 3 in 4 people with diabetes live in low and middle income countries where I used to live and work. Then more than 90% of diabetes care is self-care. This is very important because people need to be aware of the importance of their own care. Then the last one. 90% people will have diabetes not 19, 10% will have diabetes by 2030, within 8 years. And you may be one of them. So we need to update our knowledge. So I want to briefly introduce you the history of diabetes advocacy. And it is defined like this: to increase public awareness, to raise funds, influence policy, promote optimal individual outcomes. Particularly for advocacy, the term influence is very, very important. This is a keyword for advocacy. And this is what I learned in Taiwan from Michael Moore from Australia, not a movie director. Then International Diabetes Federation, it also said keyword influence. And also, they said stop discrimination is very important. And this is keyword of my presentation today. How can we stop discrimination against people with diabetes? So again, this is a day when Dr. Frederick Banting was born 101 years ago, who discovered insulin. And about 3 decades ago, this World Diabetes Day was established, and the United Nations also highlighted the importance of NCD, including diabetes, and of course SDGs targeting diabetes. And this advocacy is very actively done in the United States, and it aims to these things, as I already mentioned. And American Diabetes Association also put this keyword: stop discrimination. And the CDC is actively doing this activity. Also, the Diabetic Advocacy Alliance, a special alliance, was doing very good activities in the United States. Then how about in Japan? In Japan, we have 10 million diabetes, people with diabetes. Before preparing these slides, I thought it's very common to use diabetes patients, but it's not considered a good word to express people with diabetes. We have 10 million, almost 10% of total population in Japan. And if we include pre-diabetes, it will become 20 million, about 20% of total population. So in this sense, Japan is very advanced in making more diabetes, people with diabetes. And we have internists who can treat the people with diabetes, 60,000. We also have a specialist, diabetes doctor, about 1/10, 5,600. If all the patients go to diabetes doctor, they have to take care of 1,800 people with diabetes. But actually, many people with diabetes go to internists. Then research was conducted in Japan, and this is the best available evidence in Japan. So this is a survey of clinical physicians' perceptions of stigma and advocacy patients with type 2 diabetes, and they're still using patients in this paper. And when they compared the non-diabetes specialists and the diabetes specialists, so ND is non-specialist, D is a specialist. If you look at experience of prejudice and discrimination, specialists 100% knew it, but the non-specialists almost half. And then knowledge about stigma. You see, these non-specialists, they are all very experienced medical doctors. They don't know about stigma. And they don't know about advocacy. They even didn't know what kind of advocacy efforts are done in Japan. So, but still many people with diabetes go to these internists, and they might be stigmatized or discriminated, consciously or unconsciously, maybe unconsciously. This is a problem, and this is the area we need more advocacy. And in Japan, in 2019, only 3 years ago, Diabetes Association, Academic Association started anti-stigmatization movement. And they have found stigmatization or discrimination affect losing self-respect, avoiding care and treatment, marginalization, and economic impact. So this is a huge issue. And I was given a title, my presentation should be related with the Geneva Chart for Well-being. So I read it very carefully and then found this one. Elimination of all forms of structural discrimination and injustice. This is emphasized in this Geneva Chart for well-being. This is important not as a health issue. This is important as a well-being issue. So many people must live with diabetes without discrimination. And this is something very unique in Japan, and maybe in Taiwan too. In Japan, we use this word, 糖尿病, to describe diabetes. And this literally means, this means sugar, this means urine. So diabetes in Japanese language or Chinese language means sugar urine disease. And urine has some minus image in Japan. I don't know whether this is true in Taiwan and other countries with Chinese characters. So we have a feeling that this is a dirty disease because we use the term urine. And this urine or feces, they're never used in hypertension or hyperlipidemia. Only for diabetes, we use this Chinese character. And these days, some simple survey was done in Japan, and people feel stigmatized because of this naming. So Japan Association for Diabetes Education and Care, they try to change the wording. For example, blood sugar control should be changed to blood sugar management. And diabetes patients, as I mentioned, people living with diabetes or people with diabetes. And this kind of change of words is a very good strategy for advocacy. And I also learned a similar movement among HIV/AIDS communities. So diabetes advocacy is done like this by making this kind of a poster, and it says, It calls for better understanding of the condition among the general public. And main message is that people with diabetes are also a productive member of the society, just like you. This is what's written in here. And this message reminds me of a proposed definition of health. This one. So you may be familiar with this definition of health by WHO. But are you also familiar with this definition proposed almost a decade ago by Professor Huber? Health is an ability to adapt and self-manage in the face of social, physical, and emotional challenges. And I've been teaching this in my lecture in the University of Tokyo and other universities, and many doctors are not familiar with this newly proposed definition. And what does it mean for people living with diabetes? This means if she or he is diagnosed as diabetes, if she or he has the ability to adapt and self-manage it, she or he is a healthy person. And knowing this newly proposed definition can strongly influence the well-being of people with diabetes. And if you stick to only the traditional definition of health by WHO, it is saying like, because you are not complete in socially, physically, and mentally, you are not healthy. This can give only minus damage to people. But the newly proposed definition can encourage a person if he or she is adapted and self-managed diabetes by exercise or by having good nutrition, by getting good nutrition, or by using some medicines, including insulin. Then I tried to look at the advocacy activities in Asia, and it was a bit surprising. And this is a title search in PubMed. Diabetes advocacy, Japan. I put these 3 keywords and could find only one academic article. In Asia, I added keyword Taiwan, Singapore, Malaysia, and other countries. I couldn't find any academic papers which is related with diabetes advocacy. And it was very surprising. The next speaker, Dr. Huang, Professor Huang, seems to talk a lot about Taiwan's advocacy efforts. So maybe it is written in Chinese language. But in English literature, I really didn't find it. And publishing this kind of article can improve the quality of advocacy activities in Asia. So I think we should do more research about advocacy. And a long time ago, my colleague and I published one paper about the relationships between NCD advocacy and HIV advocacy. I found a long time ago, I attended one World AIDS conference in Austria, which was amazing. More than 20,000 people came, and they were doing advocacy activities during the academic conference. Then I thought, can we use these lessons from AIDS advocacy to NCD advocacies. And AIDS got huge amount of money, but NCDs, not so big. And as we heard in the morning, 74% of all deaths globally, and most of them come from low and middle income countries. How can we use the lessons from effective HIV advocacy programs to NCD advocacy programs? And we found 6 lessons. They are all implemented for NCDs, but I found one thing missing. Money. For HIV advocacy, huge amount of money collected from all over the world. If you look at the change between 2003 and particularly 2013, from 0.1 billion US dollar to 2 billion US dollars. We are not seeing this kind of huge increase of budget for NCDs and diabetes, partly because during this period, many people died. So for health and disease, we can get money. But for well-being, can we get money in the same way? So this is my question, which is not answered. And my last message, more advocacy for diabetes advocacy in Asia. Diabetes advocacy for all health professionals, not only diabetes doctors. Many doctors are not aware of the importance of discrimination or stigmatization. So we should teach more about the importance of discrimination in diabetes care. Then for policymakers, to ask more money for diabetes care before they become people with diabetes. Thank you very much.
Thank you so much to Professor Basamine Jimba. Thank you.
This is Zhi Chenxu from National Health Research Institute. Ladies and gentlemen, good afternoon. We just heard about the health promotion strategy on NCD from a global perspective. We also learned about diabetes advocacy from an Asian perspective. Now, let's come to our domestic issue. How about Taiwan? How about Taiwan's diabetes care and the management? In this talk, I want to introduce a very key person in Taiwan for the diabetes care and the treatment. It's Professor Huang Jianlin. Professor Huang is a medical physician who is specialized in diabetes care and the treatment. He is also a professor of internal medicine, Zhongshan Medical University. More important, he is a president of the Zhongshan Medical University. And the most important, he is also the president of the Diabetes Association of the Republic of China, Taiwan. So he is the right person to talk about this topic, the achievement, the current status, and the challenge and the strategy for diabetes care and the management in Taiwan. Let's take a big hand for Professor Huang Jianlin.
Thank you, Mr. Chairman, distinguished guests, and ladies and gentlemen. I'm Dr. Chen Huang. It's my greatest honor to be invited here to talk about the challenges and the strategy for diabetes care management in Taiwan. And here is my outline. I will talk about the Taiwan diabetes profile and monitoring of Taiwan's current diabetes status. And I will talk about the pay-for performance and two of the challenges. And also we'll talk about the DA-ROC action and government action. And the talk is also based on the DA-ROC point of view and not the government point of view. And I have no conflict of interest. The WHO global NCD target for 2025 is to reach 25 relative reduction in the risk of premature mortality, and 1/3 reduction by 2030. WHO had set a 5 voluntary global NCD target for 2025. Among them, to halt the rise of diabetes and obesity is one of the most important targets. According to the IDF Diabetes Atlas, as you can see here, the prevalence of diabetes is increasing worldwide, including the Southeast Asia and Western Pacific Asia. And also, you can see here in Taiwan. In Taiwan, we have about 2.2 million people living with diabetes. I just learned from Professor Jimba. We approximately have 160,000 new incidence cases every year. Majority of them are type 2 diabetes. As you can see here, we have estimated, the prevalence of diabetes in Taiwan around 10 to 12%. In this slide, you can see the prevalence continues to rise with all different age groups. For age group between 40 to 64 years old, the prevalence rate is 11.6% in 2014. And for the age group more than 75 years old, the prevalence rate is increasing to 46%. It's quite high. So Taiwan sees an aging trend on type 2 diabetes, with approximately 50% of type 2 diabetes patients are above 65 years old. So Taiwan will become a super aging society by 2025. And we also see there is a long-standing trend on patients with diabetes. About 40% of the patients have been diagnosed for more than 10 years. Another challenge is that the diabetes in young people is still on the rise. From year 2000 projecting to year 2045. As you can see, for the age group below 40 years old, the prevalence rate will increase to 2.6-fold. For the age group below 20 years old, it will increase to 9.2-fold. It's quite amazing. So to tackle these diabetes problems, Taiwan implemented pay-for-performance program since 2001 to strengthen diabetes prevention through 4 checks-up of hemoglobin A1C, LDL cholesterol, urine testing for albuminuria, and the fundus examination. And for these years, you can see the patients with type 2 diabetes enrolled in P4P rate increased gradually until it around 30% in 2014. But recently, the enrollment rate increased to 40% about. In consideration of the accountability, there's also increase in annual lab checks-up for patients with diabetes in terms of hemoglobin A1C, lipid profile, and urine testing and fundus examination. And this is showed the combined test for hemoglobin A1C at least 2 times a year, lipid profile, urine protein, and eye fundus examination at least 1 time a year. And you can see, since the launch of the P4P program, the examination rate is increased gradually. As the previous slide showed, the P4P enrollment rate increased gradually, as well as for those more young people with diabetes, more female people with diabetes, and more diabetes patients with chronic kidney disease enrolled in P4P than those with other comorbidities. The proportion of patients with diabetes enrolled in P4P program who had undergone 3 times diabetes education also increased from 45% in 2005 to 60-80% in 2014. And this slide showed the people with diabetes complete annual checkup who are enrolled in P4P program increased gradually until the 2014. You can see 70% of the patients complete their checkup. That means the 4 times of checkups and also the education program. As a result, the chronic diabetes complication trend decreased over years because of the implementation of the P4P program, including the cardiovascular disease, stroke, retinopathy, and diabetes foot, except that there is a significantly increase in diabetic kidney disease and dialysis. For microvascular disease, the CKD increase and the retinopathy increase most on the aging people, but the number need to treatment for the retinopathy decrease. For macrovascular disease, the prevalence rate increased with ages, especially for the heart failure. Also, everyone talk about the female people with diabetes. We got worse. Another achieved example is that the hospitalization rate of type 2 diabetes patients decreased by 21% in Taiwan. And this is a paper published in the American Journal of Medicine from our group to try to investigate the effect of the diabetes shared care program, that is P4P program, on the effect on the risk of cardiovascular event. As you can see, the DSCP group was associated with a 14% reduction of cardiovascular events, a 16% reduction of stroke risk, and 22% reduction of all-cause mortality. And also, according to 2019 Taiwan Diabetes Yearbook, in comparison with the people who do not enroll in non-P4P program, the people enrolled in P4P program has a better outcome in terms of all cause of death, cancer death, and any death related to any diabetes disease. However, we still have many challenges and unmet needs. The challenges are increasing diabetes incidence and prevalence trend, the aging and long-standing trend for higher comorbidity burden, and the increasing trend of young onset diabetes. And the last one is the upward trend of obesity. And we also have medical unmet needs. They are P4P coverage rate remains low, and 30% unscreened rate for hemoglobin A1C and LDL cholesterol, and 70% unscreened rate for fundus exam, and only and 40% unscreened rate for urine testing for albuminuria. So hence, we DLRC collaborate with other diabetes association in Taiwan to call for actions on Taiwan's diabetes management through publishing diabetes declaration, diabetes yearbook, and clinical guidelines, and also advocacy for literacy. First of all, we revised the Taiwan Diabetes Declaration in 2021 with 4 goals and 6 action plans. The 4 goals are, the first, to improve public awareness of diabetes, to increase screening rate of high-risk group, to delay onset of diabetes, to establish treatment guidelines, to synchronize international guidelines, and also to leverage big data and new technology to improve diabetes care quality. And we also developed 6 action plans. I just talk about the number 6. We promote the quality of diabetes patients and caregivers by satisfying their psychological needs. In 2019, we kick off Goal 50 initiative in order to mobilize 50% of diabetes, people with diabetes achieving glycemic goal. That means hemoglobin A1C less than 7% by 2023. We have 4 actions in the first phase. That means to develop standard of care guidance and to enhance general practitioner care capability with tutoring program and to improve reimbursement policy to enhance care of diabetes comorbidity and to encourage patients for better self-care through disease awareness education campaign. We first kick off Goal 50 online kickoff press conference to encourage patients with diabetes go to 3 to 1. 3 means 3 glucose control indicators, AC, PC, and A1C. 2 means 2 kidney function test, UACR and eGFR, and 1 for prevention for heart failure. We also held a disease awareness campaign to leverage online and offline channels and various advocate partners, trying to drive the public sense on timely management of glucose and cardiorenal risk control. In this campaign, we asked Tang Sanzang call for action on Go to 3 to 1. Tang Sanzang is a famous Chinese traditional fairy tale man. We associated with more than 200 pharmacies to activate people with diabetes to ask care team about their glucose control and cardiorenal risk. We also tried to policy shaping by holding a diabetes and comorbidity summit. In this summit, we DROC invite the Health Promotion Administration, the NHI administration, and other medical society to align diabetes and chronic kidney disease management in Taiwan, including how to drive the CKD prevention from early screening on diabetes patients, and also how to optimize diabetes and early CKD incentive program to early prevent ESRD on diabetes patients. According to TAD survey, it's a cardiorenal risk on diabetes survey. This is among 15,000 diabetes patients. 50.4% achieved A1C goal. And also we found that about 97% with at least one cardiorenal risk factor, and 37% with albuminuria. That means the CKD risk. From year 2000 to 2014, the number of patients with diabetic nephropathy in Taiwan increased by 400%. It's an amazing number. That means 1 in 3 diabetes patients with CKD in Taiwan. And we also, from the Kidney Disease in Taiwan annual report in 2020, there is the report, the 46.2% of the new dialysis patient principal diagnosis is diabetes. Also, from the other 2 survey, also found that more than 50% of patients with diabetes were unawareness of CKD risk. Since the routine UACR screening is critical to drive early diagnosis, but we still have more than 60% patients no annual UACR check. More than 70% of patients with diabetes with cardiorenal risk not treated with recent guideline recommendation, and also more than 60% of CKD patients not join national P4P program to follow up care quality. So to overcome these difficulties, we propose the next Goal 50 ambition in order to advance diabetes kidney disease care quality up to 50% by 2025. That means we want to reach the 50% of annual UACR screening, 50% of treatment guideline compliance, and 50% of diabetes and early CKD P4P coverage. Last year, DROC carried out a time action on DKD pilot project in order to build up Center of Excellence for DKD care. We implement PDA to advance quality of dialogue between physician and patients on DKD treatment. And we also set up paradigm of DKD care in clinical practice, from screening, treatment, and follow-up. There were 23 hospitals, 23 medical centers and regional hospitals during this study. There were about 7,000 people with diabetes enrolled in this study. So with PDA implementation, you can see the patient awareness of DKD or UACR increased from 44% to 85% after 6 months follow-up. The guideline-directed medical therapy, for example, SGLT2 inhibitor for chronic kidney disease, also increased from 38% to 48%. And the most important of all, I think, is the people with diabetes enrolled both in diabetes P4P program and also early CKD P4P program increased from 42% to 60% after this trial. Recently, we are joining Taiwan Society of Nephrology to advocate to level up diabetes and chronic kidney disease integrated care to a national health policy. Fortunately enough, we have reached the first critical milestone. That is to drive a new P4P program for diabetes and early CKD integrated care, successfully launched in March this year. And the program adds incentive. We have money, and also mandatory follow-up and defined KPI to evaluate integrated care quality. Finally, in this July this year, our Health Promotion Administration launched a metabolic syndrome management program with a funding of $1 million US. Not much, but it's a first step from NHIM budget on GP level. Try to early intervention for the metabolic syndrome for prevention of further disease progression, such as diabetes. I think this is a very important step for our government to reimburse the disease prevention, for example, diabetes prevention. So we hope the plan, the program can be expanded with more large scale in the future. With that, I want to stop here. Thank you for your listening. Thank you.
Thank you so much to Professor Huang. Professor Huang, would you please remain on the stage and join us directly for the panel discussion? Thank you so much. 那接下来呢是我们综合论坛的时间哦。And for the panel discussion, we'd like to once again invite our moderators and all the speakers in this session to join us on the stage. So let's welcome back once again our moderators, Professor Hongyi Qiu, Professor Zhi Chengxu. 让我们有请场次的主持人邱弘毅所长、许志成副所长。And also our speakers in this session, Professor Padmini Murthy, Professor Masamine Jimba, and Professor Jianling Huang on the stage. 也要有请我们这个场次的3位讲师 Padmini Murthy、沈马征辉教授以及黄建宁校长。All right, and now over to our moderators. 那接下来把时间交给主持人。
Okay. Thank you for our 3 distinguished speakers that talk about in the global perspective, Asian perspective, and then also the domestic issue. Do you have any comments or questions from audience? Yeah, please.
Yes, please use the microphone by the chair and let us know who you are. Introduce yourself. Thank you so much.
Hi, thank you. My name is Jack Niedenthal. I'm the Secretary of Health from the Marshall Islands. Just to really appreciate all the presentations on diabetes, because for our country it's a pretty big problem, much bigger than most places. I noticed that throughout all the presentations this morning and even now, when something's presented and it shows what's going on in various countries in the world, you never see a place like the Marshall Islands. At best, we're maybe a pencil point, but we can never see where we are in that. And it's not a criticism. Those of us who have been in the islands for working most of our lives in the Marshall Islands or lived there in small Pacific countries, we're used to that. But if you put a map up there that showed per capita diabetes rates, we'd probably be the largest country in the world. And there's reasons for that. And I don't really have a question, it's a comment that maybe you can comment on, because it's been a really big problem for us in that one of the things that's often commented on is diet. But for us, in a poor country where the minimum wage is $3 an hour still, people will buy a big bag of rice, a bag of flour, or just the processed foods, because that's what they can afford. A bag of brown rice is maybe 3 times more expensive than white rice. And so when you're feeding a family, very large family like we have often in the Pacific Islands, I know Marshall Islands isn't the only place like this, you're talking about making sure somebody has something in their stomach so they're not hungry. So they wind up eating these terrible foods for long periods of time. We're talking about habits that are decades old, ever since World War II pretty much. So my comment is, the thing that we've been working really hard on, and the comments about what happens with COVID and diabetes, which is one of the reasons why we worked so hard to keep our borders closed for 2.5 years. We never had COVID until just this August, and it went very quickly. And we did really well with it, but we were afraid about because of the diabetes. We had so many diabetes cases, and with such a high comorbidity for COVID, we were just terrified. So my comment is, how do you reverse these trends that you just can't get the sugared colas out of kids' hands? And I think it's like that everywhere. But it's because a big part of it is, I guess I would say, number one is income level, and number two, it's decades-old habits. And maybe some of the larger countries have these same kinds of issues, but in our country, it's the majority of people. And it's really sad to see that, but ultimately when we start working on these things, we work on various programs, and I really would like, I can't end my comment without thanking Taiwan. They have a great Taiwanese farm where we are in the Marshall Islands in Majuro that adds a lot of vegetables. We're trying to add vegetables to people's diet, but they don't like, our people generally don't like eating vegetables. So what do you do? I guess that's my comment. I don't know who I'm addressing it to, but maybe somebody there can comment on like these kinds of situations that smaller countries face, and not just the larger ones. Thank you.
Thank you. Thank you for the comment from Marshall Islands. Any, yeah, Dr. Jim.
Thank you very much for your comments. I'm Masa Jimba from University of Tokyo. And last time when I came here, I made one presentation about a positive deviance approach. And this is an approach to find out someone who are not being diabetic condition. I do not think diabetes prevalence is 100%. There must be someone who may be diabetic, but somehow not diabetic, aware from this condition, without any external intervention. If you can find someone like this, maybe he or she can be a good model, to be modeled. And I'm telling this not only because for your Marshall Islands, in Taiwan or in Japan, also we may find some community or district or sub-district where diabetes incidence is not big enough. And I haven't done this kind of research, but we tend to talk about average of all the world or average of all the country. How about the situation at community level? If you can find some successful efforts or idea in such sub-district to district or community, this might be a good model with less support from outside. And I personally do not have such data in Japan, but if Professor Huang has such kind of district data, I'd like to hear.
I'll talk about my experience in Tuvalu, where one of our, country alliance. My hospital did a team to go to Tuvalu because the prevalence of diabetes is also very high. But I think the most important is the education, the lifestyle modification by education, empower the people to know what is what diabetes is. From the top of the beginning, then they will change their behavior to, you mean they don't like to vegetable, but at least they have to know, to identify what kind of foods they cannot eat. they cannot eat too much. Something like that. I think from the very beginning, lifestyle modification, education is the most important. This is my opinion.
Thank you so much for your comments. I just wanted to say one of the things, just to add to what you said, Dr. Jimba, is peer education. I have found that working with colleagues in India, where, India also has a lot of pre-diabetics and undiagnosed diabetics, like peer education, especially women. I'm not saying it because I'm the only woman on the panel here, but to bring the gender perspective, like peer education, like as you suggested, somebody who has diabetes, so pregnant women who had issues coming and talking about it did make a difference. And with regard to your how do you convince people, is I think the mantra is let me help you to help yourself. And we have a concept of these community gardens, which you also mentioned. So that has been really useful, because the Bronx in the in New York, in the United States, we have a lot of poorer, definitely, groups. There are a lot of immigrants. So one of the issues is like growing the fruit, growing fruit and healthy vegetables in the community garden. And with regard to your thing on brown rice, it's expensive everywhere compared to white rice, whether it's Marshall Islands or anywhere. Maybe this is something, I'm going to throw the ball back to your court, that you politicians need to have a price curb, something where it's more accessible, because unless economically something is within the reach of people, we can scream and yell from all the podiums and say, lead a healthy lifestyle, change your behavior. But if we are not giving them the means of making sure their money goes a long way in leading a healthy life, we are fighting a long cause. So I think we have to work together and looking at various angles. Thank you, sir.
I think that behavior change is very difficult, especially I think it's more important for countries, the public and private partnership. For example, in Taiwan, we have a lot of achievement. That's because our government and also the NGO, such as the Diabetes Association, also a lot of patient group, they work together and communicate and promote, develop some health promotion campaign. They will achieve a very good achievement. Can we let another person to ask? Yeah, the ladies.
Thank you very much. My name is Bettina Borisch. I'm from Geneva University and from the World Federation of Public Health Association, its CEO. I would like to follow up with the discussion and what our friend and brother from the Marshall Islands pointed out so brilliantly. Among the influential factors for health that we heard, education, health literacy, and so forth, I think we should underline the economical and social determinants. And here comes my question. We know that the food industry clearly targets the social deprived groups, and we know also what we have as tools to change attitudes of the food industry. I'm not far away living from Nestle, the one that supplies, I think, 40% of the food of the world. For example, sugar taxes have been shown to be very effective. UK introduced a sugar tax on sweetened beverages, and 3 months later, the sugar content was lowered. So my question also to my friend and colleague Mini is, what is the US planning in terms of taxation? Because we know also from smoking policies that taxation is one of the tools that works, and that works especially for the social deprived ones. Thank you.
Professor Murphy.
Thank you, Bettina, for putting me on the spotlight. I just wanted to say, in New York City, a couple of years ago, there was this tax introduced. it worked well for some time. There was so much of protest because the election was around the corner. I'm not talking politics. I don't belong to any political party. I'm an independent. But this was the issue. Then they rescinded it. So unless we have more support at all, local government and then the state and the national government, it's not going to happen. So this was a major issue. And I know there are people bringing it up, but unfortunately, it's on the back burner because there are other issues there. So there's a bunch of dedicated people trying to, so we'll keep you updated. But this tax was introduced by Mayor Bloomberg in New York City a couple of years ago, and then it worked well, and then again it was rescinded. So that's the story.
Probably because it worked well, yes, I know. He did a great job. So what we see is the political determinants of health. We have to have political support for all the measures, may it be health education, health literacy, or also the law and taxation systems. Political support is key. Thanks for the example from New York.
I think this is a very important discussion about political determinants of health and also commercial determinants of health. And in Japan, for example, for tobacco, Ministry of Health is pushing increasing more tax for tobacco. But Ministry of Finance is very conservative. And the proposal from the Ministry of Health is declined by Finance Ministry because there must be some relations with the tobacco industries. And I found very strong lobby activities by food industry, tobacco industry at the parliament level. And this is affected. They affected Finance Ministry too. So this is very difficult to change upstream trend. And another thing, I think food industry is selling happiness to people. And we are selling health for people. And people want to buy happiness, not health. Maybe both, they should seek both. But I feel people like to eat delicious hamburgers. So what I mean is some kind of raising awareness, empowerment of people might be an important way to overcome this upstream threat.
Okay, I will follow this question. I think this is a very important issue. And almost like in Taiwan, as you can see, we have a lot of bubble tea, everywhere. But it's a kind of conflict of interest, and I agree with Professor Jimba. It's a kind of by happiness more than by by treating. But I think at least before we tax it, our government tried in Taipei City, Taipei City, they have a great regulation to most of the soft drink need to label their calorie. I think this is the first step. Yes. So bubble tea, maybe you can see the low sugar, middle sugar, or large sugar, something like that. And the other thing, I think, we need a national high-level policy to see this question. I think maybe related to the political issue. Thank you.
I just wanted to add to one more thing. Like there are we have a soda tax. Some of the states in the US and some of the counties, they have a soda tax. So that is something where people don't buy that because, so that is something we have in the works, which has been quite successful. Again, it's the discretion of the local government or a particular state in the county, but nowhere do we have, as I just said, a tax, a sugar beverage tax, but we do have a soda tax. Suppose you went to Pennsylvania, you would be taxed more than you would be somewhere else. And if you went to a few counties in California, your soda would cost more. So then you think like, but your dollar, you have not earned more by going there. So, you know, so people think that, okay, maybe I'm not going to have that. Maybe I'll get a bottle of water or something like that. So thank you.
Thank you. Thank you. May I just say just some word on the fun aspect? I know we in public health are always considered the anti-fun people, the good things we don't like, but we don't say that sugar, as nicotine, is addictive. And I'm coming from a chocolate country, Switzerland. I suffer myself from a chocolate sugar addiction. And the way we put sugar in food early on, we educate children to a certain sweet dependence. And that's something we shouldn't do from very early on. So just think about the addictive effect of sugar. Don't forget.
Yeah, thank you.
And again, processed sugar. Again, the sugar in the raw is more expensive, coming back to the brown rice debate.
Thank you. Professor Cho.
Hi, I'm Professor Shruti Cho, the former Director General of Health Promotion Administration, and currently the board member of International Union for Health Promotion and Education. I have one question and one comment. The question is related to Professor Junba. Which country, according to what Professor Murthy mentioned about long COVID, which countries in East Asia would you guess to be the one witnessing the biggest rise in diabetes rate after this pandemic? This is the question. And then the comment is, quite often we think about syndemics, that different problems occurring together, and they created interactive negative effect on one another. But at the same time, facing these difficult political decisions, we advocate for a synergistic approach. For example, talking about taxation, it seems unpleasant. But how about the fiscal approach that for countries like Marshall Islands, they faced rising medical costs for diabetes? How about the advocacy to say that by imposing sugar taxation, we are going to reduce the prevalence, the intake and then the prevalence. At the same time, the money could be used to invest in health care for diabetes and in subsidy for healthier food choices. And at the same time, promotion of such healthy eating is also beneficial for the government to achieve their SDG targets, including SDG 2, not only SDG 3, and also the SDG on climate change mitigation, for example. So that's one way to create political momentum, and at the same time to create the support from the people and the healthcare society. That's my comment on this, not just taxation approach, but fiscal approach, both preventive and also incentivizing positive behavior.
Okay, Dr. Junba, you go first.
Sorry, for your first question, I have no answer, no statistics. So at the moment, I cannot respond to you correctly. But if you can, I'd like to ask.
Thank you for your question. I just want to say that in Southeast Asia, I know the data. It's India, Pakistan, and Bangladesh, which are skyrocketing because of the reasons I just mentioned earlier, is COVID. This is another thing. So they're saying that the diabetes and violence against women, sorry, I had to bring in that thing too, are increasing because the violence against women is the discrimination you were talking about, Professor Jimba, and added to, you know, the whole gender lack of gender parity. Women did not have access. So it's India, Pakistan, Bangladesh, which are the top three, and we don't know who the gold medal winner is going to be because it's terrible. They're in the race for the maximum number of diabetics in that region because of COVID. Thank you. I don't don't know the data for the other countries, but this I know, that's why I could tell you. Thank you.
I can only comment and share my personal experience. For my patient with diabetes, when they get coffee, their glucose control will become worse than before. Okay.
Professor Peter Zhang.
Thank you. I'm Peter Chang. I'm the Vice President of International Association for Health Literacy, also President of Asian Health Literacy Association. I echo a lot of presenters regarding health literacy. Thank you so much. I also appreciate our Ministry of Health offering such a discussion about D-Day. I have a comment, but also question that when we talk about health education, but we are offering resources, information to the other, but we do not ask what's the health literacy level of information accessibility or understanding the information by the public, because the public was the sufferer of the diabetes. So when we say we are going to educate them, health education, but do we ask them how much do they understand what we are giving them, okay? So my question is, we have been offered with good lunch. We offer the same amount of lunch. How much calorie we have been given? Because we have people with different size of the need in this audience, right? But we have been offered, we've not been offered a chance to say, can I choose little? Can I choose others? I remember one of the health ministers in Taiwan, he was very brilliant, Li Mingliang, many years ago when he was the minister. He said, I asked all the restaurants, including this one, the lunch, how much calorie put on the box, and people can choose. So that's my question. When government, Taiwan, or many others, they want to having caution, alert about the D-Day, but do they ask the producer of these meals or any kind of putting on the label? This is the beginning of health literacy. Thank you.
We'll probably have to make this the last question because we're running out of time here. Thank you.
No, he asked about Taiwan, so I'm passing it back to you. Thank you, Peter.
I think I cannot answer the political issue, but I can answer them. For the Taiwan Diabetes Education Program, they have a series of courses to teach to show the patient how to choose food, how to calculate calories. It's a kind of a serial education program. So we also emphasize to empower the patient to choose the right food. It's a kind of continuous education program, but not just you can give them just one time. So I just answer your question. Okay.
Just one comment. This is also an issue of chair you are sitting. Our size of body is all different, but we're given the same chair. So some kind of meeting individual needs must be very important for health and other issues.
I just want to add one last thing, is that we don't even have gender-specific PPE for women. So, so I just had to throw that in. Thank you.
Yeah, I think the NCD prevention and health promotion is very difficult, especially in the emerging COVID-19 pandemic. For example, in these 2 years, our government and also the worldwide, the same, we are putting a lot of funding and also the advocacy in the infectious disease prevention. How about that the resources will be squeezed from the NCD prevention? That's a very problematic issues for the global perspective and also in Taiwan. Because the time is very limited, and I want to ask Dr. Cho to give us a closing remark for this section.
Okay. Thanks all our three distinguished speakers and all the participants in this conference room. And I think everyone agree the diabetes is the big challenge of for the global. And we want to fight with it. There are a lot of the strategy needed to design, and this is a package from the policy, education, empowerment, action. This is also very important. And the recent study have shown the risk factor with the diabetes is not the only one. This is the multiple risk factor combination. Like maybe the sugar intakes, but if you combine with the more exercise, then you can reduce the impact from the taxes. So more and more research and more policy needed to figure out how to have to personalize the policy to empowerment. So the Geneva agenda say we ensuring the people and the community can enable to take control of their healthy through the education and the culturally relevant health literacy. So the meaningful empowerment and the engagement. So this is our conclusion, and we need the global group to help each other and under the different experience to help each other to fight this the biggest NCD of the world. And thank you all of you to join this symposium, and we hope in the future we can cooperate with each other to have our diabetes influence for our healthcare can be reduced. Thank you. Thank you.
Thank you so much. Give our speakers a big round of applause. Thank you so much to Professor Cho, Professor Xu, Professor Murthy, Professor Jimba, Professor Huang. Thank you again. All right, ladies and gentlemen, it's time for us to have a break, and we'll take a 10-minute break. So do your best to be back by 3:07. All right? Okay. Thank you so much. Okay. And we have an exhibition on the 10th floor. It's showing some VR, AR solutions and assistive devices. If you have some time, feel free to pay a visit. Thank you again. 那接下来呢，我们稍微短暂休息一下下，我们休息10分钟。等一下呢，我们3:07分呢，请各位贵宾回到会场哦。那我们10楼呢，同时也有展出一些最新的 AR、VR 的解决方案以及辅具哦，都欢迎各位贵宾有时间的话呢，可以到10楼的1003去参观。那我们等一下回来。Thank you again. We'll be back later. Okay, people, we're about to begin in 2 minutes. Please take your seats. Thank you so much. 各位贵宾，我们下一个场次呢，大概再过2分钟之后要开始了。我们的工作人员是不是也到我们场外呢？帮我们把还在场外的贵宾请进会场来，谢谢。非常不好意思。We are about to begin. Please take your seats. Thank you so much. And people are coming back right now. Sorry, please just give us 1 to 2 minutes. Thank you. 不好意思，请贵宾呢再稍后一下下哦。那还有一些贵宾在用这个茶点啊，现在在回来的路上，我们再等个1分钟左右，谢谢。 Okay, we'll begin anyway. Okay, people are so busy having desserts. Just told them not too much sweet stuff, right? People, it's so hard for people to change, all right? Okay, yeah, ladies and gentlemen, welcome back. We're right now in plenary session 1, and what we're going to talk about in this session is how to engage the public for advancing well-being and welfare and health. 那接下来呢，我们这个主题场次要聚焦如何来让更多的大众呢一同参与我们健康促进的工作。And now I'm going to introduce to you your moderator in this session. We're very honored to have Dr. Chao Ronghu. He is the professor and vice dean, College of Medicine, Taipei Medical University, and also the director of Dementia Center, Shuanghe Hospital, New Taipei City. 那接下来我们就掌声欢迎我们的主持人，台北医学大学医学院教授兼副院长胡朝荣胡教授，掌声欢迎。Let's welcome him.
Good afternoon, ladies and gentlemen. Thank you so much for coming here. I'm Chao Ronghu. Because the original moderator, Professor Ye, for some reason, he cannot come here. So I do the moderator for him. This section entitled Engage the Public for Health and Well-being. We have 4 distinguished speakers, and every speaker have a 20 minutes presentation. After then, we have about 15 minutes for panel discussion. The first speaker, I would like to introduce Professor, Victoria. Oh, Frank? Okay, sorry. From Professor Frank Bang. She is Director of Steno Health Equity University of Adelaide, Australia, and he also the professor of public health and the director of Southgate Institute of Health Society and Equality, Fender University. The title of his talk is People, Power, and Participation, Essential Consideration for Equitable Well-being Economy. Let's welcome Professor. Okay.
Let's welcome Professor Frank Baum, Director of Stratton House Equity University of Adelaide, Australia.
Lovely. Thank you so much, Dr. Hu, for the introduction. And it's really lovely to be in Taiwan, and thank you for the invitation to speak at this important forum. What I want to do is think about participation and people and how that relates to our health. But I want to do that in the context of what would make a more equal society and a well-being society. And I noticed that a number of the speakers have talked about participation. You can see here where I come from. I come from Adelaide, where the traditional people are the Kaurna people, and it's in the southern area of Australia. What I'm going to talk about, I've listed here. I'm going to talk about a definition of health equity, introduce the nutcracker effect to ensuring that a society is equal, think about the difference between citizens and consumers. It's safe, yeah. And look at the sort of number of crises that we're facing in the world. Look at the social and commercial determinants of health and how important they are, and introduce some ideas about power and think a bit about the role of civil society. So really, health equity is different to health equality. Health equality means the same, whereas health equity is about being fair and the result of unfair or unjust processes. So that means there's something we can do about it, usually through policy. I like to use this analogy, and this is why I think participation is so important, that if we're going to bring about policy change, then it's like a nutcracker. Yes, we need political will, we need a public service who's committed to reducing inequities, but we also need a lot of civil society action and people's pressure for change. And if you think about all the big changes in the world, they always resulted from people's movements, whether it's votes for women, the end of slavery, and so on, and a lot of other movements which resulted in more equity. And I like to draw the distinction between health consumers and health citizens. Both are important, but I think health consumers very often focus on the disease, and very often it's people who are experiencing that disease. They're engaged with health system improvement, and they're sometimes challenging medical dominance. Health citizens, I think, are much more about, well, what democratic actions can we take to promote health and equity? Much more likely to focus on the whole population, and they're concerned with well-being and challenging the underlying causes of ill health. And very often, they're challenging power and saying we need to change the balance of power. So, what kind of world do we have now? Well, it seems to me, and I think we've got a talk from Bettina tomorrow about crises, so I won't say too much about these, but it's sort of a beginning to think about them, that the world is facing a lot of difficult issues. We've had financial crises, and it looks like we might be heading into recession. There's lots of talk of that. We've got social crises of people talking about declining solidarity and isolation. There's a lot of declining trust in political leadership around the world. A lot of previously public assets have been privatized with very mixed effects. There's even now a war in Europe. There are lots of other civil and other wars around the world which are increasing under climate pressure. And of course, underpinning all that, we have a massive ecological and climate crisis, which every day there seem to be more stories of extreme climate events and more stories of the difficulties that often poor communities are facing with floods and fires and other climate events, which I think now most people would agree are person-made, that they're not just natural events. We keep having a once-in-a-100-year event every few years. So that's the kind of, these are the crises that we have. And all of these are affecting our health. They're affecting chronic disease, mental illness, anxiety, depression, and of course new infectious disease. And we had some great presentations this morning looking at that from a One Health perspective. So when we think about participation, we have to recognize that we can't if we carry on with business as usual in the world, there will be ecological disaster. And here's a few quotes. I'll just read the one from Margaret Chan, who was the former Director General of the World Health Organization. She said, climate change is the defining health issue of the 21st century. A ruined planet cannot sustain human health. Cannot sustain human lives in good health. So that's a really ringing rally call for us to do something about that. And yet all the reports we see are that despite a lot of people's pressure for climate change, it just isn't happening. The other thing that the world is seeing is huge levels of economic inequities, which also affect our health. And as Anthony Atkins has said, that is intrinsically inconsistent with the conception of a good society. So he's saying a good society is a more equal society. And just to show that, Oxfam, the large NGO, has talked about inequality killing. They've pointed out that just one example, that in the US, Black Americans were much more likely to die of COVID, and in fact has reduced life expectancy for Black men from about 72 to about 65. So massive health impact. And also pointing out that just the 10 richest men in the world has had their wealth doubling over the period of COVID, whereas most people are worse off, most of the population are worse off. And while they seem like big macro trends, they have a very real impact on our health. And of course, if we look at consumption and who does the consuming, it's the richest part of the world that is consuming most of those CO2 emissions that are contributing to climate change. And that's at a very strong level. So when we look at the social determinants of health, this is some Canadian research that was done a couple of decades ago, but they estimated that social and economic development contribute about 50% to our health, the healthcare system about 25%, and then physical environment 10%, and biology and genetics. So that's why I think we need to pay so much attention to social and commercial determinants. And indeed, the World Health Organization has now set up a section on the commercial determinants of health, and you can go to their website and have a look at the work that they are doing in the area. And I think what they're saying is, if we look around the world, something like 70% of the world's largest economies are not countries, but corporations, just to give an example of the kind of impact that they have. And again, to quote from Margaret Chan, she has said that, she's pointed out that these commercial determinants have a real impact on people. She's saying particularly through here diabetes and obesity, and she said it isn't about the failure of people's willpower, it's the failure of political will to take on powerful economic operators like the food and soda industries. And she says very clearly the interests of the public must be prioritized over those of the corporation. But very often policy responses to overweight and diabetes is to tell people to change their lifestyle. But of course it's about much more than that. It's about the food supply, it's about high sugar, high fat increasing dramatically in diets around the world. And Ban Ki-moon, when he was the Secretary General of the UN, he also made the point that diabetes is shaped by global forces, and that was about the marketing and trade of unhealthy food. And lots of studies have shown that when a country imports a lot of that kind of fast food, then obesity and diabetes follows in the wake of that increase of importation. In my book, Governing for Health, I've really stressed that we need healthy public policy in all sectors, and I came up with a kind of manifesto for well-being that said, well, if we wanted to organize a society around well-being, what would we do? And you can see that that would require economic measures such as fair taxation and ensuring that large corporations pay tax, transparent and inclusive governance, which means a strong civil society. I'll obviously talk more about that. Lifelong learning with free education, both for children and people in later life. Good quality jobs and decent welfare. I've just come, for the people who are at the session on pensions, we heard about the different approaches to pensions in that session and how there are lots of ethical questions about whether that's getting too expensive. Healthcare. The evidence is that systems that are free at the point of use and universal are the most effective. And housing and urban planning also have a big impact on our health. And of course then ecological health again. If we don't attend to that, then none of the things up. Time's up. I thought I'd only been going for 10 minutes. No, is that right? We started at 3:10? Yeah, okay, thank you. And you know, a health-promoting political economy would have well-being budgets. It would perhaps stress local businesses, cooperatives, strong public sectors, and look at local accountability for businesses, and again, fair taxation. And there are a number of countries around the world, New Zealand, Scotland, Iceland, and even in Australia, our Treasurer has started to talk about the importance of a well-being economy and a well-being budget. So I think that's a really important thing, a really important move for health promotion. And I think most of you will know what healthy public policy is. It's about being responsible for health and equity in all policy areas, not just in the health sector, but for everybody. And I've done a lot of work, and I know around the world people have done a lot of work on health in all policies and determining how you can get that action happening in every sector. Here's two reports. One, just a book by Nick Freudenberg, when he talks about commercial determinants of health, and he says that it's citizen and consumer activism that mobilizes populations to put pressure on elected officials or businesses to take actions that stop harmful practices. over a decade ago, I was lucky enough to be a commissioner on the Commission on the Social Determinants of Health, chaired by Michael Marmot, and we also stress that civil society action is absolutely essential to promote the human right to health. So, though that community engagement and action can happen through professional associations, public health associations are very important, civil society, trade unions, community groups, consumer groups, and of course the media is an important part of that. And one of the work we've done in Australia, really looking at power, we've sort of noted that power happens in all sorts of ways. It's sometimes invisible, sometimes invisible, sometimes it's structural, sometimes it's economic, sometimes it's moral. But it's absolutely essential to consider power relationships when we're thinking about this. And we also know that very often when people are invited to participate, that participation is on a ladder. It can be anything from citizens' control to manipulation, in other words, no power. And this, similarly, the work of Minkler and Wallerstein is showing that you can have social action that is challenging power, and you can have community building that encourages power with. Very important. And I just want to finish by talking about the People's Health Movement that I think is a great example of civil society activism for health equity. And I've been very active with the People's Health Movement. It is about citizens' power for health, community organizing. It has a very strong value base laid out in the People's Charter for Health. It watches and analyzes organizations that are responsible for health, particularly the World Health Organization, and it engages in capacity building. So this is the vision of the People's Health Movement. You can see that it puts equity and ecological sustainable development and peace at the heart of their vision, and it really encourages the last bit, the flowering of people's talents and abilities to enrich each other, and a world in which people's voices guide the decisions that shape our lives. If you Google People's Charter for Health, you'll find that document that was written 22 years ago, but I think it's still very important. The key point here, I think, is that governments have a fundamental responsibility to promote the human right to health, and that the participation of people and people's organizations is essential. So really important messages. The People's Health Movement also watches WHO and analyzes the World Health Assembly and Executive Board papers and produces policy comment on that. And very often countries which don't have strong policy analysis in their own ministries of health will use those of the People's Health Movement. And those policy positions are put together by a network of people around the world, working very, very fast when those papers are released. We also have a manual on how to organize a People's Health Movement country circle, which is meant to be empowering. It does challenge that power over. It's very collective, and it really stresses a shared network leadership. The People's Health Movement also runs an International People's Health University that's very much about capacity building, has a roving faculty, and we've got probably now over 1,500 alumni around the world. And most recently, we ran one of these courses in Morocco, which was fantastic. We also produce an alternative health report called the Global Health Watch. We have over 100 contributors to that, and it's really, again, about increasing understanding of that global political economy, very much from the bottom up of the nutcracker, if you like. And we've worked with other organizations. Here we worked with Health Poverty Action in the UK to produce a report called Changing Track, Putting People Before Corporations, where we showed how much money could be reclaimed by taxation to fund health and social services. In India, people's health tribunals are held, which is about community awareness raising, and there's mass participation in those, and particularly in rural health areas, with people demanding the right to health services. We also have a series of campaigns and themes, and you can see how those address the issues I've been talking about: gender justice in health, environment and ecosystem health, nutrition and food sovereignty, which is looking at some of those issues of large corporations, trade and health, the way trade agreements can affect our health, the need for equitable health systems, and then the effect of war, conflict, and forced migration on health. So all of those areas are those broad structural, social, and commercial determinants of health. We've also looked at why people get involved in activism. That can be because they feel a grievance, because they have a strong amount of idealism, because they want to convert injustice to activism. Sometimes it's an extension of people's professional roles. It can also be the experience of having been an activist encourages people to do that more. And our experience is it's very important to create organizations that are welcoming and supportive and which facilitate the development of activists. So we would say there's a big difference between an NGO and a movement. One thing I would note that there's been a crackdown on civil society around the world. I can't go through these examples, but they are coming from many parts of the world. And if we look at the Civicus monitor, which tracks civil space, you can see that there are a number of areas that are in red. There are less areas that are open in green. So that's a big issue, I think, that affects all our health. What freedom of expression do people have to protest? So in summary, we do need just governance if we're going to achieve a healthy and sustainable society. We need governance for health rather than profit. We need to make sure all our institutions are democratized, whether that's universities, health and social services, banks, or whatever. And we need to have more worker empowerment, trade unions, cooperative, and labor protection laws, which flow when we have strong trade unions. And most importantly, we need to support and protect civil society, because civil society is always going to be crucial to achieving the right to health. Thank you very much.
Our next speaker is Ms. Sarada Das. She is the Secretary General, Standing Committee of European Doctors, CPME. The title of her talk is European Doctors' Recommendation on Lessons Learned from COVID-19 Pandemics. She will present his talk online. She has a pre-recorded video.
She will actually be joining us in real time online.
Okay, good. Okay, let's welcome Mr. Sarada Das. Please.
Let's welcome her. 掌声欢迎。Hello, Ms. Das. We can see you right now. But it seems like we cannot hear you right now. Please make sure that you are not muted. Yeah, we want to make sure that we can hear Ms. Das. Yeah, and of course, if you have any questions, yeah, we still cannot hear you, Ms. Das. Ms. Das, we cannot hear you. We're sorry about that. Please make sure that your mic is on. 请问一下，后面的控台是讲者那边的问题吗？还是？ It seems like we still cannot hear you, and we are having some technical difficulties right now. So maybe we let the next speaker go first. Ms. Das, during this. Anyway, okay. we'll give you some more time to figure it out. And our moderator, would you please introduce our next speaker for us? We're sorry about that. 不好意思哦，这个连线有一些技术上的问题。我们先请下面一位讲师上台来跟我们分享。
Okay. Let's welcome the next speaker, Professor Victoria Fan. Professor Fan is the Senior Fellow, Central for Global Development. She also is the Associate Professor of Health Policy, University of Hawaii at Mano. The title of his presentation is the Mitigation Planning and Policies Informed by COVID-19 Modeling, a case study of the state of Hawaii and the lesson learned. Let's welcome Professor Fan.
掌声欢迎。
大家好. Aloha mai kako, which is hello everyone in Hawaiian. Let me take this off. My name is Victoria Fan. I'm a senior fellow at the Center for Global Development. The work that I'm about to present is work that I did in the past few years while I was at the University of Hawaii. As many of us all experienced, COVID threw us into a tremendously exhausting time. This was one of the couple of jobs that I did, which was leading our COVID modeling workforce, a task force in the state. How do I, okay. So let me just lay out the problem for you. The problem is, of course, there's many different problems, but the problem that we faced in particular was about the use of mathematical and epidemiologic models proliferated during the pandemic crisis. There were many models that were being discussed in the news, but most of them were not created with the explicit audience of policymakers, and nor did they have the intention of informing specific policy scenarios, and often there was no explicit communication of the assumptions, limitations, and the complexities of all of these models. You may be thinking, what is a model? Am I walking on the catwalk? No, these models are predicting COVID cases. So this is a brief framework. This is by the way, we're in the afternoon dead session. I want to thank you all for coming at the end of the day. It is about 3:35 a.m. in Washington, D.C., so I apologize for my jitteriness. But just a quick recap for those of you who don't want to stay for the whole session. What we did was we had a framework for thinking through how you model on the COVID surge and then on the decline. And then I'm going to discuss very specific policy use cases where we actually use this modeling to inform local decision making, including determining hospital capacity, isolation quarantine capacity, and also our broad and direct communication strategy, which is, I think, the theme of this session. So some of the key lessons that we learned from our COVID modeling task force was that there is obviously a huge need for local evidence, and states in the United States need locally tailored models and local experts to help best inform our policy decisions. We also need a brain trust, so being able to tap into a scientific advisory group for COVID forecasting. I was watching the Taiwanese CDC very closely, and Taiwan was so lucky to have Zhang Sangchun be able to advise the minister. And I think many jurisdictions all need that type of scientific advisor to navigate through such confusing scientific information. And then finally, we learned a lot about how to communicate. The whole idea being that we need to reduce the confusion and increase trust when we're communicating these very complex models. And so some of our key takeaway lessons was we need to limit the time horizon of these very complex models. We need to focus on the dynamic nature of these models. And also we need to limit our role to forecasting rather than making specific policy recommendations, especially given the fact that COVID became so polarized about, should we increase restrictions or should we reduce restrictions? So we tried to stay as neutral as possible. So that's the high level recap, and now I'm going to get into some of the details. So just as I mentioned before, we have a framework. So the policy decisions that policymakers need to think about as they're dealing with the COVID crisis or the pandemic was on the surge up, right? So on the surge up, policymakers were asking, Do we have enough healthcare resources? Do we have enough beds, ventilators, PPE, medication, isolation, quarantine facilities, contact tracers, all of the sort of resources? And then on the decline, what kind of mitigation members do we need to maintain, and which can we dispense? And so throughout the pandemic, we were, as our group developed, we were constantly asked by our local policymakers, governors, mayor's office about what advice could we give them on these issues. So a little bit about the local context. The United States, as many of you know, did not do very well in fighting COVID. We had one of the highest mortality rates. Fortunately, in Hawaii, our little small state in the middle of the Pacific did actually quite well. We ranked top in the nation in terms of health systems performance. And in terms of excess mortality, we also had the lowest in the nation as well. And I would hope that our COVID task force had a little bit of contribution to this effect. And of course, during the pandemic, there was an incredible, constant, evolving situation of policy internationally. We were in Hawaii tracking everything that was happening. And of course, in Hawaii itself, we were also monitoring all the different policy changes and all of the things that, again, just was a relentless, dynamic scenario and situation. Well, let's go back to 2020, early 2020, as the situation started to evolve. We all started to see that coronavirus was going to be a major economic impact. I wrote a paper years ago with Larry Summers and Dean Jameson about how it's a huge economic loss globally. But then as the pandemic progressed, we saw incredible confusion locally, and this is true for much of the United States, where there was confusion about data. We didn't know how many cases there were. And it was partly hampered by bad data. So the data in Hawaii, if you can imagine, was collected by fax machines. Okay, so it was constant, relentless news about how the data for COVID was really, really bad. Okay, it was a pretty severe situation, and I was shocked as a health economist, a data scientist. Never before had the public demanded to know more about health data on a real-time basis. Right? Usually our health data is like 2 years out of date. We're like, aha, here's the data for health. And now the public wants to know the health data every single day. This is the most amazing thing for me. So in Chinese, there's a word, weiji, which for those of you who don't know the mechanics of this word, there's both a negative side, which is the danger, right? But then there's this word on the right, which is opportunity. And so how do we use this danger to like Aikido or sort of do the Kung Fu to make it an opportunity for doing something good? And so COVID-19 presented the University of Hawaii an opportunity to partner and build various data products and dashboards in the public's interest. And this COVID forecast was one of those things. So we built this group called HIPAM, Hawaii Pandemic Applied Modeling Work Group. We pushed out a COVID forecast by July of 2020, an ongoing forecast to help inform states' policymakers about the situation. And it was a pretty simple dashboard with 4 pieces there in terms of cases, fatalities, hospitalizations, and ICUs. And usually in public health, I think we often think of interventions as things, like vaccines or bed nets or things like that. But actually, I think the intervention that we did in this case was a work group. We brought people together. And this is something that I learned from the Center for Global Development, is how to bring an interdisciplinary work group together. And so this work group convened community partners, a data collaborative, the health department, the university. And for the first time in my life, after being at the university for 8 years, I met professors from life sciences, from computer science, math, and physics. We had never, ever met before, but only because we were interested in doing what was best for our community that we gathered together to help with this COVID modeling work group. So that's our work group that we created. And early on, we had to pick a model. So basically, what is a model? It's this mathematical representation of how COVID's going to spread, the epidemiology and the biology of the transmission. And if you may recall, back in April of 2020, there were these media reports by very eminent and famous universities from the University of Washington and Imperial College pushing out these reports about how severe COVID was going to be. And it was an amazing device because that set the agenda locally when the policymakers then asked us, hey, we're hearing these reports in the news, what do you think? Is it right? And so here we are in early 2020. We're not COVID modeling experts, and we don't have much time. or resources or scientific expertise in early 2020. And we don't have the ability to review all the models or say what's feasible or practical. So we have to make some hard decisions about which model is right, okay? So our team, we decided to make some pretty strategic decisions about which modeling tools to use. So some key questions that we considered were, what was the purpose of the model? Seems like a really basic question. What was the purpose of the model? Can the model be tailored to fit the local parameters and local characteristics? Is the local age distribution used? Again, seems like a really basic question, but something that was really important when we compared these national models to Hawaii's situation. Is the model a stochastic model or is it a mechanistic model? And importantly, is it an open source model? Can we alter it or go under the hood and figure out what is driving the model? Okay, so again, in early 2020, in the absence of any predictive validity of the models, we couldn't really compare, you know, which model is better than the other because the pandemic hasn't happened, so to speak. So we had to argue to policymakers which model was more relevant based on these characteristics. So it was an ex-ante argument. So based on that, we picked a model actually from mostly Johns Hopkins that we felt was better tailored to Hawaii's situation, and we were able to argue that actually, you know, there were certain circumstances where the national model didn't apply to Hawaii. So here are the 3 use cases, and I've put an asterisk here because they're selected use cases. They're mostly positive use cases. I can't really tell you yet some of the negative use cases. Maybe in 10 years I can tell you some of the misuses of modeling. But here are 3 use cases where they were positive. So the first use case was asking, do we have enough hospital bed capacity and PPE in April 2020? The second question that we were asked was, do we have enough isolation and quarantine facilities? This was in the second wave in the fall of 2020. And then finally, how can we use public communication? And this was primarily in the Delta surge in the summer of 2021. So let me walk you through each of these use cases here. So in our first use case in the hospital capacity one, I mentioned to you the IHME model was one of the very few models early on that provided state-level information. This was really important. And however wrong it was, it prompted a discussion at the state level to ask whether we had enough acute facilities. And there were several deficiencies in the model, the lack of local parameters, local age distribution. It was a stochastic model, and it was not open source and therefore not customizable. And so we were able to show that compared to our model that we were using primarily from Johns Hopkins, it was a mechanistic model, an SEIR model, and that we argued that the surge that the IHME, this is the University of Washington, had predicted was not likely, and that we would not need to retrofit a stadium with millions of dollars, and we managed to save the state a bit of money because we believed, and we were correct, that we would not see that immediate surge. Okay, so our second use case is in terms of isolation and quarantine. So we had our second surge in the fall of 2020. The health department asked for guidance about whether they had enough bed capacity for isolation and quarantine. And we needed a quick answer, right? They don't have enough beds. They have to go, you know, procure the hotels. They need a decision like in a couple of days, right? So we said, okay, what's the easiest way to figure this out? We need a quick benchmark. And so they were planning to do isolation and quarantine only for those who could not isolate safely at home, which was defined as you have a shared bedroom. So basically, if you have a shared bedroom, you can't safely isolate at home, and therefore you need external isolation. And so it turns out in Hawaii, about 10% of the state's population live in a shared bedroom. And so we just used that simple benchmark, and we applied it to our model on the total active cases. And that gave us the justification for, at its peak, around 400 beds in the winter of 2020. And finally, the last use case that I want to share about is a direct and public communications model that we took. This was in sharp contrast to 2020. In 2020, we were primarily behind the scenes. We saw a lot of the mistakes that many of the scientific modelers were making and kind of miscommunicating the results. And we were very afraid that we would lose the public trust if we went to the public. And so 2020 was sort of our piloting in communicating with policymakers and the mayor's office and the governor's office about how to communicate this very complex thing called this model. But in 2021, the Delta surge we saw was going to be quite severe. And before it surged, we notified the health department that it would surge. And seeing that perhaps there maybe was not so much acknowledgement of our recommendation, we decided we would take a much broader outreach where we started to produce the report on a weekly basis and would actually actively engage with all sorts of media. We went on television numerous times, radio, social media, and went on various state and county government hearings. Like I said, it was quite different from 2020, where previously we were primarily behind the scenes. And our main focus, we were just so afraid that people would lose trust in the model. And so our primary focus was maintaining scientific credibility and public trust in every time we communicated with the public. So some of the key lessons that we learned, I think, just by happenstance and just sort of by experience, was that we decided intentionally to take a neutral perspective. We constantly tried to, emphasize that this is an unbiased forecast and that we're not making a policy recommendation. And the reason for that was we didn't want to get accused of having some type of political bias on either side, that you were saying you need to have more restrictions or less restrictions. We just said we're giving you what we think is the best and most scientific and unbiased forecast. And we also told the policymakers that the forecast is only one piece of information that you can use to make your decision about your policy. There's lots of other information besides COVID, whether it's economic or education, all sorts of other sectors, and that this COVID information is just one of many pieces of information. Another key piece was in terms of the time horizon and the sort of dynamic nature of the model. I can't tell you how many times, even after so many meetings, I would still get asked, can you tell me what the forecast is going to be in 3 months? And I would tell them, no, actually, the model, the forecast is only accurate up to today. And now that I've told you what it is today, it's actually wrong, okay? And so we would limit our time horizon to only 2 weeks, despite the relentless demand for a longer forecast. And the idea was that anything longer than 2 weeks is going to definitely be wrong, because individual actions will now change now that I've told you what the model is. And also that there may be policy actions in response to change what will be, whatever they decide to do based on the forecast. And so we also emphasize that policy actions and individual actions from today onward are not incorporated into the model. So really the model only lasts for 2 weeks. And finally, we emphasize that the model is not static. It's not like the weather forecast where your individual and your policy actions don't really affect the weather, right? But in COVID, your individual actions and your policy actions do affect the outcome. And that's why this model really only lasts for at most 2 weeks. Okay, so some of the key lessons that we learned is, of course, modeling is so complex. It requires subject matter expertise to utilize the data, interpret, and communicate the results correctly. That local data and local customization matter quite a bit, and that interpretation is very complex. We should focus on the direction and not just the specific numeric value. And that policymakers, of course, need to be time sensitive when they're making these decisions. They also need humility and foresight to seek guidance for planning, which is not always taken for granted, I think. We also found that having this interdisciplinary scientific advisory group can help inform policymakers and reduce some of the confusion. We drew from a range of local experts, and actually working in close partnership with the community and government through a state public university, I think, is a very important lesson as well. So several limitations. This is not a research study per se and a quantitative research study. This draws on a historical perspective. I can't tell you what would have happened to Hawaii if we didn't have this COVID modeling task force. And throughout this whole time of all the modeling, we were hypersensitive and attuned to the fact that there was a political context for all of these major decisions that would be happening. And of course, as I mentioned, this is only a selective discussion of the positive use cases. I haven't shared with you some of the misuse and misappropriation that we saw quite a few times. So some of the broader questions and lessons that I'd love to have a conversation with you about is, how do we create and institutionalize these bodies which have blended technical expertise? So universities we tend to think of as having technical expertise, but sometimes they don't have the communication skills and they don't have the linkages to the policymakers. So we need to have all three there in place. How can communication about science build trust in the public? And what is the role of local universities in bridging the gap between evidence and policy? Some of the bigger considerations for the United States and also low and middle income countries is, how do we upgrade our public health workforce and training? So I would argue that modeling is a form of epidemic intelligence, and yet oftentimes when we think of disease investigators, they're not trained to do modeling, they're trained to do case investigation. There's also big questions about leadership, whether or not a leader is motivated to seek out evidence and data is a huge challenge for us in public health. And then sort of the bigger question of the ecosystem, how do we leverage the university to work in partnership with the government and also with the media, which is an amazing agenda-setting device. So what's a country to do? Well, I think it would depending on your own country's resources, but I believe from this experience that it's so crucial to have investment in your local university, thinking through ways to build that talent locally, and how can you build those partnerships between the university and the government itself? How do we get those international training opportunities, including communication training? I think for scientists we need that even more than ever before. And then also I think in this world of foreign aid and assistance, which is a lot of what I'm focusing on in Washington, D.C. at the Center for Global Development, is we need to move away from technical assistance as this helicopter thing where someone from, I don't know, Washington flies into a country and gives technical advice. We need to really think through how are we going to build the local capacity of both the workforce and the IT systems, and what is the role of universities for building that capacity. There's a lot more that donors, I think, need to think about. The organizations like the Global Fund, they tend to focus on buying things like drugs and bed nets, but we're not really thinking about how do we increase and invest in human resources and our local capacity. It's a huge challenge for us, but the history of global health has shown that there's a huge role for foundations in investing in the workforce. The Rockefeller Foundation invested in several universities, the top medical university in China, and even in Rwanda, the University of Global Health Equity, I think, is really important examples of things that we in global health should be thinking about how we can build capacity. So that's it for me. I want to thank you for your attention on this this afternoon. Thank you very much.
Thank you so much to Professor Victoria Fan. Thank you for walking us through the very interesting, intriguing research you've done. Thank you. All right, ladies and gentlemen, next we're going to go back to our previous speaker. We hope it works this time, fingers crossed, okay? I want to make sure that we can hear you first, Ms. Sarada Das, and then I'll have people give you a hand clap.
Very good.
Yes, we can hear you right now. Perfect. Ladies and gentlemen, join me in welcoming our speaker, Secretary General of CPME, Sarada Das. Over to you.
Good morning once again, and my apologies for the technical problems. It's not always so predictable. I'm very pleased to be joining you this morning, and I'm just going to, well, I hope you can also see my screen.
Yes, we can see your screen.
Okay, excellent. Then I have been kindly invited this morning to share with you the CPME recommendations on pandemic preparedness. And just to introduce CPME, the organization, we represent national medical associations in Europe, which in total represent around 1.7 million doctors in 37 countries. These are mainly countries of the European Union, but also broader Europe. I'm the Secretary General of CPME, and we work in the Secretariat in Brussels, and we work across a vast amount of policy areas. including professional practice issues, pharmaceuticals issues, digital health, disease prevention, and also patients' rights issues. And we saw that the pandemic is really touched on all of these areas. And so today I would be pleased to present the lessons learned that we have together with our members, the National Medical Associations, developed. So just to give you an overview, we felt that there was really from governance, two different policy areas, two kind of general observations, things where we feel there can be improvement. This is especially true, as I'm mentioning, for the European region, but possibly also globally, you will recognize some of these issues. So really one of the first things that we noticed that there was not such a clear division of who is engaged in which tasks during the pandemic management. So while the national governments, of course, are very much in control, there were also international actors such as the WHO and WHO Europe. The EU had certain activities. The EU has agencies who are also involved. And lastly, OECD is always very important in this context because they develop a lot of data and provide it to national governments as well. So really one of our first recommendations is that there should be a much clearer division on who is active in what area in cases of future health emergencies, and that there is better coordination between all of these actors, especially, and we heard now from my predecessor how important it is to have very clear public communications. And we had the situations, for example, that different national governments gave out different restrictions, which is in the European context where many people cross borders a lot, quite confusing at some point. One of our other main observations was that healthcare systems had really been following a policy vision, which was dictated by deregulation, and where we felt it was really almost close to the kind of just-in-time rationale of commercial sectors. And I think one of the most important observations that we had was that this does not work for healthcare. We cannot rationalize healthcare capacities to the extent where the bare minimum is covered without really endangering the capacity to respond in case of emergencies. So we joined the call to move from a just-in-time to a just-in-case model of thinking about investment in healthcare, where for one, in, let's say, normal times, healthcare systems are sufficiently resourced to provide universal health coverage for their populations, as is at least in the European Union, for example, also in line with the obligations that the governments have made, but also that this would then enable healthcare systems to build surge capacity when needed. So that in cases of emergency, be they pandemic emergencies or other, that there's ability to respond. And that this is very much dependent on permanent and guaranteed funding. So this cannot be just a political choice, which is then abandoned. And there must also be the very clear understanding that there are obsolescences, so that not all funding will be used, and that there will be probably funding, for example, in research, which is obsolete in the end, but is still very necessary. Then to move a little bit to more concrete areas of action, really, and this is maybe not surprising from an organization that represents doctors, we wanted to put primary emphasis on the health workforce. We saw that in many countries, actually, the lack of staff was the bottleneck, where supplies can be procured, staff cannot be easily procured. And in the case of a global emergency, there is also not the option to request really additional support from other member states, which is maybe possible if there is a local emergency in one member state. And we did see very minor movements of health professionals across the borders, where some countries were in very extreme situations and other countries were maybe, especially in the first waves of the pandemic, still able to provide some support. But this is really a key. And what we saw was that, for example, especially in the first phase of the pandemic, that doctors and other health professionals had to work not always in really safe working conditions. There was a lack of personal protective equipment. There was a lack of such basic things such as soap that really led to people feeling unsafe in their place of work. And this is something where governments need to take better action. Then we saw that it is very useful to actually have training in any case, but also in regions where there are neighboring regions where maybe there is some movement, as I already indicated, of health professionals who cross borders, but also maybe patients, that really there is training even to get to know neighboring healthcare systems. So it is perhaps easier to be able to support across borders. And this is something that we also highlighted very much in legislation, which has since been adopted at EU level. Plus, and I was pleased that one of my predecessors also emphasized this very much, there is also need to take into account the One Health approach in this training and in all preparatory activities, so human, animal, and environmental health, to ensure that there is coherent action here. And one of the most concrete recommendations that we have given, and this was also for my organization placed into the context of new legislation which has been adopted at EU level for dealing with pandemics, is to use the data that is collected on health systems capacities, for example, a number of doctors or number of ICU facilities, and really evaluate what minimum capacities countries have to be able to provide safe care. And this is something which is so far not really coordinated at a European level, because national governments remain competent to organize their healthcare systems. But we feel that, and this goes back to this just-in-time case, that we saw in some countries there were just political decisions taken due to which, for example, ICU capacities were really, really reduced to the bare minimum, and were not really, there was no capacity to upscale these. And if you look that there are huge differences in the number of ICU beds per population across the European countries, and not always this is due to economic hardship, this is also due to political choice. So this is something which the debate on this minimum capacities continues, but we hope that there will be opportunities also to consider this really in more context. And then we saw also there is a very basic lack of data. For example, in some cases, there is not very good data about how many professionals are actually active in the system and how many hours they work. So this is also something which is important to improve, to have better data on the health workforce, and then also to have this capacity for health workforce planning. And this is something that we also promote at a European level, that there is EU support to member states permanently to be able to build health workforce planning capacities. Then to move to data in general, so far I've been speaking about the data on health system capacities, but here we're really speaking also about data, patient-level data and surveillance data, which my predecessor also mentioned this was a very important topic to have, and also level, we saw many difficulties and delays in collecting patient-level data, epidemiological data, and transferring. And indeed, also my home country, Germany, we use many fax machines to move data around just because there is no infrastructure to do this in a better way. So I have to say, at the moment, the European Union is discussing a legislative proposal for what will be called the European Health Data Space, which exactly intends to create such an infrastructure so that on the one hand, electronic health records can be created for patients for use in, well, what we call primary use, really in care provision, but that this data can then also be aggregated and that there is a secondary use for research and that this can be accessed better as well across borders. But here we saw that there was really need for improvement. Then there was also, and you see here some abbreviations, this stands for European Centre for Disease Management and Control, the European Medicines Agency, that there is a need for these agencies to also make better use of the data and have better access to the data. And to some extent, this has also happened. And also that there would be better EU-level coordination on exposure, because especially for people crossing borders, this is very relevant. And many of us had different apps on our telephones, so we could be linked into different national exposure apps, for example. This could also be improved. Then to go to what we call supplies, but this is pharmaceutical supplies, medical devices, and other supplies. Here, as I mentioned already, there were shortages. For example, in PPE, but also very quickly due to the disruption of global supply chains, there were shortages in providing other medicines, be they related to the treatment of COVID, but also in general, just basic medicines, that it was very difficult in some cases to procure them. And here also at EU level, there has now been a monitoring mechanism introduced where there are groups that will monitor shortages, but specifically in pandemic cases. And this is a little bit of a problem because also before the pandemic, there were already shortages in medicines across Europe, and not so much has really been done about that. So this is one area where there is still need to further improve. Also, what has recently been strengthened is the opportunity for joint procurement of medical countermeasures. So during the pandemic, at EU level, there was joint procurement of vaccines. And since there has also been the introduction of a new agency at EU level, which recently, for example, successfully had a joint procurement project for a vaccine against monkeypox. So this is also something where there is potential for more coordination and cooperation between countries. But one factor which is also still in discussion is how to reduce reliance on third country manufacturing, or rather how to stabilize supply lines, because also if there will, of course, be continued reliance on third countries, it was found that often there was reliance on very few manufacturers. So if there was really an organizational problem in one of these companies, that this created a huge problem for the whole supply of medicines. And then to look a little bit broader, one of our other key recommendations was really to look at prevention and how to strengthen prevention to ensure populations are healthier as a baseline. And here there is a lot of opportunity. And also I heard in the previous panel, there was a lot to talk about how to reduce incentivize healthy lifestyles to reduce diabetes rates, and indeed very similar measures will benefit the whole population to stay healthier. And here we call for stricter legislation, for example, through higher taxes or through labeling requirements on alcohol and unhealthy food. Then I already mentioned the kind of intersections between human health, animal health, and environmental health. This is a very important factor where, as was seen, there are many health risks coming from climate change and other environmental health variables that need to be tackled. And secondly, also a topic that we see more and more discussed, not only for societies as a whole, but also in the health workforce, is mental health. So we also call for action to create programs that improve mental health support. Then just two other factors where we also were involved in was the dimension of disinformation and misinformation during the pandemic, and also information fatigue, or also the infodemic, as it was called. I think there were many different challenges around this. And also at my organization, we published sort of mythbuster documents to really, especially around vaccines, to make sure that scientific and evidence-based facts were available to the public, but also to doctors. So this is also very important to ensure that within the profession that there is very clear communication from authorities to make sure that really even in individual practices and at a level of primary healthcare, GPs or other doctors have access to current and well-founded information. And lastly, and this was also already mentioned in today's panel, it is very important in normal times, but also during the pandemic, to be aware of inequities and inequalities in the population and how these will impact on preparedness and management policies, because we saw in some of our members reported where there are, for example, ethnic minorities or religious groups which, for example, don't engage with mainstream media, that it is really necessary to have a dedicated strategy to also ensure that information is made available to these groups and that it is tailored to their needs, and that, for example, in relation to vaccination, it is made very clear that this is really available to everyone. And we have, for example, in the past also had projects where it was about providing healthcare to undocumented migrants, that groups such as undocumented migrants are not fearful to participate in vaccination programs because they think this might have repercussions on their migration status, for example, but that there are very well thought out projects to get in touch with these hard-to-reach groups. So those were just a few of the specific lessons. I just wanted to leave you with 3 further thoughts. As mentioned, we need to look at how to stabilize healthcare systems in normal times. Many of the problems that were apparent during the pandemic were actually pre-existing, especially with shortages in the health workforce, health inequalities, and problems in coordination. And at least at EU level, we've seen some action now on improving pandemic preparedness, but no real vision or comprehensive strategy on how to stabilize healthcare systems in general, which is why such recommendations as regards minimum capacities really go towards improving baseline healthcare for citizens outside of pandemic situations. Then also we have to remember that future pandemics may be very different to the one we have just experienced. So we already mentioned environmental health, but also antimicrobial resistance is something that is very concerning. And we fear that some of the measures that have been taken are very much geared towards pandemics such as the one we just experienced. And we think it is important to ensure that policymakers really have a broad awareness of potential risks in future. And lastly, this is something which I think is important also, again, not only in pandemic times, but also normal times. We have to break down the silos of policy making. Just yesterday at CPME, we had a conference on investing in the future of healthcare and also involving experts from the world of economics and finance. And really throughout the pandemic, but also now the more recent kind of reflection processes, we've seen that there has been still, despite this being such a horizontal and societal experience, very siloed approaches. So the economic problems are solved by persons dealing with economic policy, health problems are dealt by the health community, and there is really a need for better communications between all of these sectors. So I thank you very much for your attention. Apologies again for the technical problems to begin with, and I will be pleased to stay with you for the panel in case there are any questions. Thank you.
Thank you so much to Ms. Sarada Das.
Thank you. Our next speaker is Professor Mingzhang Qiu. Professor Qiu is the Director of Department of Neurology, National Taiwan University Hospital, Taiwan. The title of his talk is Building Dementia-Friendly Community and an Inclusive Society. Let's welcome Professor Qiu.
Thank you, Professor Fu, for your kind introduction. Actually, I'm the ex-director. So thank you. Good afternoon, ladies and gentlemen. Thank you for your endurance till now. I'm the last speaker, and I promise you I'm a very good speedy driver, so I will not use up all the time. Today, I'm going to give you a talk about the building dementia-friendly communities and an inclusive society. Next. I have to control myself. Okay, it works. Okay, so this is my outline. I will have to give an outline here, and it's to talk about the background of global impact of dementia, and why we need a dementia-friendly society, and what is a dementia-friendly society, and how to build dementia-friendly communities, and what is the WHO toolkit for dementia-friendly initiatives. And then we come to some example of dementia-friendly communities, examples from the world and Taiwan's effort. And at last, we how to find a strategy to engage the public for an inclusive society. So, according to WHO's data, currently we have more than 55 million people live with dementia worldwide, and there are nearly 10 million of new cases every year. And this number is expected to increase to 139 million in year 2050. And this is the condition in Taiwan. Right now, in year 2022, we have around more than 310,000 people living with dementia. And around at the year of 2050, we have more than 800,000 people living with dementia. And this is the percentage, the red curve, indicating that the population ratio that we will finally come to 3 or 5% of the total population who will be people live with dementia. Okay, what will be the financial impact? We know that it's very costly to take care of people with dementia, and the year of 2021, it costs 1.3 trillion worldwide, and this number will be doubled by 2030. And the cost attributed to informal care, that means some unpaid care from your family or other people, and also social care. Social care, that means from the communities or in institute, and also from medical care, either primary or secondary. And direct medical care costs account for roughly 20%. And on the other hand, the direct social sector cost and the informal care each account for roughly 40%. Informal care greatest in African regions. This is very natural because the society, the social support are quite lack of in this region, and those in the North American and also Western Europe and some South American regions. Okay, the rivers for social sector costs is also noticed. And if we take it, the global dementia care cost as a country, then it will be around the 14th largest economy in terms of GDP of the world. Okay, so why we need a dementia-friendly society? Because people living with dementia and their family cares face challenge from social stigma, discrimination, isolation, and have difficulty in accessing supporting resources, whether it is social or medical. And finally, of course, financial pressures. And according to the estimation, that annual cost for a person with dementia, if it is in the mild stage, it will cost $16,000 US, and 27,000 in moderate, and 36,000 in severe dementia. Then we can see that there's a close relationship between the cost and the severity of dementia. Okay, and what will be, we take apart the cost. You can see that we can have health care or social care or unpaid care. You can see that the medical care rise accordingly with the severity of the dementia, and also the unpaid care. Of course, in residential care, like we use the least unpaid care. Okay, what is a dementia-friendly society? A dementia-friendly society is a city, town, or village where people with dementia are understood, respected, and supported. In the dementia-friendly community, people will be aware of and understand dementia so that people with dementia can continue to live in the way they want to and in the community they choose, and as long as they want. And WHO developed a toolkit for dementia-friendly initiative. Let's say the first step is to combat stigma, of course. And the toolkit support not only individual, community, but also the countries in enhancing awareness of dementia. They think the awareness of dementia is also very important. You will have to educate the people. That is very important. And also, it's very important that we show empowering people with dementia to remain in the community and to play a significant role in their society. I think this is also very important. We just not only want to give them any kind of sympathy, and instead they have to play a significant role with their dignity. Okay, so there are some tips suggested by WHO, the toolkit, that if we want to management or to arrange a meaningful engagement for people with dementia, then we have to take care of these points. For a time, that we must arrange a shoot time for them to participate, and also a menu that is convenient for them, that considering sitting or lighting or any ventilation or acoustics, because for some very noisy environment, it's not easy for them to accommodate. So I think a very considerate arrangement will be very important. So meeting agenda and the key discussion points must be sent to the person in advance. And also the care or another person is available during the meeting. That's also very important, because the care know their family or their patient very much, so they can help in time and just in case. And the specific material must be prepared to help discussion if they want to be invited to talk to provide their opinions, and the meeting pace and the length must be suitable for them to participate. I think people with dementia will not be able to tolerate such a long meeting just like today. So I think you are very, very great. The meeting is audio recorded and transcribed. So after the meeting, they must be reminded of what have been done or what have been talked in the meeting. So they must be provided this kind of data. And if we want to give them some direct, some question or to ask for their opinion, then we must give some direct questioning, and we must avoid some jargon or some very complicated questions. Okay, then finally, the contribution of the person with dementia and their supporter must be valued and emphasized during or after the meeting. Okay, so so the person with dementia must receive remuneration for express their incur. This is also very important, for they may forget what have just been talked or happened. Okay, so then we should come to the importance of following the essence of UN's CRPD. For a person, if I am a person with dementia, that I do not want to be treated differently from others or identified as being vulnerable or a potential easy target. I simply wish to be enabled or empowered to continue to engage in social, cultural, economic, and other activities as all other people do, and as I did before my diagnosis. However, I constantly have to determine the best way of navigating within and engaging with my community. This is very important because this is the choice from their own. So if a community understands and are well educated about dementia, then the task will be much easier for them because I would not have to need to explain what dementia is or why I sometimes need help or what kind of help I need. So we want to create an inclusive society. The most important one is about the choice. The choice to identify oneself or not as a person living with dementia. So it's not right if someone do not want to admit he or she is a person with dementia. I think we should not try to talk to them. The choice to engage or not in activity. So this is all their own choice, but not forced to. It's only through education that we can create truly inclusive society. And where living with dementia does not imply segregation, differential treatment, or forced choice. I think the last one should be emphasized. We must educate our communities, government, health and social care practitioners, teachers, and the students about dementia and what it means to live with dementia starting at a very young age. I think it's better from the kindergarten or even from the primary school. That's what we are trying to do recently in Taiwan. So what dementia-friendly communities can do, they can change the way of thinking about living with dementia, and they can change their focusing on meeting the physical and the health needs to supporting the person with dementia to achieve the best possible quality of life. We can inspire communities, whether small or large organizations, from health to corporations in critical departments, such as banks, police, retail, and public transportation, to address the issue of most concern to people with dementia and their caregivers. And one immutable rule to develop successful dementia-friendly communities that people with dementia should participate from the outset. So this is the slogan we are very familiar with. Nothing about with us without us. I think That reflects the importance is choice, okay? Choice by the person living with dementia. So we can come to see some example from the world. After WHO Dementia Friend Initiative, some country has made very good progress, such as in Japan, UK, and Korea. So they have reached millions of people who have a better understanding of dementia through some kind of process, maybe some class that will introduce later. And some individuals in those countries have already involved themselves in communities by volunteering work or in dementia-friendly workspaces, such as hospitals. Okay, the ADI published this report that dementia-friendly communities global developments in 2016. It has some example. It had many, many example, good example in different regions, such as in African, in American, and in Asia Pacific region. I only select two interesting ones to share with you. The first one is the Japan's nationwide caravan to train Nichishou supporters program. Nichishou means cognitive disease, cognitive dysfunction. Before that, before 2004, they used the Chiho, that with negative connotation. Actually, we have gone through the same process in Taiwan. In late 90s, we are struggling or are discussing whether we should use some connotation, bad connotation. We use 痴呆, but now we have 失智症. So, but still someone talking about, well, can we improve this kind of maybe more or less negative connotation, maybe we will need some more neutral term. Okay, so in Japan, they use a specialized 90-minute seminar for the public across the country, whether in the school or in the community or in the business or in the company. This is the groundwork of the dementia-friendly approach in Japan. The number of Nichishou supporters reached more than 1 million at this moment. And in Uchi, Japan, at that time, the Lemon 8 Dementia Action Alliance was beginning to provide employment or volunteering opportunities for people with dementia. You can see the picture here that the people may participate some volunteer or employment work for cooking or preparing food for some other community members. Okay, the other example is in Australia, New South Wales. The pilot program is called the Every Block Needs a Shed. The program aims to encourage and support men living in the community with early dementia. They can participate and enjoy friendship in their local men's shed. You can see that these men are very happy while they are doing some their handwork and use maybe some manual device. And what is Taiwan's efforts? Taiwan's effort come from both public sector and the private sector. The Ministry of Health and Welfare's Health Promotion Administration is working out the Taiwan's Dementia Plan version 2. We aim to finish this stage by year 2025. In the end, the action plan aims to support 70% of people with dementia and their family cares, and 70% of those with dementia receive medical diagnosis and service, and 7% of the 23 million general population's awareness and friendliness to dementia. I think 70% seems not very high for a country that we have very readily accessible medical resource, that everyone have their free access, almost free, okay, to our health insurance service. But I think this is different between those who use the resource of our health insurance, and they're being adequately diagnosed or served, okay? And the private sector, for example, the Taiwan Alzheimer's Disease Association promotes dementia-friendly initiatives by inviting people with dementia to engage so they can just tell people what people with dementia needs in the society. So they're inspiring many organizations, corporations, and individuals, such as dementia-friendly banks, convenience shops, supermarket, churches, libraries, even museums, buses, and the villages. You can see from the picture here that we have dementia-friendly temple, post office, bank, police station, and so on. Okay, and Taiwan also tried to do two noble tasks about dementia-friendly. But I think this is a very noble one, as I'm concerned. And the financial dementia-friendly is much easier, as I think, because we can change some financial supervisory rule to encourage financial safety, maybe for some property trust to ensure their financial safety for their late life. And also we have to enhance bank and insurance supervisory. This is to be done by Financial Supervisory Commission. And also we have to encourage bank counter that have more dementia-friendly acts during their encounter or engagement with people living with dementia. And also occupational dementia-friendly is a very difficult task. Maybe we can start from the workplace dementia-friendly, and the Workforce Development Agency, Ministry of Labor, is trying to enhance labor employment and do some retraining. But I think this is never be easy. And also they are trying to do some very limited number of job redesign to help people with dementia to stay at the working place. Okay, what is the strategy of engaging the public for health and well-being? Since our talk should be about this. So this is NIAA clinical staging picture that most people are very familiar with. The 4 is the mild stage dementia, and the 5 is moderate, and they need many help for very much help for activities of daily living. And 6, the severe dementia, they have almost dependent on their everyday life. However, these are called pre-dementia stages, and people are usually not very familiar with this. The first stage is the silent stage of disease. They have no symptoms. The second stage that you may feel you have some memory decline. But if you receive some cognitive test, then the doctor will tell you that you have no more cognitive test according to your education and the gender and the age. So we call this subjective cognitive decline. And third is the mild cognitive impairment. They have memory below normal level, can be detected, but the forgetfulness seems to impose only a very mild impact on their person's daily living activities. Many people are at the first stage, second stage, or third stage, but not yet dementia. However, this stage of people may be improved by some program, such as this, we call it Worldwide Fingers. This is from Finland, geriatric, some cognitive enhancement program. It's non-medication and use nutrition and exercise and social engagement and also cognitive training. And they found this is workable and did improve and delay the onset of dementia. So if we let people know that many people are in this stage, and you are not very far away from dementia, and you should participate this kind of fingers movement, and maybe we can mobilize this kind of public to have a better participation to become a dementia-friendly society, and also help them to delay dementia. This is a picture that the TADA, Taiwan Alzheimer's Disease Association, has enjoyed her 20 years annual meeting. And so building dementia-friendly community is cultivating a dementia-inclusive society. So people with dementia can live well in friendly, inclusive communities in a way they want to and understood, respect, and supported. Thank you for your attention.
Thank you so much to Professor Cho. Would you please remain on the stage and join us for the panel? Thank you so much. And ladies and gentlemen, we'll move on to the panel discussion. We'd like to invite all of our speakers and moderators to join us on the stage, Professor Hu, Professor Bum, Professor Fan, and also Professor Cho. 那接下来是我们最后的综合座谈的时间，我们有请我们的主持人以及我们的语坛贵宾到台上来。And also Ms. Sarada Das will join us online for the panel. And we'll try to finish before 5 o'clock Taipei time. Yes. All right, and do we also have Ms. Das joining us online? Yes? Okay, so over to our moderator, Professor Hu.
Okay. First, I would like to thank all the presenters from Australia, Hawaii, and Europe, and Taiwan. In this plenary, we cover the health equity and the lesson we learned from COVID-19 pandemics, and also the dementia care and the friendly community for dementia. So this plenary is open for discussion. Any question or comment from our audience?
Is there any questions?
Yeah.
Please raise your hand and identify yourselves before asking questions. Thank you.
Maybe we can, okay, please.
Yes, sorry. Secretary of Health, Jack Niedenthal. I just realized, Victoria, after your presentation, that I want to thank you because the Marshall Islands, we really relied on your information from Hawaii, and I realized that's where I had heard your name before. I know when we talked, at that time I didn't recognize it, but Hawaii was where we did a lot of our quarantining when coming to the Marshall Islands. It was 2 weeks in Hawaii and then 3 weeks in the Marshall Islands, if you wonder why we never got COVID. So it was really intense. It was like that for a long time, but we studied what you did the entire time, and that's when we slowly started dropping our quarantine days. And we used that information a lot. And I just want to say thanks to you, and I also wanted to say thanks to the Taiwanese government because they were so proactive with us. By the time COVID hit us just a couple months ago in August, we had already pre-supplied everything we needed. Everything was ready to go. We were really well organized. We had really good communication, and a lot of that was because the Palawan embassy just kept coming. I mean, the Taiwanese embassy just kept coming to us and saying, "What do you need?" Which was very unusual for a partner. And what we had done at the Marshall Islands, and I know we're a small country, and maybe you know a lot of people may not think we went through a lot of problems too, but we did. And one thing what we would do is when we saw some of the smaller countries around us have COVID, like Palau, we called Minister Ghaffar and we had a one-on-one call with them right in the middle of their outbreak. And we learned from them, protect your hospital. And I remember when Nauru had their outbreak, we noticed how well they were using Facebook and communicating information. So we used that. And so we spent a lot of time studying these things, and those kinds of statistics that you were providing, I just just want to say it probably saved a lot of lives in the Marshall Islands and maybe throughout Micronesia. So I just wanted to say thank you so much for that.
Well, thank you so much. That's extremely generous words, and I'll share that with the rest of our team. Maybe you could send me an email that, then I could just forward it to our group. But I will like to acknowledge, actually, I think there was for me as a Taiwanese American, a master class learning from Taiwan, watching every day Taiwan CDC on YouTube at 8 p.m. I would say I got all my COVID information from Taiwan CDC. And it was so much ahead of the curve that, you know, the US media was like a month late on everything. So in that sense, I want to thank the Taiwanese for showing that leadership, although it was all in Chinese. Fortunately, I do speak Chinese, so I could understand what was being communicated. And I would say that I hope someone will write a book about the Taiwanese lessons of communication, because that is an incredible case study about how to communicate as simply as possible in ways that increase trust and cooperation. I think was just the most amazing thing for myself as someone sitting in Hawaii. So yeah, thank you very much.
Thank you. The other question? Okay.
Yes, hello, Joseph Sulada from Executive Board of WHO in Slovakia. I really thank you, all the panelists, for excellent talks, and this is bringing me to some special issue that we use names for the diagnosis and for events in the medicine. But for example, in dementia, it is not only the biological diagnosis, but it is also social diagnosis of the family and surrounding area. So what would be your recommendation, how we can deal more effectively with using behavioral and cultural insights to address how to deal with the patient, with the family member with dementia? Because we know that just the education is not enough, and we have to have like contextualized tools very probably. So do you use some, and if yes, perhaps you can share with us with what outcome? Thank you.
I don't know if I understood your question correctly. If I'm wrong, just please tell me. I know that it's not, in terms of education, to improve a society or to change a society into a dementia-friendly one is not always enough. So we also have to offer some regulation or incentive, including that, because for some private sector, they will probably the government should provide some, maybe some financial support to those who will provide some employment to people living with dementia in their very early stage. Take that for an example. And also, we must remove all the restriction that we have already done bit by bit in some aspect of regulation or law issues, because you know that with some people with dementia do not like to wear face mask during the COVID. So we have some very strict regulation. If you pull down your face mask in certain period of time, in certain period of occasion, then you'll be fined a lot of money. But so if you can show that, oh, I'm sorry, I'm people living with dementia, then this can be waived. Also that, but this is not very easy. This is only for from the public sector. But still, many people walking on the street, they don't know if you are people living with dementia, then they will still criticize your care about removing your face mask. I think this is a very complicated one, but I agree with you that education is not enough. Thank you.
Yes, Professor Jimba.
Thank you very much for your presentation. The theme of plenary one is engage the public for health and well-being. So I tried to find something common among your presentation. And what I found was you were talking about engaging the public after a kind of fatal event happened. And I think it might be important to engage the public before such huge event happened. So do you have any idea about how to involve the public before such event happened, or during dairy event, or when dairy event happens, such as common cold or diarrhea, maybe for children particularly, instead of older people or middle-aged people? If you have any comment, please.
Well, thank you for the question. I mean, in terms of health systems, if a country has a very well-functioning primary healthcare system, then it is likely to involve people. I can give you an example from Australia, where we have a network of community-controlled health services for Aboriginal people. So Aboriginal people are on the board of the service, they're very much involved. And during the pandemic, they were very effective in protecting the Australians, Aboriginal Australians, who have the worst health status, a life expectancy of about 8 to 10 years less than other Australians. But that network of community-controlled health centres were really effective. And that's because people were involved in their health, whether it's a pandemic, whether it's non-communicable disease, whatever health issue. That issue of proper involvement is a very protective factor for a population. And I'm sure there are many other examples around the world, but that's one from Australia.
Maybe Ms. Das, you also want to respond to this question? Because you said that the next pandemic might look very different. So how can we be prepared way earlier before it happens? What, anything that we can do?
I think, as I mentioned, I just listened into the previous panel a little bit as well, and there was a lot of talk of health literacy, and I think that this is really an important factor to ensure, first of all, that people have a better status of health. I very much agree with needing to reach out to specific communities to empower them to achieve that, and to be very aware of all of the determinants which impact on this. Education, housing was a huge factor as well during the pandemic. Beyond health literacy, then you have a basis in which you can feed this information in an emergency, and people will be more receptive to it. And I think that is key. And as I said, not only for the general population, but also within the healthcare community, there is need for clear communication lines.
Thank you.
Thank you. Okay, any other questions?
Yes, here. Maybe one last question here.
I'm Professor Xiaoqi Wu from National Yangming Jiaotong University. I'm a great appreciate all your presentation, especially for the Secretary General. May I ask you a question? You mentioned about the disease prevention. Prevention is an asset, not a cost. Especially you mentioned about a strategy for a healthy recovery, including action on environmental health and mental health. Can you explain more about how to action on environmental health and mental health? Thank you.
Ms. Das, please.
now. Sorry, I couldn't unmute. This is something where really at European level we've seen a drastic escalation of a need for action, and this is not only in societies where there are many mental health problems, especially among younger people, among school-age children who have really had a very disrupted experience. And require support now, but also in the medical profession, we see extremely high rates of burnout, and in fact, for many years we've been discussing how to treat incidences of violence against doctors, and actually burnout has been added to the understanding of what violence constitutes. And this is linked to things like moral injury, really the system failures, which cause these very extreme working conditions, which then add to the burden of the workload that doctors have to then face. And we were pleased to see that now the European Commission has actually taken up mental health again after several years of not very much action to have a strategy. We also see at national level that national medical associations provide support, helplines, and other forms of support to doctors, for example, who are struggling with burnout and other types of mental ill health. But I think this will be a very important area in the years to come. And unfortunately, this is also one part of the healthcare system, which in most countries there is severe shortages of professionals to provide treatment, or facilities even for treatment.
Thank you. And because the time is limited, we have run up all we can. Okay, there is a simple question. The last one, Professor Bang.
In the screen in front of us, we've got a question from Slido, which is asking me, could I please talk about the digital healthcare inequity and how to build the capacity of civil society organizations to decrease it? Well, I just think that that's a really important point. If everything's on an app, I imagine for people with dementia that doesn't work well. And certainly in Australia, a lot of people can't afford a lot of download. So there's both access in terms of capacity, access in terms of cost. And it's not just in terms of access to healthcare, but access to a whole range of social determinants of health, such as getting housing or a job or making social contacts. So I think digital inequities is going to become even more important, and it already is.
Okay, thank you. I end this plenary, and thank you all of you for your participation. Thank you. Bye-bye.
Ladies and gentlemen, give our moderator and speakers here or online, Ms. Das, thank you so much for your participation. Thank you. Thank you. 谢谢我们的主持人以及讲者. You may return to your seats. Okay, ladies and gentlemen, that's it for day 1 of 2022 Global Health and Welfare Forum in Taiwan. We thank all the speakers for their wonderful, wonderful talks. Of course, we thank you here or online for your participation. And day 2 will begin at 10 a.m. Taipei time. We'll see you tomorrow. Thank you. Bye-bye. 再次谢谢各位贵宾今天的参与。我们明天早上10点见。拜拜。那也提醒，如果现场有借口译设备的贵宾，也请不要忘记归还了。谢谢。